recall of the INICET MDS November 2025 paper. We will be doing a recall of oral surgery questions and the one question of anesthesia, general anesthesia. Although it is taught as a separate subject here, but I will be taking the recall of general anesthesia also because there was only one question here. Oral surgery, there were 11 questions. So we will be doing a total recall of 12 questions in this session. So let's begin. Okay, the first question is, which of these is not an alternative strategy to enucleation to prevent recurrence in the management of odontogenic keratocyst? Okay, so the typical question is asking the strategy as an alternative to enucleation to prevent recurrence. Okay, I'm very happy that this question has come directly from our DBMCI MDS oral surgery notes. Whenever we have discussed OKC, we have discussed in detail how peripheral ostectomy should be used along with enucleation. It removes the bone along with the lining to remove the satellite cysts. How we can use chemical cauterization using Cornois solution. And in the last exam recall, we have also seen that 5-fluorouracil is also a drug which is used often. All right. So these are the three things we use to reduce recurrence in a case of OKC. And same were the options, 5-fluorouracil application. Now, some people keep it for 5 minutes, some people leave it for 24 hours. It's a surgical preference. So this is correct. Peripheral ostectomy with edges and mucosa and soft tissue removal, absolutely correct. One second. Okay. So option C is also correct. And option D, Cornois solution application 5 minutes after enucleation. So all these three are correct options. We know we are using it to remove all the daughter cysts. The wrong answer is iodoform gauze soaked strips in the wound after enucleation. Now we do use iodoform in the management of OKC, but we don't use it to prevent recurrence. There is a procedure which is called enucleation and open packing. We have seen this in our live class and recorded also, that sometimes when you have a very big OKC or when you have multiple OKCs with unerupted teeth and you want the teeth to erupt, in such cases, just to shrink the size of the cyst, a lot of times we do enucleation with open packing. When we do open packing, we pack the cystic cavity with a sterile material which is iodoform. It has no role in healing. It is just an antiseptic material which will prevent infection into the cystic cavity. All right. So it is not used for reduction of recurrence. And that is why it is the answer. B is the answer of choice. Okay. We have seen that if suppose this is a case which has large size OKC, we can fill it with iodoform gauze. Iodoform will look absolutely radio opaque on the X-ray. This is how the iodoform soaked gauze looks. And we've also seen a case of Gorlin-Gold syndrome where there were multiple OKCs in the mandible, in the maxilla, associated with unerupted teeth. How we have done an open packing with iodoform gauze, and it has also reduced the size of the cyst, and it has also allowed the eruption of teeth that were unerupted initially. After the size of the cyst shrinks, then you can enucleate. All right. So the correct answer is B. Coming to the second question. Now, this is a little extension of what we have read. This is where the question and paper is difficult. This is where it is INICET and AIMS. A 30-year-old male underwent en bloc resection of 4 centimeter size for a follicular ameloblastoma of mandible. 15 days later, he came with a fracture of mandible at the same site of surgery. Which of these is the cause and management options which hold true for this case scenario? Okay, now again from the notes, we have seen what is en bloc or marginal resection, what is segmental resection. Coming to en bloc resection, en bloc resection is one where you do not compromise the margin of the mandible, just a small block of infected or affected tumor tissue is removed. Okay, so suppose the tumor is very small and restricted to the superior margin of the mandible. In such cases, you don't have to sacrifice the whole mandible. You can just remove a block of mandible like that and do an en bloc resection. What is the advantage? The advantage is that you don't lose the continuity of mandible. It's a resection without any continuity defect. This much we have learned. Now, what the examiner is asking here is, in spite of an en bloc resection, there can still be a pathological fracture in the mandible. Okay, the patient has come to you 15 days later with a fracture. So this is of course a pathological fracture or a stress fracture. Okay, what is the cause? So the cause is, a lot of times, we have read about saucerization in osteomyelitis. We have read the word saucerization. What is saucerization? Saucerization means you give a saucer shape to the defect. Instead of a block 90-degree angle, you convert the edges into slightly curved ones like this. Instead of a block resection, you slightly turn the edges like this. What is the advantage? The stresses that come to the border of mandible when it is at 90 degree, they are very sharp forces. Whereas if the stresses are on a curved bony tissue, the stresses will be distributed nicely. The chances of fracture will be less. Okay. So similarly, when we are doing a resection, we try to make the shape of the residual bone into a saucerized shape. That helps in closure of the soft tissues also. There will be no sharp edges, so soft tissue closure is also easier, and it also prevents the stress accumulation at the 90-degree joint of the residual bone. And that is exactly what the options are. Again, it's a difficult question to ask because it's a very very clinical correlation of the things which you have not actually done. So it's a difficult question. Sharp edges with right angles of resection cause the fracture. Now this is absolutely correct, which is why we trim the edges to a saucerized shape. Residual mandibular height of less than 1 centimeter has caused the fracture. This happens. So if I'm a surgeon, I will always want, oh, some bone should be left with the patient. Let me not do a full resection. Let me save some bone. But honestly, when the residual bone height is very less, you can't save it because post-operatively the patient will come with a fracture. So when the residual mandibular height is very less, like just 1 centimeter, do not have the lalach of saving that bone. Let that bone go and give a good rigid recon plate or something like that to maintain the continuity. So option 2 is also correct, that residual mandibular height when it is very less. So if this height would have been just 1 centimeter, suppose the resection was like this, and residual mandibular height is only 1 centimeter. In that case also, it will not be able to take the large masticatory forces which come to the normal side of the mandible. Okay, so in that case also it will cause a fracture. So these two are correct. Coming to the third question, IMF for 2 weeks is enough for management. Now we all know IMF can never be used to treat a defect fracture. Now this is a defect fracture, a fracture within a defect or a pathological fracture. Whenever you have a defect fracture, you need a rigid internal fixation. You can't treat that with a IMF. So this is wrong. Free fibula is the only way of management now. Again, this is also wrong. You can simply put a good load bearing reconstruction plate and you can manage the case. Okay, you can just put a recon plate. No need that, okay, only free fibula is the case. No, you can put a reconstruction plate. After that, if you want to rehabilitate the area, then you can go for two types of graft. You can go for a non-vascular graft, okay, or a vascular graft. Non-vascular grafts like the iliac crest or the rib, depending on the size and vascularity of the region. And vascular grafts like a radial forearm flap or the free fibula depending on a lot of things. So there are various reconstruction options, both vascular and non-vascular. So saying that free fibula is the only way of management is wrong. All right. So only 1 and 2 are correct. 3 and 4 will be wrong. So answer is option A. Yes, that was one of the options, that only first and second are correct, and that's the correct answer. All right. Coming to the next question. Which of these local anesthesia techniques is preferred in hemophiliacs? Now, this is a very, very old repeat question. Maybe when probably I was preparing for my NEET, that time this question used to come, because honestly, practically speaking, it's useless. In hemophiliacs, you can very easily give an infiltration and do the procedure. Okay. The correct answer, according to textbook, is PDL injection or the intraligamentary injection. I'm sure all of you have marked it correctly, because in all the books this question is repeated. Practically speaking, in hemophiliacs you can just give an infiltration and that will also solve the purpose. Okay, you avoid giving any blocks like field block or nerve block or even a supraperiosteal injection, because you don't want the patient to bleed. All these blocks are associated with the neurovascular bundle. So while blocking the nerve, there is a chance you injure the vasculature of the tissue and you cause a bleed. And that can be a problem in the hemophiliacs. So according to the textbook, the correct answer is intraligamentary. I have taken a screenshot of the famous book of local anesthesia called Malamide, which says that the primary indications for PDL injection include when only one or two teeth need anesthesia, or treatment of isolated teeth in different quadrants, because if you have to do here also you'll have to do a bilateral I and B. That is not required, just few teeth here, few teeth here, you can give PDL block there. Or in children where there will be a lot of soft tissue paresthesia after the injection, so they will bite their lips and all, in that cases you can give PDL injection. Or treatment in which the nerve block anesthesia is contraindicated, example hemophiliacs. It's a direct pick from the textbook. So practically speaking you can give infiltration, but theoretically speaking, yes, you can use the intraligamentary injection. Okay, question number 4, again this was also a straightforward question. Which of these instrument causes maximum amplification of forces during extraction? So we all know that whenever we are using the elevator, again this is very nicely given in the DBMCI MDS notes, we talk about the mechanical advantage. So whenever we use any lever, okay, or any other principle like wheel and axle, or even when we wedge an elevator, there is an advantage to which we work. So if I'm giving X amount of force, if I'm using a crossbar elevator, the amplification will be 4.6x, which is why we avoid using a crossbar elevator in the maxilla, because it will give so much forces and the maxilla is a porous bone, right? So out of all these instruments, periosteal, apexo, crossbar and crier, the maximum amplification of force due to the T-bar handle is with a crossbar elevator. Crier also can be used in a wedge and wheel and axle principle, but the amplification of forces would be maximum with a crossbar elevator. Okay, so that's the correct answer. Question number 5, again a very, very straightforward question. A patient underwent syncope during extraction of multiple teeth. Which of these would be the correct sequence of steps for management? Option A, aromatic ammonia inhalation. Yes, it's a respiratory stimulant. You can give that. Give more LA for pain control. I don't think that's a right thing to do. Complete the procedure. The patient has just recovered from a semi unconscious state. I don't think he will allow you to complete the procedure. Give the patient a fruity drink in post op. Yes, that is okay. You can ask the patient to take something, but that is usually done in hypoglycemics where the sugar is low. All right. So option A does not look to be a perfectly correct option. Option B, giving NSAIDs. Now, whenever we are talking about giving NSAIDs or giving injection of diclofenac, that means we are trying to manage pain. And syncope is not always due to pain. The most common cause of syncope is fear and anxiety. All right. NSAIDs and diclofenac will never control anxiety in a patient or fear in a patient, right? If instead of diclofenac it would have been, some alprazolam or some some drug which is a little bit of sedative before the procedure or one night before procedure, that would have been okay. That would have been a prophylactic thing to do before syncope. But NSAIDs or diclofenac or even fluids or injection glucagon, check blood glucose level, this is all not really directed towards management of syncope. Okay, syncope, what is syncope? It's a transient vasovagal reaction. Okay, because of fear and anxiety, the vagus nerve is stimulated, which causes peripheral vasodilatation, causes pooling of blood in the peripheries, blood pressure drops, and the patient becomes unconscious. All you have to do is allow the blood which is in the peripheries to come back to the heart. Okay, the venous return should increase. How will you do that? Simply make the patient lie down with the leg raised. Okay, it's a Trendelenburg position with the leg raised position. Just monitor the vitals, just ensure that the blood pressure is picking up, the pulse is becoming more palpable, and definitely defer the procedure for this time. Okay, so you do not complete the procedure, just defer the procedure. Okay, again, it's a direct pick from the DBMCI MDS notes. What is syncope? Vasovagal loss of consciousness. It is transient. Position supine with leg up. So initially the books used to use the word Trendelenburg. Okay, so in Trendelenburg the head is low and the legs are up. The current books say that you don't need to take the head low. Head can be straight. Just take the legs up. So it's a supine with leg up position, which is a better answer. Improve the venous return. Yes, you can use aromatic stimulation by the spirit of ammonia, which is a very, very bad stringent odor, and that it acts as a respiratory stimulant. It's more common in males, more common in hot and humid seasons. All right. So this is all about syncope. Okay. Next question. A 60-year-old diabetic patient on warfarin therapy has an INR of 3 and needs extraction of an infected third molar. What would be the safe next step? Okay. Here the examiner has checked whether you know one fact or not. Okay. The correct answer to this question is proceed with normal extraction. Direct pick from our notes where I have taken everything about the medical history of the patient. If a patient is taking blood thinners, okay, those blood thinners can be either antiplatelet drugs like aspirin, clopidogrel, or they can be anticoagulants like warfarin, Noax, or heparin. Okay, so the question is asking warfarin. Patients who need minor surgery, check PT INR. INR less than 3.5, proceed with surgery. INR more than 3.5 or those undergoing major surgery, then you have to go for a bridging therapy. Okay, simple fact, if you have read your notes properly, clearly mentioned that bridging is not required when the INR is less than 3.5, when the patient is undergoing a minor surgery. Okay, so again, coming back to the question, he needs extraction of a infected third molar, and INR is 3. So you do not need to reverse anticoagulation. You do not need vitamin K injection. You do not need general anesthesia. All you need is just go with the normal extraction. Maximum what you can do, you can put some sutures to make sure that he doesn't bleed postoperatively. That's it. The answer is proceed with normal extraction. Okay. Another important thing to uh, understand in this question is the examiner has told you that it's a diabetic patient and the tooth is infected. Why has he given these two facts in the question? So we know that diabetic patients are immunocompromised. Okay, their healing ability, their WBC function, everything is compromised in a diabetic patient. Okay, plus the third molar is infected already. So in any patient where there is a focus of infection and the patient has an immunocompromise, the chances of spread of infection is very, very fast. So we don't want to postpone the extraction in such patients. We don't want to linger on the infection for a long time. As soon as possible, We want to remove the focus of infection so that in this immunocompromised patient, it doesn't spread and become a space infection. Okay, that infected third molar can very easily become a pterygomandibular space infection or become a lateral mandibular, retromandibular space infection, which becomes a major complicated procedure, which becomes a complication of this third molar. So we don't want that. So that reason, that is also another reason you want to quickly get rid of the focus of infection, which is the infected tooth. All right. So for that, any postponement of surgery is not advisable. Okay. So the best answer to this question is proceed with normal extraction. You don't need to do any bridging, no nothing. Okay. Next question, again straightforward. A tooth which is not erupted due to a physical barrier to eruption is called an impacted tooth. Okay, that's a definition of an impacted tooth. A tooth which has failed to erupt into its correct occlusal position by the time it is expected to erupt. Okay, not expected to erupt any further. Okay, in a 13-year-old child, I cannot call a third molar impacted because 13 year is not the age of eruption. It is called an unerupted tooth. Okay, but in a 25 or a 30-year-old child person, it will be impacted. Okay, so a tooth that has failed to erupt within its time frame can be either retained or impacted. The difference is retained tooth has no physical obstruction. Okay, whereas impacted tooth denotes a physical obstruction such as an adjacent tooth, a bone, or a soft tissue. It can be bony impaction, it can be soft tissue impaction. Okay, straightforward question, definition of impacted tooth. Okay, another question which was tricky, which was difficult, which was not of the graduate level. In bilateral sagittal split osteotomy, we often use bicortical positional screws for fixation. Which of these is the correct principle of positional screw? Now, the correct answer is it is a semi-rigid fixation. I am not saying that it's easy, but if you have read the trauma and the orthognathic notes properly, most of you will be able to come to this answer. I will tell you how. So, in the notes, when we are teaching you orthognathic surgery with images, we have taught you how after BSSO you can do the fixation either with three positional screws on either side. Okay, they can be in a straight fashion or they can be in a triangular fashion. Or instead of positional screws, you can use mini plates. Okay, that is there. Three positional screws, long screws, hold the proximal distal segment together, pass through all the four cortices. Okay, mini plates should have 2 to 3 screws on both sides of the osteotomy. It's a monocortical fixation. So we have given you the details of how the screws should be placed and what kind of fixation it gives. So with this much detail from the notes, you will be able to rule out that single screw fixation is enough. This is a wrong answer because at least 3 screws we could see. Okay. Now, option A and option D, how will you rule out? If you look at the notes of trauma, okay, we have discussed, what kind of fixation is mini plate, what kind of fixation is lag screw. Okay, so lag screws are not the same as positional screws. Lag screws cause a special kind of an effect called compression, which positional screws do not. Okay, just like compression plates, lag screws also cause compression. And that's the speciality about lag screws. You can't use lag screws anywhere. There's a specific indication of using lag screws. Okay. So if we come back to the question, saying that positional screw is the same as lag screw, no, it is not the same as lag screw. And it causes compression osteogenesis, no, only lag screw can cause compression osteogenesis. Okay. Lag screw and compression plates. These are the only two things that can cause compression osteogenesis. So, what this question is teaching us actually is you can also answer a question by elimination. You can answer a question by elimination. If you know the fact that lag screw causes compression, you will be able to rule out option A and option D. All right. If this image of the notes is there in your mind, you will be able to rule out option C. And then you will know that it is a semi-rigid fixation. See, three screws. Three screws cannot be a rigid fixation unless you're putting a big, thick plate. All right. So it's difficult, it's tough, it's unfair to ask you in the exam. But if you just understand the concepts and if you learn to answer by elimination, even such questions you can make correct. All right. Okay. Next question, direct pick from the notes. What is the rationale for VY plasty done in case of Lefort 1 advancement? Examiner has tried to confuse you by giving option A and B. Okay. Option C, that's useless. To prevent nasal widening, it is LR cinch suture and not the viviplasty, which we do for nasal widening. Now, option is for increasing thickness of upper lip to make it look fuller or to prevent shortening of upper lip. The correct answer is B. It will not increase the thickness or the fullness. It will just prevent the shortening. Okay. Again, we have seen it in our notes. I'm just taking a screenshot of our orthodontic surgery notes where we have explained VY plasty in detail. Instead of a single incision like this, which looks like a V, what we do is we give an additional vertical incision like this. So the inverted V looks like an inverted Y. And this is known as VY plasty. Okay. Upper lip thinning. Advancement of maxilla causes rolling of upper lip. To prevent that, we do a VY closure. It increases the tissue length, prevents the thinning of upper lip. Direct pick question. If you have answered it, very good. If you have not answered it, in future, whenever this question comes, you should know that it is to prevent the shortening of upper lip. Okay. All right. Next question again. Now this the repeat part of this question is, which of these osteotomies would risk damage to the descending palatine artery in Lefort 1 surgery? Till now, the question that was asked is, which is also there in our notes, is which vessel is compromised and which vessel is the residual vessel that supplies the blood supply to the osteotomized maxilla. Okay, so we know three vessels: descending palatine artery, ascending palatine artery, and ascending pharyngeal artery. After we have cut the maxilla, these are the three vessels which provide blood supply to the mobile segment of maxilla. Now, the examiner has gone one step forward. He has asked you that if you do one osteotomy wrong, you can damage this vessel. The answer is C. Sorry. Lateral to the pyriform fossa. It's not a direct from the notes, but we have taught you Lefort 1 surgery. In Lefort 1 surgery, first we do a straight horizontal cut in the maxilla. Then we do three special cuts. One is lateral nasal wall osteotomy with a special lateral nasal wall chisel. Second is septal osteotomy with a septal chisel. And third is pterygomaxillary disjunction with a pterygoid chisel. Out of these three, if this first osteotomy, the lateral nasal osteotomy, is done very deep, it can damage the descending palatine artery. Just excuse me. Sorry, some bad cough going on. So the correct answer is the osteotomy, which is if done lateral to the pyriform fossa, it will cause damage to descending palatine artery. So this finishes our oral surgery recall. One last question, no, one more question. Rotation around the vertical axis is known as. The correct answer here is yaw. Okay, we all know that, again, straightforward from the notes. There are three axes, which your all are three kinds of movements that we do. If the axis is transverse like this, along this axis, if we are moving the maxilla up and down, so this is the axis, which is the transverse axis. On this axis, if we are doing up and down, The movement is called pitch. Okay. So the axis is transverse, the movement is up and down. Okay. Second is yaw. The axis is vertical and the movement. So this is the maxilla, this is the axis. So axis is straight, vertical axis. Maxilla is going left and right like this. So midline corrections of the maxilla. Suppose the midline of upper and lower is not matching. You have to move the maxilla left, right. So this is the axis, the vertical axis. And moving the maxilla left to right is known as yaw. And this is what is asked in the exam. And the third is roll. Roll is when you are tilting the maxilla up and down. So if you are taking a sagittal axis like this, antero-posterior axis, this is the axis. On this axis, your maxilla is tilting left and right like this. For cant corrections, for slant corrections of maxilla, that is known as roll correction. Okay. So the question is asking about the vertical axis, and the answer is yaw. And the last question, which is a question of general anesthesia, which I will be taking here, is a 38-year-old boy is brought to the emergency department after a road traffic accident with bilateral mandibular fractures, severe facial swelling, active oral bleeding, saturation is dropping. Okay. Which is the best first emergency airway to be established? The only important thing in this question is this. As a general rule, whenever there is an emergency, any emergency, the best airway is always orotracheal. Any situation, except when the patient is unable to open the mouth. Like cases of ankylosis, cases of trismus, cases of OSMF. In any situation, if the patient is not able to open the mouth, then your emergency airway will become the surgical airway. Other than that, all these bilateral mandibular fracture, facial swelling, active bleeding, this is only distracting facts. This is only disturbing you. This is kind of trying to say that, oh, oral bleed, how can you put an airway? Why can't? What is the problem? Just remember, any emergency situation, the best airway, definitive airway is always orotracheal intubation. That's a rule. All right. Let us look at the options quickly. Nasotracheal intubation under sedation. So, a patient whose saturation is dropping, how can you sedate that patient? You cannot sedate a patient whose saturation is dropping. What if you are not able to get the airway? You sedated the patient, right? So, and nasotracheal intubation for some extent is blind till it reaches from the nasal cavity to the oropharynx, from the nasopharynx to the oropharynx. Till that time, it is blind. And a patient who has severe facial swelling can also have mid-face fractures. And mid-face fractures may have a skull-base fracture. And in skull-base fracture, nasotracheal intubation is avoided. So, you will not do a nasotracheal here. Bag mask ventilation with a pharyngeal airway. Again, this is not a definitive airway. Any airway which is above the larynx, which is above the glottis, is a non-definitive airway. It is a useless airway. Why? Half of the air will go into the trachea, half will be wasted into the esophagus because there are two pipes, windpipe and food pipe. If you are above the level of hypopharynx, if you are above the level of glottis, air will be wasted. So it's not a definitive airway. B is wrong. Surgical intubation only done if oral fails. Otherwise, it is not done. Right? So the correct answer here is D. Sorry. Orotracheal intubation. Okay. With this, we finish the recall of oral surgery and anesthesia. If you still have any doubts, you can connect with me in the DBMCI MDS Premier group. All right. Good day, everyone.
हाँ 2 सेकेंड ना तो फोन्स को कनेक्ट करने के लिए नहीं
Hello, students. Am I audible? Just please say hi and audible in the comment section if I am audible or not, please. Am I audible, guys? Okay. So first, tell me, how was the periodontics paper overall for you all in the comment section? Let me know how was your paper and what were the difficulties you faced in the questions. Most of the questions in perio were repeat questions. Approximately 8 questions we have recalled. And just give your views, opinions that how was the overall paper and how was the perio paper per se. Let me know in the comment section, guys. How was the paper? Most of the questions in perio were repeat questions. The topics were repeat. Even the questions were same, and they were repeat from last 1 or 2 years papers only, right? Okay, so the paper overall, Haru is saying was difficult, I think, right? It was moderately difficult or difficult paper. But in Perio, how was, as we will go through the session, you will know that in Perio, the questions were from the repeat topics, except I think one question which was on bone graft. That was also a repeat topic, but slightly tricky. So I'll not call the paper a very difficult one in from Perio perspective. It was medium difficult paper from Perio perspective, right? Perio was comparatively easy, right? and approximately 8 to 9 questions which we will be discussing here. You will see that yes, we have discussed those papers in our recorded sessions, in our live sessions, in our PYQ sessions also we have discussed those questions. And also guys, if you feel this is a recall session, right? We have recalled the questions, we have asked our students and our team members to frame the questions as well as the options. And if you feel that if the option, some option is incorrect or some other question was there instead of what we are saying, you can let us know in the comment section. We will be very grateful to you all to know what what other way the question was asked. Okay. I think last section was the only difficult one. First three were good. PhD wala was, yes, I heard that PhD was a many questions were approximately 20 questions were there from PhD and it was slightly difficult. PhD mostly applied based questions were asked in PhD, but that part Dr. Garima will take. So guys, let us start the discussion first. The first question is, which host modulating agent inhibits collagen degradation and bone resorption? Which host modulating agent inhibits collagen degradation and bone resorption? This topic we have discussed very nicely in our live sessions. This is from the chapter host response and host modulation therapy, right? Host modulation therapy. This is a we have discussed all the concepts of host modulation in our classes. So the options, let us read the option. And if you feel some other option was there, please let me know in the comment section. Option number A is ibuprofen. Option number B is chemically modified tetracycline. Option number C is minocycline. And option number D is doxycycline. Now you might feel that in host modulation, basically tetracyclines are used, right? So all three, CMT, minocycline and doxycycline are tetracyclines, right guys? But remember that in host modulation, the dosage which is used of these drugs is different, right? So specifically, the host modulating agent, which is used for inhibition or down regulation of collagen degradation and bone resorption, two types of tetracyclines which are used are SDD, sub-antimicrobial dosage of doxycycline, and CMTs, right? SDD and CMT. These two are used. So minocycline and doxycycline, though they are tetracyclines, they are not a host modulating agent. In this question, what is the host modulating agent? Chemically modified tetracyclines. So the answer to this question is CMT, right? This is a repeat question from a repeat topic. Okay. Now, in this only another, we will discuss the second question. The second question is also from host modulation. Okay, so Lakhi Bora is saying that metronidazole was also there. So guys, if metronidazole was also there in the options, still the answer will be if metronidazole was also there in the option, still the answer will be CMT. Okay, still the answer will be CMT. Okay, now the next question. Sub-antimicrobial dose of doxycycline. Sub-antimicrobial dose of doxycycline means SDD. What is the sub-antimicrobial dose? Options are option number A, 20 milligrams. Option number B, 50 milligrams. Option number C, 100 milligrams. Option number D, 150 milligrams. So a single dose, what is the dosage? Actual dosage of SDD is, it is 20 milligrams of SDD given twice daily, okay? Twice daily for 3 months. And this we can continue for 9 months. This we can continue for 9 months, right? So the total dose of doxycycline in reality is 40 milligrams. But as they have not given 40 milligrams in the option, as they have not given 40 milligrams in the option, the answer here will be 20 milligrams. The answer here will be 20 milligrams. And this same question, guys, this same question is there in our question bank, in DBMCI question bank. I have shared the, I have linked the screenshot of the question bank, PYQ question bank of DBMCI, and it is a repeat question, same repeat question with the same options. Even the options are same, guys. Even the options are same here, and it is a repeat question of July 2021. Okay, this is a repeat question of July 2021. So, as basically, host modulating agents are very important topics which we have to study, and it is important for both, guys, for INI as well as for NEET. Okay, now the next question. See, a similar question. I have in AIMS May 2017 also a similar question was asked. Actually, these questions are asked many a times. But see here, they have given 40 milligrams, right? Here they have given 40 milligrams in the options. So that is the correct option to choose. If 40 and 20 both are given in the options, you have to go with 40 mg. Because 20 mg is the single time dosage. But if 40 mg is not given, then the answer will automatically be 20 mg. Okay, it's clear? Let us go to the next question. Again, a repeat question. Every year in INI, I will say every 6 months they are asking this question, and even the diagram they are not changing. The image they are not changing. The same image they are giving again and again and again, right? This is a repeat question, a frequently repeated question, right? So yes, Lucky Bora, if 40 mg is there in the options for STD, 40 mg will have more weightage compared to 20 mg. Okay, 40 milligrams, if it is there in the option, then 40 mg will be more than 20 mg. Okay. Now, IBQ to identify bone destruction pattern. Here they have asked on the right side and on the left side. Now this is the right side, this is the left side, right? This is the right side. Okay, this is the right side, this is the left side. So what is this? What is fenestration? What is dehiscence? Dehiscence means the marginal bone is lost. The marginal bone is lost. So that is dehiscence. Fenestration means the marginal bone is intact. It is a sieve light defect. It is a whole light defect, right? So on the right side, it is dehiscence. On the left side, it is fenestration. On the right side, it is dehiscence. On the left side, it is fenestration. So the answer to this question is answer number B. Okay. What's written? Fenestration. Yes, fenestration and dehiscence is their favorite question. See, this was asked in AIMS November 2016, in INI May 2025, in INI November 2020, and before that in INI 2024 also it was asked, and the same question, the same image they have asked, this is there in our PYQs, right? It is there in our question bank, guys. Okay. Now the next question. This is also a repeat question. Again, which of the following is a surgical curette? Which of the following is a surgical curette? Options here are option number A, Gracie curette. Option number B, Pritchard curette. Option number C is Barnhart curette. And option number D is Columbia. Now, guys, Gracie curette is a area specific curette, and it is not a surgical curette. It is a curette which is used for root planing and curettage, right? It is an area specific curette. It is an this is an area specific curette, and this is used for root planing and soft tissue curettage. Soft tissue curettage. What is the difference between a Pritchard curette, Gracie, Barnhart, and Columbia curette? Basically, guys, in any surgical curette, it is a heavy instrument. The tip of that instrument is a heavy instrument because it is used for removing the thick granulation tissue which is there inside the flap. It will have a thick working end. Okay, it will have a thick working end. While Gracie curate, Barnhart curate, and Columbia curates, these three are very delicate instruments. They are very fine instruments. They have to go deeper. They have to go deeper in inaccessible areas, and from there they are used for cleaning of granulation tissue. Okay. So Gracie curate is an area-specific curate. Now, Barnhart and Columbia curate. These two are universal curates. These two are universal curates. While Pritchard is a surgical curate. So this is the answer here. Okay. Pritchard curate is the answer here. This question was also repeated in AIMS November 2019 and INI November 2024. Same question. Again, this is a screenshot from our question bank. See which same question, right? No difference. Which of these is a surgical curate? Same question. Okay. Now the next question. Again, a very commonly asked question, right? The main mineral constituent of calculus is option number A, hydroxyapatite. Option number B is brushite. Option number C is magnesium bichlocide, and option number D is octacalcium phosphate. Now, hydroxyapatite, we all know that what is the correct answer here? It is hydroxyapatite. The concentration, the amount of hydroxyapatite crystals in dental calculus is 51%. It is 50 to 51%, right? The concentration of octacalcium phosphate is 12%, magnesium bichlocide is 21%, and brushite is 9%, right? Sorry, guys, it is 20. Octacalcium phosphate is 21%, and magnesium bichlocide is 12%. Okay, so this is how the concentration of dental calculus is there. So the highest, the main mineral content of dental calculus is hydroxyapatite. It is equal in both supragingival calculus and subgingival calculus. The highest amount is of hydroxyapatite only. This is again a repeat question from INI July 2021. This is the screenshot of our question bank. This is the ID. So you can see how the questions are repeated. Now, antibiotic, the next question is antibiotic prophylaxis. Antibiotic prophylaxis before scaling and root planing in cardiac patients is done to prevent. This again is a repeat question, though it is not repeated in last 5 years, but this is a repeat question of, I think, approx 2015, 2016. This is there in the question bank, but right now I was not able to find it. So guys, so the options here, this has been asked previously, right? This is also a repeat question. Option number A is infective endocarditis. Option number B is rheumatic heart disease. Option number C is bacteremia-induced sepsis. And option number D is myocardial infarction. Antibiotic prophylaxis. Antibiotic prophylaxis is done why? It is done to prevent sepsis, right? Whenever we do scaling, what is there? There are chances that the bacteria from the bloodstream, they can go from the blood vessels into the heart of the cardiac tissues of the patient. And mostly the patients who have underwent valve replacement or any cardiac surgery, they are at a higher risk of developing infective endocarditis, infection of endocardium, infection of heart, right? So the answer here is option number A, infective endocarditis. Okay, guys? Any doubt? Anything you want to tell me up till here, whatever we have discussed? I hope it makes sense. And I hope the questions and the options were mostly similar to like this. Any suggestions you would like to give me in the comment section? Just write it down, guys. Okay. Now the next question. So here the option, I got two options. So just I have written both of them. Let me know which one of them is correct. Option. Let us first read the question. The question is, which of these are characteristic of NUG? Which of these are characteristic of NUG? Options are, option number A has, most of the students said it was written has a constant duration. NUG does not have a constant duration, guys. Okay. Option number A is has a constant duration. Option number B is commonly seen in children. Option number C is acute infection leads to some degree of immunity. And option number D is it is contagious or contagion is present. Now, guys, see, if option number A was like there is no constant duration, it has no constant duration. If in the options this was there, then the answer will be A. But if this was there in the option was has constant duration, then remember NUC does not have constant duration. Option number B is also not correct. It is not seen commonly in children. What is seen commonly in children? Acute herpetic gingivostomatitis. That is the difference, right? NUC is commonly seen in adult patients. It is seen in patients who have some kind of psychiatric disease, who have psychiatric problems, or in patients who are not able to maintain oral health, or in patients of low socioeconomic status, right? So it is commonly not seen in children. So B is also not correct. Option number C, acute infection leads to some degree of immunity. Now here the keyword which is important to remember is they have written some degree of immunity. So guys, remember that NUG, I will not say complete immunity is there. If once you are affected with NUG, you will again be not affected with NUG. It's not like that, okay? But it has been seen in certain researches that some degree of immunity patients develop against NUG if they are infected with NUG once. Okay. So if the options were like this, has a constant duration instead of this, then the answer will be C. It is contagion. No, it is not contagious. This also we have studied in the differences, right? So the answer here will be C. But if this was there in the options, then always A is greater than C. The answer will be A. Okay. Yes, if no constant was given, Raftar, then the answer will be A. Okay, understood? I hope this is clear. Any doubts, guys, you have in this? Any doubts? This is clear, I hope. Okay. And if you feel any other option was there, just let me know. Now, the next question. What is the connection of soft tissue to implant? What is the connection of soft tissue to implant? Again, a repeat question. Every year now they have started asking this question since last 2 to 3 times. This is the fourth time they have asked this question. And this also we have discussed in our classes, right? So options here are hemidesmosome. Option number B is desmosomes. Option number C is hemidesmosomes and basal lamina. And option number D is desmosome and basal lamina. The answer here will be hemidesmosomes and basal lamina. Again, I have written here, it was asked in INI May 2025, 2024, and previously also one time it was asked. Okay, so this is a repeat question. This we have is explained very nicely in our question bank, guys. Okay, now the last question. So there were 9 questions from Perio. Amongst the following, which graft is non-resorbable? I will say that this was the only slightly difficult question, not difficult, but yes, medium difficult question in Perio, which was asked. And I have formulated a table. You can take a screenshot of that table, and it will be helpful for you all to remember the graphs and everything in a sequential manner. Okay, so I'll just read out the options. I'll tell you the table, and then I'll tell you the answer. Okay, so the options here are Among the following, which graft is non-resorbable? Options are option number A, compacted hydroxyapatite. Option number B was beta-2 tricalcium phosphate. Option number C was demineralized bone. And option number D was hydroxyapatite with collagen fibers. No, Roche 87756, it is not contagious. Okay. So which amongst the following graft is non-resorbable? Compacted hydroxyapatite, beta-2 tricalcium phosphate, demineralized bone, and hydroxyapatite with collagen fibers. So this is the table which I need to discuss with you all. So here I have written the what are the different types of grafts which we study in perio. The examples of every graft is written. Then what is the source, whether it is taken from the individual or from a cadaver or from the same individual or some animal or an exogenous source like synthetic grafts, right? And the potential, whether it is osteogenic, osteoinductive, osteoconductive, the resorption rate, and the these remarks are not useful for us. This I have taken from somewhere, right? So autograft, the examples are iliac crest graft, mandibular. Autograft means taken from the same individual. It is osteogenic, osteoconductive, osteoinductive. Okay, and it is resorbed in the bone. Now allograft. Allograft is DFDBA, okay, it is DFDBA. Allograft, DFDBA and allograft FDBA. They are taken from the cadavers and they don't have osteogenic potentials. They have osteoinductive property. DFDBA has osteoinductive properties because it is demineralized and the BMPs which is present into the bone get exposed and they help the surrounding bone to induce bone formation, right? So DFDBA has osteoinductive while FDBA is just osteoconductive. Okay. Now xenograph. Xenografts are derived from an animal source, bovine derived. They are derived from different species and they are also osteoconductive. They stimulate the bone. Their resorption rate is very slow. See, all of these can be resorbed into the natural bone. Moderately resorbable, moderate to fast resorbable, slow resorbable, very slow resorbable. Allograft acts as mainly as a scaffold. Okay. Now there are alloplastic grafts. Alloplastic grafts are taken from another they are made from the outside sources. They are mostly, the example is beta tricalcium phosphate. It is synthetic and it is fully resorbed in 6 to 8 months. Most of you might be thinking that the answer here will be beta tricalcium phosphate, but guys, it is not the answer here. Alloplastic non-resorbable is compacted hydroxyapatite. Okay, it is acting as a long-term space maintainer and it is non-resorbable. So the answer here will be hydroxyapatite compacted. Okay, so I hope you all have taken the screenshot of this. This is very helpful. This table will be very helpful for you all. The answer here will be A, compacted hydroxyapatite. Okay, guys. So any other doubt you have, anything you need to ask here, just let me know. Anything else, any comments you would like to give, any change in question or options you feel, just let me know in the comment section. Okay, guys. So all the best and just stay focused and keep studying. Okay. All the best, guys.
So, hello and good afternoon, everyone. I am Dr. Ruchi Raj. I am your prosthodontic mentor at DBMCI, and I welcome you to the recall session of INICET questions pertaining to the subject of prostho. It is almost 24 hours only since the exam has been over and out, and here we are with the complete set of questions that were asked in the exam. It took a whole lot of effort, and I welcome all of you to this session today afternoon. First and foremost, how was the exam? How was prostho to all of you? Very good afternoon, everyone. How was prostho? How was the exam for all of you? I hope the screen is visible. It's your INICET November recall session pertaining to prostho. And I welcome all of you in today's class. So let's keep the session interactive. Hello and good afternoon. Yes, Lucky Bora. Hello and good afternoon. And how was the exam, first of all, for all of you? Was it easy, moderate, tough? And overall, how was the paper? How was everything pertaining to prostho? Now, yesterday I asked a couple of students while arranging the questions and recalling the questions, and the response what I got from majority of them was that prostho felt moderate to them. In total, we have 21 questions from Prosto, about 7 IBQs from Prosto. That's a good number of questions. It is a very important subject for the exam point of view, whether it is INI-CT or NEET. But INI, as I think Dr. Imani also mentioned, focuses main on these clinical core subjects. So it is understandable that 20-25 questions can come from Prosto. Now, I just keep the link open. And yes, all of you are saying it was moderate. Now, what I could figure out and got as response is that a lot of students said topics were the same, what we have learned in class. About, I think in September, we had our live class. So topics were the same, what we had taught in class and everything, but the options seemed confusing. And that is classic INI-CET, where topics will be the same topics. Your Facebook has come, vertical dimension. You can go down and check. On Instagram, we have a list of most important topics. You have vertical dimension, you have your indirect retainers, you have your Facebook as a topic. But then what comes out of it, the options or the language will be changed in a manner that you will be confused and you may tend to make mistakes. Of course, 1 or 2, 3 new questions will come, which will be new for everyone. That comes in every INI exam. But apart from that, overall, I would say it is a moderate paper, right? Repeats were there. Yes, a lot of students are saying. So without wasting any time, let us start with question number 1. Decreased vertical height in anterior floor of mouth is due to. It is asking a question pertaining to your border molding, where if you get a lesser flange height in anterior floor of the mouth, that is in your mandible, it is either due to proximity to sublingual gland, or it is due to lingual frenum movement, it is due to mylohyoid ridge or buccal frenal area region. Yes. So let me know what you have marked, and I'll put in my correct answer in the screen over here also. So the correct answer for decreased vertical height in anterior floor of mouth is primarily due to lingual frenum's movement. Due to the lingual frenum movement and how the lingual frenum will, whether it is hyperactive, how it moves, that will guide primarily the height of sulcus that you get here in the floor of the mouth. Now let us look at other 3 options. Proximity to sublingual gland here. When your proximity to sublingual gland, yes, it does affect, but it may affect the contour of the flange, not the height of the flange. It will affect the contour of the flange. Mylohyoid ridge, it affects the posterior part, not the anterior part. And frenum, buccal frenum, as it suggests from here only, it is on the buccal side. It is not on the lingual side, it is on the buccal side. So then there's no scope of buccal frenum affecting it. So the correct answer, pretty easy question, decrease in vertical height. That means when you get a lesser flange height, then your answer is the lingual frenal movement. I think students have marked this only. So all the students, you can keep putting your answers in the chat box. Let us see what you have marked, where majority of you have committed your mistakes, right? Now, let us come to question number 2. As always, at any point, if you have a doubt, please put it in the chat. I have the chat open in front of me. I'll answer your doubts. Question 2. Increase in vertical dimension of occlusion can be achieved by. Here, during the rehabilitative steps, if you want to increase the video or restore the video, what can you do? By posterior contacts only, by increasing the posterior cusp height, by alteration of condylar guidance, or by contact of anterior teeth in centric relation. Now, here there is a slight controversy. Why? When they have asked you want to increase the vertical dimension of occlusion, or rather the correct word should be restoring the correct vertical dimension of occlusion for a patient. And most likely this is considering a case of FMR. How can you achieve it? Let's tackle one by one options. By posterior contacts only? No. You can do it by anterior contact also, right? Not just by posterior contact, you can do it by anterior contact also. So that may alone not be the answer. Increasing the posterior cusp height, see, yes, there is a treatment modality where we add composite on the posterior cusp height of teeth that are completely flattened, and we do that, and then we restore it to the correct video, and we can do a trial run like this. So yes, you can do by increasing the posterior cusp height, but if you do it only on a few teeth, it can cause interference. Can we alter condylar guidance? No. So let me cancel this option. This is absolutely wrong. It is an anatomical modality. We cannot alter condylar guidance. And contact of anterior teeth in centric relation. If in centric, anterior teeth are in contact, then you cannot alter the vertical dimension, because your posteriors also at that point of time cannot or do not have that space in between to take up that alteration, change, or increase in height. However, if the option was by correction of anterior teeth, that could be a probable answer. The gist of all of this is you can increase or restore vertical dimension by correcting posterior and anterior teeth both. Generally, it is done by posterior teeth by adding cuspal height. Now, let us come to the answer. I have selected correct answer as option number B, increasing posterior cusp height. Why have I selected? First option, posterior contacts, when it says only, then I take it as a wrong answer, because you can do it by correcting anterior teeth also, right? You can't just do it only by posterior teeth. When you open up the bite in anterior teeth, posterior teeth bite also opens up and video obviously increases. So that is why I cancel this one option. And here in my recall, I have this as the option, contact of anterior teeth in centric. The correction of anterior teeth is not there. It was written contact of anterior teeth. And when teeth anteriors are in contact in centric relation, then obviously by that method, you cannot increase the vertical dimension. So after all of this thinking, we have boiled down to this as our answer, by increasing the posterior cusp height. But I hope you have understood the gist of it and the theory around it. All clear, students, everyone? All the 65 students that are watching right now. All clear, everyone? Right? So question 1, the answer was B. Question 2, I'll give the answer as B. Again, increasing posterior cusp height. I have given my explanation why other options are not your answer. And I think this is your best case. Now, here what happens is, say for example, all of the options can be an answer. Then you have to select your best case scenario. So that is what we have done here. Come to question number 3, very straightforward. 62-year-old female patient, class 1 distal extension, firm residual ridge mucosa, wants fabrication of prosthesis. What impression technique will be used? Selective pressure, dynamic, mucostatic, and functional. Correct answer is selective pressure. Why? Distal extension case, class 1, healthy, firm residual ridge mucosa. Selective pressure is the ideal technique. Now, if you want to cancel option, dynamic and functional mean the same. They cannot be the answer because they both mean the same and they are two different options. Mucostatic is not indicated here. It is indicated in cases where you want to not put stress onto the ridge. This is a good firm residual ridge mucosa. You can use a selective pressure technique. So question 3, option number A is the answer. I hope it is all clear till now. Now, this was a PYQ. It was asked previously, slightly tweaked or a modified PYQ, but it is a PYQ. Which of the following is correct pertaining to reciprocal arm in RPD? It is asking about your reciprocal arm in RPD. So, reciprocal clasp should be active before retentive clasp? No, that is not correct. Reciprocal clasp should contact the tooth before the retentive clasp flexes to counteract lateral forces. Yes. This is a correct answer. It should contact the tooth to stabilize it against the lateral forces that will be generated when the retentive clasp will flex and go over the height of contour. So B is your answer. Let us still look at other options. Option C, Reciprocal class prevents movement of prosthesis away from the soft tissue. No. And even in bracket gingival direction, something was written like this, right? But this is not the correct answer. Also, it is contradictory. Away from the soft tissue cannot be towards gingival direction. So that was a contradictory option which was there. And reciprocal and retentive arm is always active. That is also a wrong statement. So after cancelling all options, option number B, where reciprocal arm should contact the tooth before the retentive clasp arm flexes to counteract lateral forces, is your correct answer. It is a PYQ, a repeat question, something we've learned in our classes. You need this for bracing the tooth. Now, another nice question coming from indirect retainers. Indirect retainer serves as an auxiliary rest because or also why? What is the reason for it? Students, are you able to follow through all of the questions we have done till now? We have done 4 questions. And Kamakshi is asking a question, why not functional impression? So Kamakshi, first and foremost, why we will not use functional impression? Because with functional impressions, there's a tendency of denture rebounding. And you cannot distribute the load to stress-bearing area and distribute away the load from the relief areas. Equally, all of the areas will be loaded. So in comparison to that, selective pressure is better. Logically going here, 2 options mean functional, dynamic and D and D both, dynamic and functional mean the same. So logically, if I want to tackle this MCQ by the techniques of solving MCQ, I can strike that option out because 2 options mean the same only, so they cannot be the answer. So I hope that solves your doubt. Now, let us come to question 5. Indirect retainer serves as an auxiliary rest because it helps direct retainer in retention. It gives vertical support and distributes stress along long axis of teeth. It acts as indirect retainer only and it prevents dislodgement of major connector from soft tissue. Now understand the question here. What they are asking. This generally we are used to understanding the question in the way that auxiliary rest will act as an indirect retainer. Here they are asking the reverse of it. When you are using an indirect retainer, which is an auxiliary rest, what additional function it can do? What it will do is, it will give vertical support and distribute stress along long axis of teeth. It does not act as only an indirect retainer. It helps as a direct retainer in retention, but that is not the property of the rest. That is the property of indirect retainers. And option number D is also not correct because that is also a property of direct and indirect retainer. Here they are asking you the function pertaining to auxiliary rest. If the indirect retainer serves as an auxiliary rest, what it will do? So you have to boil it down to the functions of rest, which was it gives vertical support and distributes stress along the long axis of teeth. So slightly twisted question. The concept is something we have learned, but it is a good question because a lot of students would have done silly mistakes here. Have you all attempted what I've marked or you've made a silly mistake here? Let me know in the chat. Students, for question number 5, what have you attempted? So indirect retainer, when it serves as auxiliary rest, it will give vertical support and distribute stress along long axis also. A, C, and D. All of these are functions of the indirect retainer, not the functions of the rest here. All clear, everyone? Let us move to question number 6. Students, according to latest biomedical waste management protocol, disposal of dental plaster and model is to be done in which bag? So according to that, anything that is a patient waste, if you have a patient impression and you've poured your model into it, that model goes into yellow. So correct answer is B. Now, here you need to understand one more logic. The model that has been prepared from a patient's impression will go into yellow because it is after all a patient generated waste coming from any patient treatment, right? But supposedly if it is a model that is say coming out of your molds, your study molds or something that is not contaminated by your patient. I'm not saying patient contamination happens, but something that has not been used in a patient. It is something that is, say, your preclinical work. That can be discarded in black. So just as a basic knowledge, I'm sharing that with you. something that is not coming from any of patient treatment procedures that can go into black if it is a study model like that, right? But for our question, answer is B, that is yellow. Students, all clear till now? Now, something that I've taken a lot of pain to explain in classes, and I hope all our students would agree over here. Yes, students, were you able to solve the Facebook question? A dentist wants to mount a cast on articulator for which he is using a Facebook. What is true? It transfers orientation of maxilla to opening and closing axis of mandible. It fixes occlusal rims in patient's mouth. It records relation of TMJ to skull. And there was one more option. And I think it should be very clear to all of you and come naturally to you. Correct answer is option number A. Transfers the orientation of maxilla to opening and closing axis of mandible. We have discussed this several times in orientation jaw relation during live classes, recordings, and even during our free YouTube sessions, PYQ sessions also. If you've listened to any of those, you would have heard this coming from me, right? So yes, it was there in one of our recent GTs also. Even the question on functional impression also, that also I had added it in one of our GTs. So yes, when you give GTs, it will prepare you for your exam. So question 7, option number A is the correct answer. Basically, there is a hinge axis here that is responsible for opening and closing of mandible. And the logic here is with the Facebook, you want to transfer that onto the articulator. So chair side errors are reduced and you transfer that orientation, right? Yes. Yes, Prashant is saying yes, ma'am. Prashant has attended the classes and I know he would be remembering it. I hope you have not made any mistakes here, right? So Subiksha, Prashant, all of our students, that would have been a piece of cake for you. Question 7. Now, let us come to question number 8. Which of the following, when missing, is indicated for cantilever prosthesis? So when something like this is written, when missing, what would I do? I'll first see what pontic is indicated for cantilever prosthesis. What pontic can be used for a cantilever prosthesis? So maxillary canine cantilevered with first premolar, absolute blasphemy. You cannot do it. Maxillary canine is one of the most important tooth in the arch. It is a load-bearing tooth and has a lot of occlusal forces. You cannot cantilever it with first premolar, does not serve Ante's laws, cannot do it. So question number 8, option A, cancelled. Maxillary first premolar, that is cantilevered with maxillary second premolar and first premolar as abutment. Logic is not working over here. You are using two abutments, but still giving a cantilever. Also, it is a posterior tooth. Posterior tooth receives significant amount of occlusal load. Remember, cantilevers are mainly for anteriors. Wherever your posteriors are going to come, we prefer not to give cantilevers. So by that logic, I would cancel option number B also. Maxillary LI cantilevered with maxillary central incisor. Yes, this can be your answer, although it is not an ideal case scenario. Ideal cantilever is maxillary LI given from canine. That is your ideal cantilever. But if that is not the option, you can give it from a central incisor. And lastly, option number D, maxillary central incisor cantilevered from central incisor, not a very favorable outcome here, where one central supports the other central. So which of the following, when missing, is indicated for a cantilever prosthesis? Remember, a lateral incisor when missing is one of the primary indications of cantilever prosthesis, not a canine, not a central incisor, not a first premolar. So considering all of this, we will give option number C as our correct answer. Maxillary lateral incisor cantilevered with maxillary central incisor. Now, question number 9. According to latest research, which of the following causes least wear of enamel? And I'm smiling because this is coming from, there's a long list of theses that goes in my department at AIIMS, and this question boils or comes from there, although it is published and a lot of departments do this research, but I have seen it in front of me and I know the answer to it. So let us come to it. But before solving that, all 8 questions, all clear, everyone? Any doubts? Any doubts, anyone? All are 67, 70 students that are watching live right now, right? So it is extremely heartening to see that our students, although they were, say, Prashant is saying he was not eligible for it, for INICET, but he is solving questions. This is very good preparation, and that comes when you've attended life classes fairly well. That comes when you have given GTs well. And after all, the bunch of topics in INICET remain the same. It's just that the language is twisted here and there. So I hope it is all clear, right? So, according to latest research, which of the following causes least wear of enamel? Ultra low fusing ceramics are abrasive in nature. So, although they are softer, but they are abrasive in nature. So, they do not cause least wear. Polished monolithic zirconia. Zirconia has a very fine structure, and when monolithic, and then when polished, it will cause the least wear of enamel. There were studies that were done in my department. One of my seniors had a thesis. My junior had a thesis about this. Zirconia were compared. Polished versus glazed ceramic was also compared. And the outcome was polishing is always better than glazing. Now, lithium disilicate and low fusing ceramics are out of question. Both of them, porcelains in some way, will be abrasive than zirconia. So remember that. Now, it comes between the two zirconia options that was there. And polished monolithic zirconia and highly glazed zirconia. Amongst these two, the correct answer is a polished monolithic zirconia. Against glazing, the only problem is that the layer of glaze initially is very good, but once it wears off, then the rough zirconia will wear the opposing enamel. That is what we found in those research and theses that were done. So out of all of that, the outcome was polished monolithic zirconia. So my answer stands corrected over here. I think I might, Anirban, what you're saying, I'll just discuss it with sir once, but the correct answer definitely is polished monolithic zirconia. And yes, I'll share those articles with you. There are two sets of article comparing polished versus glazed zirconia, and the correct answer is polishing to this. So question 9 answer is B. Now, question number 10. This was a slightly tricky question, something that we have not seen or discussed till now. And yes, okay, let me come to the previous question doubt. Anirban is saying glazed is more polished. Anirban, okay, let us take up your question. Glazed is more refined or finer than polished. That is, I think, what you mean to say. But hear me out, I just said it. The initial layer, glaze is a layer that is added on top. The initial layer of glaze, when it wears off, then what is revealed underneath will cause wear of enamel. And when we do these researches, we don't do it over a day, we do it over a period of 1 year. We do the wear pattern analysis over a period of 1 year. In that 1 year, that glaze will wear off, and the underlying zirconia will cause the wear of the opposing antagonist enamel tooth. But when you polish your zirconia, that will have the least amount of wear over a period of that 1 year in the antagonist tooth. That is what was the outcome of the study. So that is why even in private practice also nowadays we prefer polishing of zirconia. So that is why the correct answer is a polished monolithic zirconia. I'll share those articles also with you, but the correct answer comes B over here. And whatever the confusion here is with dental materials and all, I'll just have a discussion with sir, but you can confirm and take up the answer. It was B. I'll share those articles, right? So I hope you've understood. Anirban, let us go to question 10. Question 10, slightly a tricky question, right? Slightly tricky question. Before that, students, just a second. Just a second. Are you able to see the screen, students? Are you able to see the screen? Yes, I think now you would be able to see the screen. I would share I don't have the article in hand right now as such, but I would be able to share the article as soon as possible, right? Yes. So title, you can just Google polished versus glazed zirconia and wear, and you would be able to see that. The Samsung flow, if you remember, students from the live class got disconnected. If you all remember the Samsung flow issues, yeah. So that is why the screen was coming slightly hazy, but now it's fine. Now, in question 10, in prosthesis, the prepared tooth and cemented crown. Okay. Now let us take up first, before starting this, let us take up Sneha's question. The question about waste management is, where do we dispose a prosthodontic cast? Since it is not touching a patient body fluid, it should be in black or blue. It comes from something which has been in contact with the patient body fluid, which is saliva, which is why we discard it in yellow. That is as per standard guidelines. There's like, it is not my opinion, it is what has been given in the guideline. So yellow is where it comes from. But as an additional knowledge, what I shared with you is something I learned in my department. If you've made a cast out of a study mold, the diagnosed molds that you have in first and second BDS, that does not come from a patient. It was a mold. That you can safely discard in black. That you can do. But here, nothing has been mentioned here. It has just asked a prostho cast or a model. That goes into yellow. Right, Sneha? So I think that should be clear for all of you. The standard guidelines very clearly mentioned it comes into yellow. Now, question number 10. In prosthesis, the prepared tooth and cemented crown, as per analytical mechanics principle, represent what? So, as per the analytic mechanical principles, what would a prepared tooth and a cemented crown mean like? Options are lower rigid and upper sliding pair. Option B, lower sliding and upper rigid pair, an open pair system or a retention pair system. Now, considering that the tooth is a fixed entity, so it is a lower rigid and the crown gets fixed over it, but can be dislodged by loss of retention or resistance from upper sliding. So that is why option A becomes correct. It is a slightly tricky question, something that we generally don't tackle into a day-to-day preparation. So these are the questions that come as an offbeat question, but it's okay. If you slightly try and understand it, probably you can attempt these questions if at all you want to. Otherwise, you can leave them. I would say a tougher question, but correct answer is option number A, lower rigid. Why? Because the tooth is rigid and firm. The crown gets cemented over it, and the crown can obviously get dislodged by retention or resistance form, and the unit or the pairing that is formed is the lower rigid and an upper sliding pair. Now, if you reverse of it, lower sliding, upper rigid, that becomes wrong, right? Because the tooth is a rigid entity, so it cannot be sliding. It is not an open pair or a retention pair system. That is why the correct answer and most appropriate of all of them is option number A. Now, let us come to question number 11. Which of the following an intraoral scanner cannot detect? Shade of the restoration, undercut of prepared tooth, parallelism of two teeth, marginal gap between restoration and tooth. Students, is it all clear? All 10 questions, all 9 questions. Is it clear, everyone? Sneha, I hope your doubt is solved. And the previous question also, slightly tricky question, but I hope you have understood it. Right, now let us come to question 11. Question about intraoral scanners, what it cannot detect. It can detect undercut of prepared tooth. It can very well detect parallelism of two teeth. So both of them are out of question here. Now, let us come to option number A, shade of restoration. Many intraoral scanners nowadays, the latest one, can detect shade of the tooth. Can it do it with precision? No. It can differentiate between your red and white, but it will not be able to bring out the exact shade with precision. That is why we use digital shade spectrophotometers and other tools for it, not your intraoral scanner. Now, option number D also is slightly tricky. Why? For example, if you have, I was discussing the question with one of my colleagues and he suggested it very well. For example, if you have a crown onto a patient's tooth and you are suspecting a marginal gap, and you can put a scanner over then very visually see it on the screen. So it can do that. It can identify the marginal gap between restoration and tooth. But what if it is a subgingival margin? Then you can't do it, right? That is a limitation of it. But still, in most cases, it will be able to do that. So then cancelling everything out and taking into consideration what options we have, the best answer I can give here is shade of restoration, because that is something that intraoral scanners cannot do with accuracy. Rest other things it can do. It can definitely identify undercut of prepared tooth. It can identify parallelism of two teeth. It can even locate the marginal gap between restoration and tooth. But shade is something it cannot give with precision. All scanners cannot give. That is why we select the best case scenario, and this as our correct answer. Anurag, I already took up that question, and the correct answer would be yellow for it. The bin question that you're asking, the correct answer would be yellow for it. Impressions also would go into yellow. Now, maximum stress concentration in an osseointegrated implant, a standard fact-based question. This occurs at crest. Crest is the union part or the junction part where maximum amount of load transfer occurs to the bone from the implant. Bending forces are also over there. That is why it would be crest as the answer. Right? Yes. So what Anirban is saying, that is a very good strategy. You cancel out other options and then you come to your answer. But question number 12, a straightforward fact-based question. Maximum stress concentration occurs in the osseointegrated implant where this is the crest. That is why we see maximum bone loss also here. The crestal bone loss. That is why bone loss is studied also a lot. Why? Because the bending forces will be there. Transfer of load will be there at this point. So crest is the answer. Sneha and Anurag both had the same doubts, but I think your doubts are clear. Yes. Come to question number 13. Answer was already given in options, I would say. 35-year-old male patient with missing maxillary central incisor. He had a high smile line, minimal hard and soft tissue loss or resorption. CBCT shows bone is adequate height and width for placement of implant in natural position. Then, what is the kind of prosthesis? FP1, where you only give crown. FP2, crown and root partially are restored. FP3, crown, root and gingiva are given. And D, cantilever from central. Cantilever is not a favorable option considering the clinical scenario, which is near to ideal of this patient. It is a young 35-year-old male patient also, high smile line, then minimal resorption is there. CBCT already has been done. Correct answer is FP1. Even the classification was given in the brackets. That is already, I would say, a very plus point. If I were the examiner, I won't give the classification in comments. You should know what FP1, 2, and 3 means. But your examiner was very pleasant with you that they already gave that also to you in options. You just had to select FP1. That's it. So very pretty easy questions. And this is something we discussed in that last 1 hour of our live class, that this classification you need to remember. The same came in your exams. So students, yes, this is something what I tell you. Attend your classes, attend your GTs, and you will be able to solve everything, right? So I hope now we are able to figure out that what we have done in our classes is actually something is coming in exam. And let's come to Sneha's doubt. Shade selection we do with generally either directly, as in the clinician would do it directly, or there are digital spectrophotometer shade matching devices that you can use, either of them. You can use either of them. Manually also you can do, or with the help of a device. Both of them you can do. So the crest one, yes, we had done it in our T&D. Anurag is telling us that we have already discussed it. So if you see, if you've done all of this, you will be able to attend the questions. 14th question. Bone tapping for implant placement. I think there is a certain obsession with this question now. In that, I have taken this at least twice or thrice in the recall sessions also. I've discussed it in our classes. I think this is something that is now hammered in a student's mind. Bone tapping for implant placement is done in dense bone. As soon as yesterday I was discussing the recall questions with the students and just trying to tell topics so that they can remember where the questions came from. And I just said, bone tapping was asked, and they said, yes, bone tapping was asked. And it was very pleasant, but I was happy also that, okay, fine, a question came in exam, which is something we've discussed so many times in our GTs, in our classes, everywhere. So I can give 100% guarantee none of you would have made a mistake over here. There's a particular obsession with this question, but dense bone is your correct answer. Now, what is the reason? When you drill into a dense bone, lot of heat is produced. The vascularity is less. There's a chance that the bone will overheat and eventually the bone may resorb, right? So what you do is you do something which is called as tapping and threading, so that that friction and that heat generation is not there in D1 quality dense bones, right? So that procedure is called bone tapping. Now, let us come to question number 15. This exact image was there. Only thing which was not there was this occlusens was not mentioned. This was not there. Okay. Otherwise, the exact image was there. Right, students? So, this exact image, you are supposed to identify what is it. Is it a T-scan sensor? It is a bite force sensor, occlusens sensor, or an implant stability monitor. It is occlusens by Bosch company's occlusens sensor. It is a sensor to detect masticatory forces and pressure that is used. And T-scan is also for similar purposes, but this is not a T-scan sensor. It is an occlusens sensor. Implant stability monitors and periotests do not look like this. They will look like how your curing light would be like. They would have something like that. This frame goes into the patient's mouth, right? Even I had my study on bite force. The bite force sensor which I had was something like this in a block that I used to put into the patient's mouth. So again, a long lineage of study attains over bite forces and masticatory pressures, and maybe somewhere that would have initiated that, okay, this let us put this question. But the most appropriate one, this is an exact occlusens. Sneha is asking why not B? Because this is not a bite force sensor. This is an exact occlusens sensor only. You can identify it from the color, print, design, whatever the apparatus appearance. This is an occlusens sensor. It is of the company Bosch. So to tackle these kind of questions, we always say flip through your books and just have a look at the images so that somewhere it is registered in your head, right? Bite force, I'll share a picture with you in our Telegram group and you can have a look. Fine. So that was question number 15. Now let us question number 16. Very easy. Identify what is given over here. Students, before that, we have completed 15 questions. So, Sneha is asking bite force. Sneha, see, the bite force that I had, it was like this. It was a plate like this. I'll just draw it out. It was a plate like this. Just a second. Again, I think my Samsung Flow is giving some issues. Yes, I'm just coming onto it. Students, don't be worried if the screen goes slightly here and there. It will come back to normal. Yes. Okay. Students, we are back to normal. So, Sneha, I had two acrylic blocks like these. I had two acrylic blocks like this. In between them, I used to put that small bite force sensor. It was with a wire and a small plate-like sensor was there. And then I'll put the assembly into the patient's mouth near the first molar region, and patient would be asked to bite over it, right? So that is how it would be. So the apparatus looks somewhat like this. If you want, I can share the exact image from my this Anurag, because this is not a T-scan. For example, I'll give you a very weird sort of an example, but say, for example, in front of you, there is a particular XYZ brand of sneakers present. It is an Adidas shoe, or this is a Puma shoe. Okay. Now, there, if the options given is Adidas, Puma, Nike, you can't write pick Puma for an Adidas option, right? Same is over here. T-scan, this function is the same, but this is an actual occlusens that is by Bosch. T-scan looks different. It has a different configuration than this. This is an exact occlusens sensor. So because it is an exact diagram, that is why you attempt this. It is not an illustration. It is an exact image of what an occlusens sensor is. And although I don't like commercial things being asked as questions like this, because we generally don't do that, but still. Now, question 16, fairly easy question. Hamular notch was asked. Arrow was marked over here like this. and the region of hamular notch was asked. You were asked to identify that. So I think fairly easy. One of, I think, the most easiest question out of your entire paper would be this, to identify hamular notch. So question number 16, the depression that comes after maxillary tuberosity. This is your maxillary tuberosity, and this is the depression that comes after the tuberosity. So that is your hamular notch. Now, this is slightly controversial. There was a particular image like this in the exam, and arrow was pointing towards Ruge, and you were asked to identify. Now, through all of the students that I was in touch with and a lot of people who appeared for the exam, everyone is saying that they could not figure out or they could not see any pathology. Epilis was not visible, redness was not visible, no visible papillary hyperplasia is there. And hyperplasia is generally in this region, in the vault of the palate. Epilis is generally in this region. But every single of the students said there was a marking that was towards the Ruge area, right? The marking was towards the Ruge area that was there. So then the only thing which I could figure out is probably they were trying to point out at an ulcer. But still, because we don't have the correct image for this question, that is why I would not be able to give you a conclusive answer, but I've given you the explanation over here that there was an image of a completely edentulous case, fairly normal maxilla, nothing pathological as such was visible clearly. No clear-cut epilis was visible or no clear-cut hyperplasia was also visible in the vault of the palate. And if you want to show papillary hyperplasia, it will be present over here, not in the Ruge region. It will be present in the vault, right? Now, then what it would be? It would be either an ulcer or it would be either stomatitis, but then stomatitis is generalized. So the only thing I could figure out is probably they were trying to show an ulcer over there, and that is why we've given that as the answer. Okay, we have one of our comment, SS Brave 9852. It was atrophic labial mucosa. Was it in the question number 17? Let me know that also. Okay, right, students, I hope you relate with question number 17. I think most agree that there was some arrow that was pointing towards Ruge, but then nothing specific was visible over there. That was question number 17. Okay, so Lucky Bora is also saying it wasn't visible. Anurag is saying it was epilis. That is what we are saying. We have a mixed opinion. What exactly? Some people feel that they saw an epilis, some feel that they saw an ulcer. We don't have the correct image, so I can't give you the conclusive answer for question number 17, but we can teach everything about it, and whenever whatever comes in the exam, you can appear for it. Now, question 18, it was a straightforward wrong question. It was Kennedy class 2, mod 1, very similar to like this. There was some sort of an anterior FPD visible and a third molar was seen over there, and mod was not there in the options. 1, 2, 3, 4 only was there in the options. Then what do you do? So by this case, you could go for Kennedy class 2 also. And if you take up Applegate rules and think that third molar is going to be extracted, then it can be converted into class 1 also. So class 1 and 2 both can be logically appeared as answers, but this is a straightforward wrong question. The correct answer here is Kennedy class 2 and mod 1, which was not in the options. So you could have actually challenged this question and you can challenge it. And now a lot of students are saying epilis was there. Some are saying papillary area was involved. So this is what I'm saying. The confusion was there. Epilis will be visible in the vestibular region and the arrow was towards the rugae, and the hyperplasia is seen in the center of the palate, which is why there is a lot of confusion in question 17. Question 18, no confusion, only that the question is wrong, right? Come to question 19. Which muscle is responsible for role in this area? This is the distolingual portion of alveolingual sulcus, or the distal part of alveolingual sulcus. Levator anguli oris, mylohyoid, palatoglossus, and superior constrictor. And there is one option which I could not recall. Correct answer here is, however, palatoglossus and superior constrictor. They will affect the distolingual portion of the mandibular flange, and the distalmost part of alveolingual sulcus will be affected by it. Mylohyoid will affect the middle part of it, not the distolingual portion. So the correct answer is option number A. I hope students you have attempted this as your correct answer. Let us come to question number 20. A simple healing abutment was visible like this, and the question was asked in exam what it is. So options were healing abutment, implant analog, impression post, and straight abutment. This here is a standard healing abutment. It is used at the second stage surgery after osseointegration is completed, so that you can have a gingival collar formed for the subsequent process for the crown also. So we have learned this in our classes. It is present in our notes. We've shown it to you in live classes and recordings. This is a standard healing abutment which was asked in exam. One of the questions coming from components of implant. And last question, according to long centric theory, which is the theory given by Schuller, it is a theory about freedom in centric. Condyles can rotate without translation, move vertically downwards, remain stable during occlusal movements, or translate horizontally before moving downwards. Now, according to long centric theory, condyles can do what? They can rotate without translation, or they can move vertically downwards, they can remain stable during occlusal movements, or they can slightly translate horizontally before moving downwards. Now here, this is also slightly controversial for me because I probably don't have the most accurate recall. Freedom in centric basically is what? Generally, we have a pinpoint contact like this of anterior tooth. Now, instead of having a point contact of centric like this, for example, you have a horizontal region like this, which is called as a long centric. I'm not a very good person who can draw this. So basically, instead of a one point, we are given a horizontal area like this, where the tooth can come in contact, right? And it can slightly slide anteriorly also. So according to this long centric theory, the tooth will be in centric and can slightly slide anteriorly also. It is a Schuller's theory of freedom in centric. It gives some freedom in movement, right? Now, let us come to options. Because of this freedom, the condyle can rotate without translation. Yes, definitely. They'll move vertically down. No, that is not the correct option. Because of this, they remain stable during occlusal movements. That is one of the advantages of long centric, that you will have stability during occlusal movements. And also, it can slide or translate horizontally before moving downwards. So, because of, I think, dubious recall here, we cannot give a very conclusive answer because A, C, and D, all three of them feel correct to me right now. But if I have to select still one option, I'll go with option number D, translate horizontally before moving downwards. Why? Because it gives that gap, I would say area like this, where that freedom or room for movement is there, but rotation without translation and being stable during horizontal movements, all of this is also correct according to me. So I think if you have a better recall of this question, where we can cancel out other options, please share it to me. Then I can probably give a better answer to this, because right now with this recall, apart from option number B, all three seem correct to me. It can rotate without translation. It remains stable during occlusal movements. That is one of the key factors of long centric. And it can translate horizontally or move horizontally before moving downwards. So yes, what Shivam is saying, A mark kiya. Yes, Shivam, A is not wrong. I'm not saying it's wrong. It's just that probably we don't have I would say a better recall of it. So I'll urge all of our students for question 21. Just give me a better recall and we can solve it once more again and give you a better conclusive answer. With this, I think we come to an end to today's session. If you have any doubts, any queries, any suggestions, or anything that you want to ask me, you can connect with us on Facebook, Telegram, and we will be very happy to solve all of those questions for you. If you have any suggestions pertaining to these recall, again, that you can send us across on Telegram and I can take those suggestions up. Most importantly, I need your help for this question. question number 21. If you can share whatever best recall you have, we can solve and bring a better question for you. That brings us to an end to this recall session. So I would ask all of you, how was Prosto overall? What I feel is it has come from the topics that we have studied. Only thing which I feel is the options will seem confusing, but that is classic of INICET. I hope our classes and everything helped to you during the exam and during solving any of our GTs. Keep appearing for exams and keep revising, keep preparing well. I'll see you all in any other next session. Wishing all of you the very best for your exam results.
Okay, hello, my dear students. A very, very good afternoon to you all. So, the INI is done, and I hope it went well for you all. What reviews I got from the students were very mixed reviews. There were a lot of students who said it was a moderate to difficult sort of a paper. But INI is supposed to be like that. It is famous for its twisted clinical questions like that. So we had a fair share of periodontics. I have recollected around 10 to 12 questions of the subject of periodontics. And let us one by one discuss what questions were asked. So there can be a little, exact framing of the question or exact framing of the, the option will not be there, but you will get around. The questions would be more or less similar. So just pay attention. The first question that we retrieved was, microorganism responsible for rapid progression of early childhood caries. Okay, just let me visit the link where you all can, where I can see the comments you guys are posting so that I can reply to you all. Okay, so the first question that I have retrieved is, what microorganism is responsible for the progression of ECC? So every time you get this word called progression, or how does a particular caries progress, how does it spread? So whenever you get this particular word in the question, you all should hit for the answer as lactobacillus. The aciduric bacteria, the acidophilus lactobacillus, is the bacteria that is responsible for progression of the early childhood caries, or any sort of caries for that matter. The causative agent is Streptococcus mutans, but the answer when they've asked you rapid progression or rapid spread of the ECC, when they ask you that, you must go for Lactobacillus acidophilus, which is an aciduric bacteria. Okay, so the answer is C, right? Okay. Right. The next question was, which of the following is a risk for the development of early childhood caries? What can cause the early childhood caries? So the answer here is, understandably, frequent snacking on sugary foods. See, because twice brushing Of course not. Nighttime bottle feeding with water, if they say, that means that cannot be cannot be a risk for the development of early childhood caries. And regular dental visits, of course, because regular dental visits will do what? Regular dental visits will keep you updated of your dental status. If there is anything, any sort of an incipient caries lesion, it will be remineralized and stuff. So regular dental visits, if a person does, again, it is not a risk factor for the development of ECC. When we say frequent snacking on sugary food, that can be a reason for early childhood caries. Now, why nighttime bottle feeding with water? Because nighttime bottle feeding is risky, because what happens when the child feeds on milk and sleeps like that, there is a layer of milk that is formed over the teeth. The milk has its own certain sugar in it, which keeps demineralizing or keeps attacking the tooth structure all through the night, and that causes ECC. But when the child has water before sleeping and after having the milk, that particular film of milk is washed off from the teeth, and that results in a clean mouth that is free of biofilm containing bacteria due to the deposited milk. That is why every time a person, every time you prescribe syrups to the child, so like if you're prescribing antibiotics, or if you're prescribing analgesics, etc., to a particular child, every syrup, every medicine has sugar in it to make it palatable, to make it taste good. So every time you ask them to take a syrup, every time you give them the medication, ask them to take water with the medication, so that the layer that sticks onto the tooth is washed off, and that does not become a risk factor for development of caries. So that is why C, that is nighttime bottle feeding with water, will not be a case. Okay, yes, it does say water. Yes, that was a trick question. Okay, welcome to INICET, right? Okay, so the answer here is frequent snacking on sugary foods. So whenever you're giving oral hygiene instructions to a particular person who says, I cannot avoid sweet, I like sweet, the most you can tell them is, if you want to eat sweet, eat them with a meal. Snacking in between meals attacks the teeth in a worse way. But if you take some sweet with the meal, it does not attack your teeth in a bad way. You do not become prone to caries. Okay. So if you're doing a lot of snacking of sugary foods, that is 100% causing early childhood caries, or any caries for that matter. So the answer is A there. Right. Question number 3 is, patient with early childhood caries, and there was specifically mentioned that the caries are cervically present. So probably like a class 6 lesion or something that is present on the gingival margin probably must have been in the question, and they had asked you the treatment plan for it. So if there are caries, on the cervical region, so fluoride application will not help. So basically, if they would have given the extent, if they gave that the caries are deep, so you can go for restoration with GIC. But if they specifically said that there are incipient caries lesions on the cervical area, or if there is a grade 1 early childhood caries there on the cervical area, then you should go for fluoride application and diet counseling. So because the one that I retrieved, I could not specifically gather the depth of the caries, so I would say that the answer is A. But if they specifically mention that there is discoloration on the, or probably white discoloration, matte, matte or white spot on the cervical caries, if they've specifically mentioned that, then you should go for fluoride application, diet counseling, otherwise GIC restoration. Hope that is clear. Okay. Let us come to question number 4. So in a 7-year-old child with mixed dentition, which of the following is most indicative of the requirement of interceptive orthodontic treatment? Now, interceptive orthodontic treatment covers all the space maintainers, right? You all know interceptive means the type of orthodontic treatment that is done in order to prevent some malocclusion. You intervene, so that is called as interceptive orthodontic treatment. So in a 7-year-old child, when will you, what is the most, what is a condition where you require interceptive orthodontic treatment the most? Is it a carious primary molar, or a delayed eruption of the first permanent molar, or retained primary teeth beyond 12 years of age, or whether it is early exfoliation of the primary tooth without eruption of permanent successor? Okay, so here, if these were the exact options, then we would actually go for early exfoliation of primary tooth without eruption of permanent successor. D would be the answer there. In fact, carious primary teeth is also one of the reasons why you should intervene in a particularly 7-year-old child, because carious primary teeth, when there is proximal caries, they can cause loss of space, but it's not clear. So let's go for D, that is early exfoliation of. If it is Shivam, if it is not grade 1, then you should go for restoration with GIC there, right? So here you'll go for early exfoliation of primary tooth without eruption of permanent successor, right? Okay, so that's D there. The next question is, an 8-year-old child presents with carious second mandibular molar, that is tooth E, which is shown in the picture, as seen in the clinical and radiographic images. What is the most appropriate treatment plan? Okay, so this is the condition. Okay, he is an 8-year-old child. So generally, when the child becomes 8-year-old, what happens? There is resorption of the roots that has occurred. But if this was the radiograph that was given, in this radiograph, you can see a carious E, but the roots are full and complete, and the permanent successor is way behind. There is a lot of time remaining for the permanent successors to erupt, right? So, in this case, you will not do an extraction. You will do a pulpectomy and a stainless steel crown you are going to give. Okay. Now, pay attention. Roots were more resorbed than this in the X-ray. Okay, so Tejas, the trick is, if the roots are, if the root resorption is more than 2/3 of the root resorption, so that means if it is half or more than half of the tooth is resorbed, then you go for extraction. Okay, and once you do, when you do the extraction, you see that amount of tooth bud that is developed. If there is beginning of the root formation has been done of the tooth bud, and the tooth bud is very near to the boundary of the bone, then you go for extraction with space maintain extraction and weighting. But if the tooth bud is far behind and the root development has not started yet, then you go with extraction with space maintainer. But the image that I have put here, it has full roots. So according to this image, you should do pulpectomy with stainless steel crown. Okay. Right. Okay. So, B will be, okay. So if the roots were completely resolved, that is what I said. Hana? Okay. Somebody is having fun. The caries were non-restorable. Right. Okay. So, let's learn something new here. If this was not the exact question, that is what I said. If the roots were completely resolved, you go for extraction, but then you look at the developing tooth bud. If the developing tooth bud does not have roots, that means there is a lot of time remaining for it to erupt, so you go for extraction with space maintainer. If the root development has begun of the developing tooth bud, you go for extraction and weighting. But if the roots are complete, you go for pulpectomy with stainless steel crown. All right. Okay, so restorable in the image, extension, right? Okay, so if there was only crown, there, that means you should go for extraction, but you need to see whether you should give a space maintainer or you should wait. You wait when the tooth bud is just about to erupt. Okay, Sandalwood, you are smiling about something. Okay, I hope. All right, so there were two questions. One which was, right, Sandalwood, there is somebody called Sandalwood. Right. So there was a question with full roots and there was a question with resorbed roots. So resorbed roots, extraction, full roots, pulpectomy. Right? Okay. The next question. Yes. Question number 6, what I could retrieve is, please correct me if there are any corrections like you did for the last question. So ICDS score 3 in pediatric patient management is. So what is ICDS score 3? ICDS score 3 is when there are frank caries, there is discoloration of the tooth due to caries, and that you should do the caries excavation. The caries have involved a good part of the enamel. That means there is enamel breakdown that has occurred. That is ICDAS 3. So in such a case, you should not do resin sealant. There is no topical fluoride therapy. You must do cavity preparation with GIC restoration. Now, why not composite? Because composite you do for adult patients. In pediatric patients, you always prefer GIC restoration, right? Okay, so the answer for C is favorite for AIMS. Yes. So we've covered a good portion. I think a separate lecture for ICDAS in our live classes and the recorded ones. So if you would have attended them, I am sure you would have got this correct. Only thing you should remember is composite restoration always for adult patients and GIC restoration always for the pediatric patients, because the pediatric patients do not cooperate so much. You will not be able to maintain so much isolation, no proper cavity formation. So GIC, because it will stick to the tooth, so it is always better to do GIC in pediatric patients. For composite restoration, you need a good amount of isolation, good amount of enamel to bond. Okay, so we always prefer GIC. So the answer here is C. All right then. Okay, the answer is C. Now, question number 7 was carious tooth with proximity to pulp in the primary dentition. Okay, so there they had given a condition where there was a carious tooth where the caries was very close to pulp in the primary dentition, and they had asked the best conservative treatment. So because they have said proximity to pulp, that means it was very close. Okay, Anurag, it was not in this form. If you could just, whatever you remember, if you could just type it there. Right, okay. Whatever you can recollect, if it was not image based, you can type in the comments and I shall answer. So in this, because the caries is close to the pulp and not involving the pulp, the answer becomes IPC with calcium hydroxide. Okay, that's the best conservative treatment. Indirect pulp capping with calcium hydroxide. Yes, A. Correct. The next question is, so they had asked, again, there might be a little, the question might have been framed a little differently. Recent fluoride used to prevent caries that does not stain the tooth. So they had given 4 types of fluoride that prevents caries, but the condition is it should not stain the tooth. So they had asked which of them is the best amongst all of these. So the answer here is, okay. So the answer here is silver fluoride nanoparticles. Okay, so if we have silver fluoride nanoparticles, there is no staining of the tooth. And out of the options that I have given here, that I have recollected, out of these, silver fluoride nanoparticles is the most recent advance, and the best out of these does not cause staining at all. All right, okay. The 9th question is, which system or protocol is primarily aimed at preventing further progression of dental caries through early detection? So they had given these 4 types of detection methods, the caries detection methods, and they had asked which of them helps in early detection and management of caries. So, okay, moves. Yeah, but silver nanoparticles. Yeah. All right. So these are the systems that they have given. ICDAS, which means International Caries Detection and Assessment System. There is CAST, which is Caries Assessment Spectrum and Treatment. There is ICCMS, which is International Caries Classification and Management System. And then there is PUFA, which is actually an acronym for index used to record the clinical consequences of untreated caries. So if you leave untreated caries, what is going to eventually happen? So P stands for pulp involvement, U is for ulceration, F is for fistula, and A is for abscess. So this is basically that. So the answer here is ICDAS, because what they've asked is they've asked early involvement of caries. Which of these detects early involvement? So ICDS score 0 and 1 detects the most early caries lesions. So the answer here is A, that is ICDAS. The rest of them you all can read in detail or attend the classes. We've got it covered in the classes. Right? The last question here is measures for caries prevention in child less than 6 years of age. Okay, so the child is less than 6 years of age. What all can you do here? What all can you do here in order to prevent the caries? So the options that they've given is fluoride varnish application, pit and fissure sealants, whether it is parent counseling or it is mouthwash. Okay, so these are the four options that they've given. Now, a child is less than 6 years. Okay, so basically, you nowadays there are certain brands that have developed mouthwashes for children less than 6 years, but generally we do not recommend its use specifically for caries prevention. So the answer, the best answer here is B, that is 1, 2, 3. That is 1, 2, 3. That is use of fluoride varnish application. You can apply APF or Durafat or other varnishes, floor protector, the varnishes that are available. Or you can do pit and fissure sealants for caries prevention. In 6 years, they have the new molars coming out. So you can seal the fissures there. Parent counseling will also help, and then use of mouthwash is not recommended in children under 6 years. So for this, let us go for the option B, that is 1, 2, and 3. Okay. There was antimicrobial. Yes, antimicrobial mouthwash must be a reason, must be an option. But under 6 years of age, you cannot generally recommend it for caries prevention. Okay, so the best option is 1, 2, and 3. Again, okay. There was a question on wipe home study. Wipe home study, I think the community faculty will cover because she's the one who's taken this. So I don't have it included in my session. Okay. Anything else? Any other doubts? Okay, so I think this is all. So these were all the questions that were present in the pedo subject, and I hope you've got them correct. There was no twist and turn, no twisty clinical question, nothing like that. So yes, so all the best for your results, and I hope you did well. Thank you so much.
Okay. So guys, let's start. I guess everything is working fine. Uh Hi, afternoon, friends. Afternoon, everybody, bache. Afternoon, everybody. So, I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So, let us start with our path and micro recall. So, hi, afternoon, dosto. Afternoon, Tanvi, Komal, Anandam, Shivam, everybody. Acha, वैसे before I even go further, like it's very mutual. It is good to see you too, dost. So before I even go further, how did you find the paper? How was the paper? I know this was a question that would have been asked by majority of the faculties. How was the paper? This, that, whatever. But I like to tell you, firstly, the purpose of the recall. It is not to make you anxious. That is not the point at all. It is about the fact that these were the questions that came in the paper. Those of you who gave the paper know that well, but it is just a good compilation of the same. Topics can be repeated in NEET exam also. NEET MDS is our main exam. So topics can be repeated. As a result, you have to do these topics extremely well. And thirdly, under no circumstance overthink either on the questions being discussed or on the result. जो आएगा देख लेंगे. NEET MDS अपना main है. Paper was moderate. I agree, it was actually moderate to slightly tougher because I was just watching. It was difficult. I agree to that. It was moderate to slightly tougher. It wasn't as simple as it seemed because I was just watching the previous session, Dr. Anaya's session. The first question was on early dental caries. The progression was by. Dekho, even in that question only, you very well know that the initiation of childhood dental caries, it is by strep mutants. That was what we used to discuss with respect to infective endocarditis also. That is if the tooth is extracted, face gets mutilated. So infective endocarditis after tooth extraction, strep mutants. But the examiner had asked you progression. So the minute the word progression is written, the answer had changed to lactobacillus. I'm sure you already know this. So seriously, thanks, Anurag. Matlab, that is such a nice statement for you to say. But this is what I'm trying to say, that even a single change in word changes the answer with respect to INI, and we have to take care of such questions. So let us start. Let us start with our path and micro recall. And once we are done with the path and micro recall, I have something special for you also in the last 5 minutes. I'll show you that. So let us start. Let us start with our first question. I guess this was a question. Afternoon, Tanya. Afternoon, Biche. So I guess this was a question that we always used to keep in all the grant tests. That is the most common opportunistic infection after steroids or when the immune system is weak is that of Candida. It is that of Candida. Plain and simple. I am pretty sure majority of us would have been right in this. Isme another question that is again pretty commonly asked is with respect to Kaposi sarcoma. So tell me these two answers also. Which is the most common malignancy associated with HIV? Most common malignancy with HIV? Answer bache. NHL, non-Hodgkin's lymphoma. NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. Please do not make that mistake that you say most common malignancy as Kaposi. No, most common is NHL, followed by Kaposi. Whereas most common oral malignancy with HIV is Kaposi sarcoma. Most common oral malignancy with HIV is Kaposi sarcoma. This is an important point. Kaposi sarcoma, it is associated with which other virus other than HIV? HHV8. I know I laid a lot of stress on this when we were doing routine classes also because this was last time's MBBS segment NEET PYQ. HHV8 is associated with three diseases. That is Kaposi sarcoma, primary effusion lymphoma. Kaposi sarcoma, primary effusion lymphoma, and Castleman disease. First class. Next point. So oral cavity, it is Kaposi. Ha, Anuj, agreed. And now that you're talking about oral path, I will be taking, that was the surprise that I would have told you that I'll be taking oral path recall also few questions because I'll tell you the reason when we come to that. So coming back, most common opportunistic infection, Canada. अच्छा, इसमें any question that you felt slightly tougher, please do tell me कि सर ये वाला अपने notes में नहीं था, या we were not able to attempt this question after doing the notes. Even that is also the purpose of the recall, कि अगर हमें कोई topic tough लगे मुझे बताना. नहीं नहीं नहीं, नहीं बच्चे नहीं. So coming back, Tanvi, I'll say the why part now. This gets us to our next question. If both the parents have thalassemia trait, so I'll tell you. ये थोड़े से questions discuss करके gossip करते. Let's have a look at 5-6 questions. So coming back, नहीं अभी वो अच्छा. Now that you are asking me, I'll tell you. One of our very close friends. Yeah. एक second, Lucky. I feel the question was more like what confirms the diagnosis. Those, if the language of the question is changed, then our answer is going to change. But if the language of the question is most common opportunistic infection with HIV, then it is among the fungal infections. It is Candida. It is Candida. Next question. High risk of thalassemia trait was an option. Doesn't matter. एक बार पहले question तो पढ़ें. If both parents have thalassemia trait, you know that thalassemia is autosomal recessive in nature. It is autosomal recessive. So three things can happen. Either the person will be normal, that is both his alleles are okay, he's beta beta, or he is thalassemia trait, that means one allele is normal, the other is abnormal, beta beta 0, or he is thalassemia major, that means both the alleles are abnormal, beta 0 beta 0. You know this. These are the three things which can happen. So if both the parents are thalassemia trait, they are thalassemia minor, that means both are beta beta 0. Who will be the four kids? Beta beta, this beta goes with both. Beta beta, beta beta 0. This beta 0 goes with both. Beta beta 0, beta 0 beta 0. These are the four kids. So what we have here is 50% children are thal trait, 25% are normal, 25% are diseased. This is what we have. Now, what is the risk for 50%? 50% children will be normal. 50% children will be thal trait. This is high risk of thalassemia trait. Agreed. If that was the option, Amit, if that was the option, that becomes the answer. Just a sec. Harishab. क्या हुआ? इसको छोटा करना है. ऋषभ, मुझे बताओ ना क्या करना है. It will be faster. छोड़ो ऋषभ, you leave it. बस ये हो गया. रुक जाओ ऋषभ, मैं इसको पास कर लूँ. ये लो, इसको बाहर लो. ठीक है, बस दैट इज ओके. Okay, so guys, coming back. There's some technical issue because I thought that my session will be around 3 p.m., but it got slightly preponed. Doesn't matter. So let's come back to this. If so, what will be the risk for 50% children? 50% of the children will be thal minor. 50% children are thal minor. That is, there is, if the examiner has said that there is a high risk of thalassemia trait, then we'll mark that. Moderate risk की जगह अगर high risk है, if the examiner had written there is a high risk of thalassemia trait, then that becomes the answer. High risk of thal trait. Please give me a. Sure, it is going slightly delayed. Okay. So the answer in that case becomes high risk of thalassemia trait. If high risk of thal trait was not in the options, then it is moderate risk of thalassemia trait. Please tell me, हमें ये वाला question समझ में आ गया? I know there was some distraction because of the settings and all, but I guess we are comfortable with this now. Next question. Now, this was proper INI tricky question. This was a question that is that is proper INI level, because both are beta 0. Huh. Perfect. That was the right answer that you marked, Joyce Amit Mandal. I'm not able to pronounce your name clearly, but your answer was right, because 50% were thalassemia trait, beta 0. That is why there's a high risk of thalassemia. Agreed. Now this gets us to our next question. This was tricky. इसमें क्या mark करके आए हो? Before I tell you the answer, what will be the ये वाला नहीं. Incomplete inheritance was straightforward. The next question was tricky. What will be the inheritance in pedigree which shows incomplete penetrance? देखो बच्चे, the name tells you that it is incomplete penetrance. That means even if the allele is abnormal, sometimes it will lead to disease, sometimes it will not. So of course it is not seen in all generations. Incomplete penetrance है, absent तो नहीं है. So disease is seen in one generation but not in other. It is seen in one generation, not in other. It was incomplete penetrance. No one is affected, गलत है. Only one gender is affected, भी गलत है. One gender will be affected in sex-linked inheritance. That is either X-linked or Y-linked. That is when one gender is more commonly affected. This was straightforward. Next question. This was what I meant by the fact that this is INI level tricky question. Prenatal genetic counseling is an absolute indication for all these diseases except. Answer. This was, frankly speaking, this was a point which even I had to read. मतलब ये तो वो वाली बात होगी, those of us who do good things in life ना, उन लोगों का ये आंसर फट्टे से ठीक हुआ होगा, not otherwise. देखो, if there is family history of cystic fibrosis is autosomal recessive disorder. You already know CFTR gene mutation present on chromosome 7. So you will go for prenatal genetic counseling. If there is a history of child with congenital diseases, in this case also you will go for prenatal genetic counseling. So I am sure about the fact that in these two conditions we will do prenatal genetic counseling. We are confused between option A and D. If the parent has balanced chromosomal defect, it is associated with recurrent abortions. Which again is an absolute indication for genetic counseling. But the answer is A, parental consanguinity. You very well know consanguineous marriages are marriages between family members or between first or second degree relatives. So autosomal recessive disorders are more commonly seen in parental consanguinity. If there are consanguineous marriages, autosomal recessive disorders are more common, and genetic counseling is recommended. See the difference in the wording. Genetic counseling is recommended, but it is not an absolute indication. You know that consanguineous marriages are pretty common in South Indians, that is Karnataka, Muslims and all. You know that. We discussed it in class also, but it is a recommended for prenatal genetic counseling, not absolute. So the answer was A. I know this was a tricky question. Majority of us would have marked the answer as D. So ठीक हो गया. Okay, so पूनम लाइफ में अच्छे काम करती है, so ठीक हो गया. But this was a pure luck based question. This is, yeah, I put such questions. That's okay. The answer was A. Next, this gets us to a last question with respect to path micro. That is, I'm sure you know this, gastric mucosa associated lymphoid tissue lymphomas. So MALT, इसको हम MALT भी कहते हैं ना. We would have done this MALT, mucosa associated lymphoid tissue lymphomas. It is most commonly associated with which organism? That is H. pylori. ये Helicobacter pylori. ये we made that master table in neoplasia. So H. pylori, and I'm sure majority of us would have been right in this also. So before we go further, एक बार फटाफट से देख लेते हैं क्या क्या आया। जेनेटिक्स से अपने दो क्वेश्चंस आ गए, जिसमें एक ट्रिकी था, प्रीनेटल जेनेटिक काउंसलिंग। द सेकंड वन वाज स्ट्रेट फॉरवर्ड। जेनेटिक्स से एक्चुअली तीन आए, इनकम्प्लीट पेनिट्रेंस एंड percentage analysis. These were the three questions from genetics. We had one question with respect to immunology, opportunistic infection. This was microcandidiasis, and one question was from immunology also. So this was the breakup with respect to path micro. Now, before we go further, which the paper can never be predicted. I am saying so because last year in INI exam only, we had 17 questions from microfungi, about 4 questions from path. Overall, in the INI exam, the medical subject weightage was very high. That was the trend last year. So let me rephrase. In the previous 2 years, previous 4 papers, this was the trend that we were seeing. But suddenly in this paper, medical subjects were given extremely less weightage. Majority of the questions were again from dental subjects, which used to happen earlier about 2.5 years ago. So what I am trying to tell you is nobody can predict the paper. Frankly said, if see, we can only say that this was the trend till last year. तो अगर कोई मुझसे अभी भी पूछता ना, I would have said medical subjects important है, ज़्यादा करने हैं नहीं के लिए ये वो. But this does not mean कि NEET में medical subjects नहीं आएंगे. Please don't take that as the carry home message. All subjects are important. You can give more weightage to the bigger subjects, but don't lose out on the smaller ones. अब की बार biochemistry तो आया ही नहीं था. I know. 1-2 subject questions were tricky from every subject. I 100% agree to that. But yeah, that is what makes it INI. And that is what makes the paper tricky, makes the paper unpredictable also. अभी भी रिकॉल के बेसिस पे डू नॉट गेट डिसहार्टन, डू नॉट डू दिस दैट कि यार मेरी तो रैंक बिल्कुल ही चली गई ये वो. दिस रैंक इज नॉट इंडिकेटिव ऑफ योर नीट रैंक फर्स्टली, सो डू नॉट गेट एक्सट्रीमली हैप्पी इफ इट इज गुड, डू नॉट गेट टू लो इफ इट इज बैड. सब कुछ ठीक है, एक ही पेपर मैटर करेगा अब, वो नीट वाला. Done. So this gets us to the last topic, that is oral path. Now, oral path, I know you guys know very well that Dr. Srishti takes, but her husband's best friend is getting married, and the guys were having a bachelor's in Phuket. So बाकी लोगों की बंदियों ने तो अलाउ कर दिया. सृष्टि वाज लाइक कि नहीं, देयर इज नो वे आई एम गोइंग टू लेट यू गो अलोन. सो शी वेंट विद हिम. As a result, Shivam, dental pulse and notes are sufficient. So Sarthi and Tanvi, वो मजे काट रही है लाइफ में, मतलब as usual, that is what she does. And we guys work hard. So let us start with our oral path. वैसे हमें तुम में से कितने लोग, अगर ऐसे तुम्हारा बंदा बैचलर्स बनाने जा रहे तो how many of you will allow? Very curious, very curious. Those notes, Anirambal, notes followed by MCQs is the absolute secret to success. So coming back, this starts us with our oral path. Few recall questions. Scarcity of inflammatory cell infiltrate. If the inflammation is scarce, it is seen in which of the following? Now, firstly, whenever we talk with respect to lichen planus, बच्चे lichen planus में तो मेरा first thing जो मेरे mind में आती है ना, that there is dense lymphocytic infiltrate. हाँ करना है दोस्त, पल्स बेसलाइन है, पल्स का कोई भी क्वेश्चन अपना गलत नहीं होना चाहिए. That is absolute basic. There is no doubt about it. Next, एक बार वो सॉल्व हो जाए, उसके बाद आगे सुभिक्षा भी नहीं जाने देगी, तो फिर तो ऐसे बैचलर्स पार्टी का तो मतलब ही खत्म हो जाएगा ना सुभिक्षा. बट चलो कोई बात नहीं है. सो कमिंग बैक, व्हेन वी टॉक अबाउट lichen planus, there is dense lymphocytic infiltrate where present at the dermoepidermal junction. Epidermis and dermis पे there is a band like dense lymphocytic infiltrate in lichen planus. So whenever anybody talks of lichen planus, there is dense infiltrate. This infiltrate, it is also associated with bullous pemphigoid and cicatricial pemphigoid. Pemphigoid में भी मिलता है. Subepidermal blisters होते हैं and eosinophilic infiltrate with inflammatory cells. Pemphigus vulgaris does not have inflammatory infiltrate. नम्रता एज यूजुअल नमू तो एक कदम आगे है, दोनों अपनी अलग अलग ट्रिप पे जाएंगे. तो फिर ऐसे में देख यहाँ पे तो बहुत हीरो बनती है और उसके बाद यू आर अल्ट्रा ऑर्थोडॉक्स. बट कमिंग बैक हाँ शिवम, सब लड़के लोग तो जाना ही चाहेंगे ना, बट शिवम फिर तुम बैचलरेट्स में भी तुम्हें अलाउ करना होगा. बट कमिंग बैक टू दिस, 55 female shows pain and swelling in the palate along with mobility of the teeth. I know कि जैसे ही पेन की बात हो रही है, along with cribriform or the Swiss cheese pattern, what is the diagnosis? The examiner is talking with respect to adenoid cystic carcinoma. Adenoid cystic carcinomas, बच्चे, they are extremely painful. They are malignant lesions. They are malignant. अनुज, हाँ. So they are, वो recall छोड़ो अनुज, वो हम सबको छोड़ के चली गई हैं. But coming back, adenoid cystic carcinomas, they are malignancies of the salivary gland. First question का आंसर तो हिमांशु है ना, pemphigus vulgaris है ना. It is pemphigus vulgaris. Next, अच्छा मुझे ये बताओ, when we talk with respect to adenoid cystic carcinoma, which salivary glands are affected? Major salivary gland या minor salivary gland? It usually affects the minor. It usually affects the minor salivary glands. Next, they are extremely painful due to perineural invasion. They are painful due to perineural invasion. This is adenoid cystic carcinomas. Plain and simple. So, adenoid cystic carcinoma, but it is a malignant salivary gland tumor, affects the minor salivary glands, that is of the palate. Painful है due to perineural invasion. Swelling है, mobility of teeth है. Histologically, it has the cribriform or the Swiss cheese pattern. Whenever we talk of adenoid cystic carcinoma, classical feature is the presence of perineural invasion that you very well know. And lastly, the cysts. Frankly, I do not know much about this question, but this is always the first topic. I know, pretty boring topic also, but usually asked in the paper. I think ये last time NEET MDS में भी पूछा गया था. There is always a question on cyst. That is, patient presented with the swelling in the mandible, showing the presence of duct-like structures with hyaline ring, with reversal of nuclear polarity. But all these reversal of nuclear polarity, that is, normally nuclei are present towards the lumen. Now they are towards the base. There is reversal of nuclear polarity with presence of hyaline ring and duct-like structures is adenomatoid AOT, adenomatoid odontogenic tumors. Plain and simple. Adenomatoid odontogenic tumors, they are usually seen in the second and third decade of life. That is, they occur earlier in life. All these were the points which were taking us towards AOT. All these are the features. That is, adenomatoid odontogenic tumors, they show rosette-like arrangement of cells, duct-like structures, reversal of nuclear polarity, hyaline material, and also shows calcifications. These were the points which were given in the question, commonly seen in young patients, that is second to third decade of life. Males, females? Female. Always, we usually think with respect to females. Females predominant may occur in maxilla. Plain and simple. Plain and simple. So this was, whereas the others, usme duct-like structure nahi hai, dentigenous cysts, there are again no duct-like structures. These three show there are no duct-like patterns. There are no duct-like patterns. Done hai bache. Absolutely and absolutely done hai. So needless to say, bestest of luck for the paper, in the sense that I'm going to say for the paper and not for the result. कोई बात नहीं, जो भी रिजल्ट होगा समझ लेंगे, संभाल लेंगे. नीट एग्जाम अभी 2-3 महीने दूर है. रिकॉल देख के लगता है बहुत अच्छे कोई बात नहीं. Shivam, actually, you have said it right in this manner. This is because marks अपने सही आ जाते हैं, but in the end, you are competing with each other firstly, and number of seats are extremely low, especially in INI. So, कोई बात नहीं है, टेंशन नहीं लेनी है, बिल्कुल टेंशन नहीं लेनी. Last 2.5 3 months to go. Last 3 months actually, क्योंकि नवंबर चल रहा है, दिसंबर, जैन, फेब, मार्च में तो पेपर हो जाएगा. There is absolutely no doubt about it. So give this your best shot. Do not, yes, have a proper break. कल क्या क्या किया? How many of you actually went out, had a nice dinner, this that? I'm very curious. देखो यार, पढ़ने तो एकदम बैठ नहीं सकते. वी आर नॉट रॉबर्ट्स की कल पेपर दिए एंड दोबारा से पढ़ने बैठ जाएंगे. टेक अ ब्रेक, टेक अ 1-2 day break. It's absolutely okay, but don't stretch that 1-2 day break to 1 week. That is all I want to say. Keep on slogging and the end result will be much better than what we expect. Thank you guys. Thank you and take care. ऋषभ, मैंने बंद कर दिया, मुझे समझ नहीं आया था बंद कैसे करना है.
Yes. Oh, very good afternoon to all of you. Okay. Yes. So, hi everyone. A very good afternoon. Yeah. Good evening, Dr. Vishnu. Yes, Dr. Vishnu. Good evening. I hope you people have given a very good exam. Yeah. Hi, Dr. Lucky, Dr. Vishnu. Yes, Dr. Anirvan. So, guys, how was your exam? So, what about the level of the exam? So, we have done a poll also in our WhatsApp group, and even we have taken the feedback from other students also. The overall is like moderate exam. It's not very difficult exam. It's a moderate exam. Only thing is, you people were not supposed to make any silly mistakes. So, silly mistakes were not accepted in this exam. Otherwise, the exam level was moderate as usual. That's the AIMS exam. Yes, moderate level was there. Yes, a very good afternoon to all of you. Yes. So let's start with the pharmacology questions. So if we talk about the pharmacology question, total 9 questions we are able to gather, right? So total 8 to 9 questions are there which we are able to gather in this exam. And this time, like I would say, the pattern of questions they used to ask the clinical questions, but this time all of a sudden they have given a twist to these questions. The 2 questions they have asked, that is not clinical, that's a fact based question. So 2 questions were fact based, most of the like rest of the questions were clinical. So I don't know why they have put these 2 questions. So this time there is no surprise question, there is no difficult question. All questions were moderate. The only thing is there are 2 fact based questions, not clinical one. Starting with question number 1, this is typically based on the tuberculosis drugs. I just want to know uh, from you people also, like, was this question asked in the exam and were the same options given in the exam? The same question was there and the same options were there, or there is some difference in the options? Anyone who has given the exam? Yes. So this is the treatment of tuberculosis. They are asking which drugs are properly matched. Okay. Yes, so this is the typical question. I would like to share the reference with you people also. Uh, I have taken the reference of this question from Park and Park. Guys, give me 1 minute. Actually, there is some problem at my end. Yes. Okay, so same drugs were there. So guys, this is a kind of a old classification of MDR-TB. So MDR-TB ka old classification is there. So according to this MDR-TB, the HNR cannot be given. So as per the definition of MDR-TB, HNR cannot be given to a patient, and they have clearly mentioned the patient is MDR-TB or rifampicin resistant TB. So it's a rifampicin resistant TB or MDR-TB. So after that, we have to give medicines, and now we can classify these medicines on the basis of groups like group A, group B, group C. So although this is the old classification, like these days, this kind of classification nobody follows. But if we assume that they asked a question from the old classification of WHO, so they have 3 types of medicines: group A, group B, group C. So linezolid is a correct option. So linezolid belongs to group A, right? And even this moxifloxacin belongs to group A. So fluoroquinolones, linezolid, these two medicines belong to group A. Now, apart from that, we have a drug bedaquiline. So bedaquiline is one more medicine that belongs to this group B. Sorry, group A. Sorry, please make a correction. Actually, there is some problem at my end. So in group A, we have fluoroquinolones, we have linezolid. In group A, we have fluoroquinolones, linezolid, and bedaquiline. So here they have given the moxifloxacin. Moxifloxacin belongs to group A, not group B. So this is a false statement. This is a correct option. Now, ethambutol and pyrazinamide. Ethambutol, pyrazinamide, right? So ethambutol, pyrazinamide, delamanid. So these are the some other examples of medicines which belongs to group C. So this is also the correct option. So ethambutol belongs to group C as per the classification. And the drug name is clofazimine. Clofazimine belongs to group B. So we have a medicine like clofazimine. We have a medicine like clofazimine. We have a medicine like cycloserine. So they belongs to group B. So this is also the correct option here. So this is an old classification they have asked. I don't know why they have asked this old classification. So 2, 4, and 5. These three options are correct here. So these three options are correct here. 2, 4, and 5. So 2, 4, and 5, these three options are correct. So there is no such option they have given. So what is the best possible answer here? So what is the best possible answer? I think the answer will be 2 and 5. So this is the correct answer, 2 and 5 here. Now I just want to ask from you people whether they have given the same options or not. Okay, according to Dr. Hirdesh Kumar, 5 options were not there. Only 4 options were there. Dr. Shivam Sahani, 2, 4, and 5 are correct. That's fine. But in this MCQ, were these options like this is a multiple choice question? So 2 and 5 are the two possible answers which we can find out of. There is no option like 2, 4, 5. So answer is 2 and 5. So classification is from your Park and Park, like the medical book. Okay, so question number 1 based on an old classification of WHO category. So question number 2, this was a repeated question, like this is a PYQ, even last year also. They asked the same question. Patient is on some antibiotic therapy. Now patient has got some white patches in his mouth. Now which medicine we can try? What is the condition? So same way they have asked, the patient is having a diabetes. Now patient was taking some amoxicillin and patient is also having a bronchial asthma. So he must be taking steroid also. The diabetic patient on steroid therapy, having a pyuria, having a UTI, increased frequency. So this is the Candida cystitis. Cystitis means the UTI, bladder infection. So what will be the drug of choice? So what is the answer, guys? Okay, first of all, tell me, were these options correct? Were these options there in the exam or not? First is oral fluconazole. Second is oral itraconazole. Third is nystatin. And the fourth option is non-antifungal. Dr. Shivam, can you please tell me what was the fourth option? What was the fourth option that was there? Like one was oral fluconazole, second was oral itraconazole. Nystatin is the drug that is given by the local route. Nystatin is given by the local route, but they asked the drug of choice. So what was the fourth option? Anyone can recall the fourth option? So what was the fourth option they asked? Anyone can recall? Anyone can recall the fourth option? Okay, none of you can recall. It's fine, guys, no problem. So what is the answer you people have marked? So I think most of you marked this simple direct answer, oral fluconazole. So oral fluconazole is the direct answer. It's a candida infection and it's a uncomplicated, like the infection is present in the bladder, not ascended towards the kidney, because once it has gone to the kidney, they start calling it pyelonephritis, then the conditions are different. So the condition is still present in bladder. So oral fluconazole is a best answer to be marked. Okay, Dr. Raftar Singh is saying they have given us the IV, intravenous, not oral. Yes, fluconazole is a drug of choice. This is the answer of this MCQ. Basically, fluconazole we have to give for cystitis or candida infection. That's fine. Okay, oral terbinafine. So the last option was oral terbinafine. So last option is oral terbinafine. So oral terbinafine is not the answer of this MCQ because terbinafine is mainly given for the dermatophytes infection. Okay, one option is fluticasone. No, guys, Shivam, fluticasone is a steroid actually. Fourth option is oral terbinafine. One is itraconazole, one is fluconazole, flucytosine. Okay, yes, flucytosine is a medicine. That's an antifungal. It's a oral medicine. That's fine. So oral flucytosine, oral terbinafine are two options. One option is itraconazole, one option is fluconazole. These are the four options according to you people. So nystatin was not there. Nystatin was there or not there? Can you please confirm me? Out of these five options which I have written over here, which option was not there? Which option was not there out of these five? Anyone can recall? Which option was not there? Fluconazole was there or not there? Itraconazole, nystatin. Nystatin was there or not there? Can you please confirm me about nystatin? Anyone? Nystatin was there or not there? Anyone can confirm? It was there. So nystatin was there. So Dr. Muskan, can you, Dr. Mukund, sorry. Dr. Mukund, can you please confirm me which option was not there? Which option was not there out of these five? Why not B? Dr. Raftar, whenever we have the candida infection, we mostly start our treatment with fluconazole. And if the fluconazole is not able to manage, then we put patient on itraconazole, okay? Or itraconazole can be an alternative drug, right? So here the answer is itra was there, fluconazole was there. Terbinafine was not there. So according to you people, terbinafine was not there, flucytosine was there. Fine. Okay, so these are the four options. Nystatin, flucytosine, itraconazole, fluconazole. Overall drug of choice for candida is fluconazole. So answer is fluconazole. Let's move on to the third question. Which of these is an orally based bisphosphonate? So this is a bisphosphonate. So which is a bisphosphonate given for osteoporosis given by oral route? So this we have discussed during the exam also. Okay, so Dr. Komal is saying nystatin was itraconazole was not oral, it was IV. Okay, so itraconazole they have given as IV. So guys, in this case, the patient is having a uncomplicated. So this is what I told you. Cystitis means the infection is present in the lower part of urinary tract. It is present in bladder, not ascended towards the kidney. So this is an uncomplicated UTI. And uncomplicated UTI may there is no need to give medicines by IV route. And also our patient is not admitted in hospital. So here we can say that we have to give the medicines by oral route. So oral is the best answer. Statin is given by the local route. We don't give it for UTI because it's not possible to give the local medicines for UTI. So that is not an answer. Itraconazole IV is not an answer because here the patient is stable. And fluconazole is a medicine that we use for the treatment of this condition. Flucytosine is a reserved medicine only given for cryptococcal meningitis, serious infection, not given for this kind of uncomplicated infection. That's why here the overall answer is fluconazole. Question number 3, which is a orally based bisphosphonate treatment of osteoporosis? So we know that bisphosphonates are the best medicines, drug of choice for osteoporosis that we all people know about this thing. So we discussed this thing in our class also that zoledronate is a medicine that is given by IV route. But rest of the three medicines can be given by oral route. So here I want to know from you people, was this question multiple choice based or single answer based? This question was multiple choice question or a single answer question. So question 3, three medicines we can give by oral route: ibandronate, risedronate, alendronate. So during the class also we have discussed this thing. These three medicines given by oral route, and zoledronate is the longest acting medicine that is given by the IV route. So this is the longest acting medicine given by IV route. It's a fact-based question. Like I don't know why they have asked this question. Like in last 10 years, there is no single MCQ where they have asked the drug ka route of administration. What's the rationale of asking the route of drug administration? This is a fact-based question they have asked. Which drugs are given by oral route? The single answer. Okay, Dr. Sandalwood is saying there was an option of pamidronate. Yes, doctor, pamidronate is given by IV route. So zoledronate and pamidronate, these two medicines are this is the second longest acting medicine. Like zoledronate is longest acting, palmidronate is second longest acting medicine. This is given by IV route. And what about the other options, guys? Palmidronate is given by IV route. It cannot be the answer. So they are asking which drug is given by oral route. So alendronate, risdronate, ibandronate. Three medicines written over here which are given by oral route. So, like, can you please tell me which option was not there in the class in the exam? Which option was not there out of these six drugs we have written over? Okay, palmidronate you have confirmed that this was there, so this is done. ये तो है, right? Now, what about the other medicines? Ibandronate, zolendronate, risdronate, alendronate. Which medicine was not there? Which medicine was not there in the exam? Okay, zolendronate was also there. Zolendronate was also there. Palmidronate was there. And what about the ibandronate and risdronate? So three medicines we can give by oral route, guys. Here, alendronate, risdronate, ibandronate. Maybe the examiner get confused. Examiner want to ask. Alen was not there. Okay, so this is gone. So this option was not there. Alendronate was not there. So this is gone. So ibandronate, risdronate, these two options were there, right? Okay, so if you ask me, sir, if you have to mark one, I will go for ibandronate. Ibandronate will be the better answer. Ibandronate will be the better answer in that case, because that is always be given by oral route. But risdronate is also by oral route. Okay, D is not there, Priya. Thanks for the confirmation. So guys, please check the options here. According to me, A and C both are the possible answers. Zolendronate, palmidronate, they are given by IV route. So ibandronate, if this is not a multiple choice question, the best answer will be ibandronate. Second best answer will be the risdronate. But if this is a multiple choice question, A and C both are possible answers. Okay, that's all about this question number 3. It's a fact-based question. Question number 4. Now, this is a phenytoin anti-seizure drug and it is not given for with seizure. So guys, this is a fact-based question again. I don't know why they have asked this time so many fact-based questions. Phenytoin is not approved. Like we have done animal studies, animal trials, and in animal trials, it has been found that like it is a broad spectrum drug. So all broad spectrum medicines are useful for any kind of seizure. And this is also a broad spectrum medicine. Ideally, this should be active against all type of seizure. But because of some unknown etiology, unknown reason, this is not useful for absence seizure. So phenytoin is not useful for absence seizure because of unknown reason. This is as per the animal trials. So again, a fact-based question. This time, I don't know, they're not checking their knowledge, they're checking like how many facts you know about the pharmacology. So I would say not a good quality question they have asked this year. Every time AIMS people used to ask very good clinical question, but this time they have, I mean, they have performed with below par their perform below par their expect below par the expectations what we have from them. So medicine is a broad spectrum drug. We can use it for focal seizure. We can use it for grand mal seizure. According to one student, sir, this option was not there. He said, "Ki, sir, instead of this, they have given the petit mal seizure." So, guys, can you please confirm me whether they gave you petit mal or they gave you just a secondary generalized seizure? Okay, in options 1 and 3 was one. 1 and 3 was one option here. So, can you please tell me what is not there out of petit mal and secondary generalized seizure? So petit mal is actually the other name of absence seizure. It is the other name of absence seizure. So guys, yes, this is what Dr. Joe Smita, secondary was there. Grand mal seizure नहीं था. Okay, ये seizure नहीं था. Grand mal seizure is GTCS actually. So maybe they have given the other name. Guys, petit mal was there or not there? Petit mal was there. Petit means small, like the seizure of the small people. The children का seizure है absence seizure. थर्ड ओनली वाला ऑप्शन नॉट देयर. ओके, ये ऑप्शन में ही नहीं था. ओके, सो दिस इज गॉन. सो दिस इज नॉट in the option. Okay, Dr. Joe Smita is saying petit mal was also not there. So this is also gone. Okay, secondary was there. Yes, it is given for secondary generalized seizure, guys. This is correct answer. It is given for that seizure. It is given for focal seizure. What was the fourth option then? देखो ये तो confirmed है. It is given for focal seizure. It is given for generalized seizure, and it is also given for grand mal seizure, which is a type of generalized seizure. So you people are saying that grand mal option was not there. So what was the option? Can you please recall? Can you please recall? So it is not given for absence seizure. What was the other option, guys? So I have removed the only three. Then ये दोनों same है, guys. You people have to understand these two are same. Option 2 and option 4 are almost same thing. So in that case, if these were the four options, then the answer will be 1 and 3. So उसमें answer आ जाएगा 1 and 3 because focal seizures में generally we don't give broad spectrum drugs. Okay, so Mukund Ram is saying, Mukund Ram Prasad is saying कि grand mal seizure was there. ठीक है, तो 2 and 4 में the drug is useful, 1 and 3 में the drug is not useful. The reason is focal seizure में practically we prefer broad spectrum medicine. But if you ask me the approvals, if you ask me कि sir where do we use phenytoin, so phenytoin is approved for focal seizure as well. Okay, focal was there, GTCS was there, absence was there. हाँ तो ठीक है guys, so 1 and 3 will be the best answer. So this is the best answer, and 3 is not a separate option. 3 and 3 is not a separate option, so answer is 1 and 3. So focal seizure में we don't prefer clinically. Okay, so let's move on to the fifth. Question number 5. A patient with ischemic heart disease diagnosed with Parkinsonism, and he was started with levodopa, and everybody knows levodopa becomes dopamine in the body. Levodopa becomes dopamine in the body, and now the patient ka anginal episodes has been increased. What is the mechanism? So guys, I'm a bit doubtful whether this question was exactly asked or not, because answer is straightforward, dopamine here. Anything like do you say that the same question, same options were there? Patient ko you have given the levodopa, it is converted to dopamine. Dopamine will act on beta 1 receptor of the heart, and by acting on the beta 1 receptor of the heart, this can stimulate the heart and can put more load on the heart. This can cause stimulation of the heart and can put more load on the heart, and this will precipitate the anginal episode. So that's a theory actually. Okay, so Dr. Anurag Chaudhary is saying here the options are wrong in the questions. Question was asked, but not the options. Okay, so what were the options, guys? Direct action on the cardiac dopaminergic receptor was an option. Yes. So it is a direct action. It is a direct action of dopamine on cardiac receptors. It's a direct action of dopamine on the cardiac receptor. So this was the correct answer. So DA means the dopamine. So direct action of dopamine on the cardiac receptor, that is a beta 1. Yes, this was the answer. This is the answer of this MCQ. So the same thing they want to say, if the drug is converted to dopamine, dopamine has a direct effect on cardiac receptor, that is through the beta 1 receptor. So we discussed this point in autonomic system, that dopamine in dose more than 2 microgram, this will start acting on heart and can stimulate the heart, can result in tachycardia and all. So this was the answer of this question. Yes, this was the answer. What were the other options, guys? What were the other options, Dr. Anurag Chaudhary? Anurag, any idea what are the other options apart from dopamine? Apart from this option, direct action of dopamine on cardiac receptor, what are the other options? What are the other options in case you can recall? So, okay, guys, in case you will be able to recall any other option and you think is, sir, like whatever presentation we have given you, the options were not included. So you can also message us later on also. So we keep on updating our question bank for you people. Another option was beta receptor, stimulation of beta 1 receptor. Okay, one option is stimulation of beta 1 receptor. So this is again a more specific answer. This is a more specific answer. देखो उससे better answer ही निकल के आएगा. So this is the better answer. Stimulation of beta 1 receptor is the better answer. So levodopa converted to dopamine. Dopamine will act on beta 1 receptor, stimulate the heart, and can put more load on the heart, and this will worsen the anginal episodes. This will worsen the anginal episodes. This is the better answer. So stimulation of beta 1 receptor is a better answer instead of the direct action, because levodopa will not directly act on dopamine receptor. It's not the direct action on the cardiac receptor. So levodopa will not act directly on the cardiac receptor. It will first of all convert to dopamine. Now dopamine will act on beta 1 receptor later on. ठीक है, तो levodopa का as such, levodopa is a inactive form. This is an inactive form of dopamine. This cannot do anything. It is first of all converted to dopamine in the body, and dopamine will act on beta 1 receptor. So this is the better answer. So what are the other two options? Like two options you are able to recall, and we have able to find out the best answer. What are the other options? Yes, Dr. Lucky Bora, your answer is correct. Lucky Bora का आंसर करेक्ट हो गया guys. चलो पार्टी है आज. Party. Dr. Lucky will give us the party. Okay, Dr. Numsword also saying the same. In case, guys, you are able to find out the other options, please give it to us, right? Okay, this is a straightforward question. Which drug is not given in pregnancy? And this we have discussed so many times during our lecture also. Yeah, hypertension में we don't give AC inhibitor ARBs. So in hypertension, we don't give AC inhibitor ARBs. These medicines are strictly contraindicated. This is one of the strong contraindication. But here I would like to ask from you people, are these options same they asked in the exam or not? So even in UTI, we don't give this cotrimoxazole. This is a cotrimoxazole. This medicine is a folic acid pathway inhibitor. So we don't want to give any medicine that is inhibitor of folic acid pathway in pregnancy. Folic acid pathway inhibitors को we don't give in pregnancy because pregnancy में we don't want to block the folic acid pathway. Otherwise, in malaria, the safest medicine is chloroquine. Hypothyroidism, thyroxine tablets are safe. और epilepsy में levetiracetam is the safest anti-epileptic to be used. So 2 and 3 are the medicines which are for thyroid. It is not mentioned. Okay, PTU was mentioned. Okay, thanks for the confirmation, Dr. Shivam. So hypothyroidism में PTU, Dr. Shivam, was it hyperthyroidism or hypothyroidism? Okay, so Joe Smita is saying hyperthyroidism. Okay, yes, so this is also correct, guys. Hyperthyroidism का drug of choice है. In pregnancy, the drug of choice for hyperthyroidism is propylthiouracil. Propylthiouracil is the best medicine for hyperthyroidism. So this is also a correct. Adrenergic receptor. Okay, so Hriday is saying adrenergic receptor. In the previous question, okay, so this is PTU. Hyperthyroidism, PTU. Epilepsy में levetiracetam is safe. Malaria में chloroquine is safe. UTI में cotrimoxazole, ACE inhibitor, ARBs. These medicines are contraindicated. So answer is 2 and 3. So are these other options? Are other options correct here or not? Can you please confirm me? Okay, so now the one more fact-based question they have asked. Which of these potassium-sparing diuretic has the longest action? I don't know why they are asking this longest shortest action. Like there was a time, let me tell you, 20 years back. 20 years back, they used to ask कि कौन सा drug longer है, कौन सा drug shorter है. Now again in 2025, they are asking the same type of question, which is a longer acting, which is shorter acting. So answer is spironolactone here. So spironolactone is a medicine. This is the one that will take long time to recover. This medicine is converted to some metabolites like kendrenone is one metabolite. It has a one more metabolite 7-hydroxy spironolactone. So multiple metabolites are there. So it will take very long time. This will take 3 to 4 days to get eliminated from the body. So this medicine, it will take 3 to 4 days to get eliminated from the body. It's one of the very long acting medicine. So this was the question they asked. So the 4 names of potassium sparing diuretics they have given you. Again, a fact-based question which has no clinical relevance. Because practically whatever be the elimination does not matter. We have to give medicines on daily basis. हमें medicine daily देना ही पड़ेगा. Rather जो Aldactone है, I mean the spironolactone is a drug. The brand name is Aldactone. This medicine can be given 2 times daily. So this point has no clinical relevance. Just a fact-based question. Spironolactone has the longest half-life. No discussion required. Now, which medicine will act on T type of calcium channel? So there is a T type of calcium channel. So which medicine will act on T type of calcium channel? So we discussed this point already. Anti-epileptic ethosuximide. So ethosuximide is a medicine. It's a PYQ actually. This is a PYQ. Ethosuximide is a T-type calcium channel blocker. Rest of the medicines are L-type calcium channel blocker. So rest of the medicines are L-type calcium channel blocker. Here the verapamil is a drug. This is inhibitor of L-type, T-type as well as N-type of calcium channel blocker. So this is blocker of all the three type of calcium channel, L-type, T-type and N-type. But ethosuximide is exclusive T-type calcium channel blocker. Ethosuximide is exclusive T-type calcium channel blocker. Okay, according to you people, one of the option was cilnidipine. Cilnidipine was there, Dr. Shivam is saying. So, Dr. Shivam, cilnidipine was there according to you. Which drug was not there out of the above four? Out of above four, which was not there? So, one was cilnidipine. This was there in the MCQ. But which option was not there? Can you please tell me this thing? Because I have to update my question bank also. So, ethosuximide is the answer. All options are dipine drugs. Acha, all options were dipins, तो verapamil was not there. Okay, fine. So this is quite easy question for you, है ना? सब dipins हैं तो dipins तो like you can easily rule out. All dipins are L-type calcium channel blocker. Ethosuximide has different spelling. So Gautam is saying ethosuximide was not there. Now this is surprise to me. What was there? Okay, Shivam, ethosuximide was not there. Okay, then which drug was there? कौन सा drug था guys? Anyone? Okay, I will give you options. I will tell you the names of medicines which are T-type calcium channel blocker. Was this medicine there? Flunarizine. Was this medicine there? Flunarizine. Flunarizine is a T-type calcium channel blocker. According to you, ethosuximide was not there. So this is again a surprise. So flunarizine was there, guys. Can you please tell me? This is a migraine ka drug. Acha, all dipins were there. All medicines which are dipins, these medicines were there. Even the fourth medicine was also there, guys. Fourth medicine was also dipin. अच्छा, all names were dipin only. So so कौन सा ऐसा dipin है जो T type calcium channel blocker है? This we need to find out. This we need to find out. Verapamil नहीं था. One was cilnidipine, one was amlodipine, one is nifedipine. Which was the fourth one? Okay, सारे dipin थे इसमें. So this is gone. So which was the fourth dipin? So even I don't know the answer of this MCQ, frankly speaking. कि कौन सा ऐसा dipin है जो T type calcium channel blocker है? So which dipin is T type calcium channel blocker? This I need to find it out. But just tell me one thing. What was the fourth option? Which dipin was given as a fourth option? One was nifedipine, second was amlodipine, third is cilnidipine. Which was the fourth option? Cilnidipine के अलावा what was the fourth option? Guys, ऐसा कुछ option था nimodipine, because nimodipine is a drug which has some activity on central nervous system. अच्छा, it starts with U. Benadipine. Benadipine was the option according to you. Benadipine. So Benadipine तो मुझे भी नहीं पता कौन सा drug है, frankly. Sorry for that. According to you, there is a drug azelnidipine. So guys, this question I need to find it by myself also, because even I don't know the answer of this MCQ. Sorry for that. But this is good that after discussion we come to know about the various options. According to Dr. Lakhi Bora, nimodipine was not there. So nifedipine, amlodipine, cilnidipine, and out of benadipine and azelnidipine, one drug was there. So this we need to find it out. Okay, next question. This is based on first order kinetics, and we know that in first order kinetics, all pharmacokinetic parameters are constant. So all pharmacokinetic parameters are constant in first order kinetics except the rate of elimination. So rate of elimination is something that is variable. All pharmacokinetic parameters are constant in first order kinetics. So can you please tell me the graph that was asked to you in the exam? Was the graph between dose versus plasma concentration or the dose versus half-life? What was the graph? This I want to know from you people. Because if this is a first order kinetics, if we assume it's a first order kinetics, so if we increase the dose of the medicine, तो जो half-life होगा, this remain constant. Half-life remain constant. The graph should be like this way, right? This is a first order kinetics. Zero order kinetics में everything is variable. In zero order kinetics everything is variable. So half life जो होगा वो increase करेगा. Half-life will increase when you increase the dose in zero order kinetics. So this is first order if the T half versus dose. Okay, so Dr. Tejas, thanks for confirmation, guys. अच्छा इसमें एक पिरामिड जैसा था. Okay, these were these four options there? ऐसा कुछ था? Okay, saturation elimination was there, not the first order. Okay, तो स्टोरी बिल्कुल चेंज हो गया फिर तो. Saturation elimination था. Guys, can you please confirm me whether it was saturation elimination? Zero order kinetics था कि first order kinetics था? Can you please confirm me? Was this question based on saturation elimination or first order kinetics? Can you please confirm me? ये फर्स्ट ऑर्डर पे था और जीरो ऑर्डर पे सेचुरेशन पे था. कैन यू प्लीज कंफर्म मी whether the question was based on saturation kinetics or first order kinetics? This you people have to confirm first because accordingly I will tell you the answer. अच्छा एक पिरामिड था अप एंड डाउन. अच्छा ये क्वेश्चन था फर्स्ट ऑर्डर काइनेटिक्स पे. इट्स नॉट ऑन द जीरो ऑर्डर. Saturated eliminated first order. Okay, was this question like this way कि initially it is first order kinetics, now later on it gets saturated? Was this concept was there कि first order था, gradually it is getting saturated? First order with saturation. Okay, तो ये होगा ना कि initially वो first order है, then gradually it becomes second order. Gradually it becomes second order. Transition हुआ, yes, transition हुआ कि initially it was first order and gradually it will become zero order. Gradually it will become zero order. Yes, so initially it was first order kinetics, gradually becomes zero order. So what happens to the half life? So half life initially remain constant. देखो initially वो first order है, this will remain like this way, and later on the half life will start increasing. The half life will start increasing. So up till here it is first order, and now it is zero order or saturation kinetics after that. So this is a saturation point. Okay, so initially वो first order था, and gradually it becomes saturation kinetics. So this is the graph of showing the first order, the straight line. This is the half-life. Half-life remain constant initially according to the dose. So dose you will increase on x-axis. The half-life in first order remain constant. And after some time, when the saturation will occur, when the zero order kinetics will start, this will start increasing. Half-life will start increasing. So this should be like this way. तो ये आंसर ऐसा कुछ ग्राफ था तो ये आंसर होगा. And according to you कुछ पिरामिड दिया हुआ था. According to you people some pyramid was given. Like ऐसा कुछ पिरामिड था. और this was the answer like in case it is there. Amlodipine is not there. Dr. Hirde. अच्छा ये था ही नहीं. This graph was not there. Okay, just tell me, do one thing. I am there with you on the Telegram group. So in case you can draw the graph by yourself because you are saying कुछ pyramid type था. According to some you people, initially increase, then dot dot dot. Okay. Okay, so just okay. Anyways, no problem, guys. ये question this remain on me. Two questions are on me because last two questions I have kept the difficult one. The eighth one I will tell you the answer कि which dipin has a T-type calcium channel blocking property because all dipins are mainly L-type calcium channel blocker. But which one is T-type calcium channel blocker? This I will find it out for you and give you the answer. And this question pyramid इस तरह से कुछ था कि initially the half life will increase, then the half life will decrease. तो ये नहीं हो सकता आंसर. This cannot be the answer. Triangle type. Okay, guys, do one thing. Whatever be the graphs given to you in the exam, just make it on the paper. Right? And share it on the Telegram group. I will see that. I will see those graphs and give you the correct answer for that. Okay, no problem at all. This happens actually because नो सर, जो आपने ग्राफ बनाया वो था। ओके, तो ये फिर ये आंसर होगा। अगर पहले जीरो था तो वो अकॉर्डिंगली होगा, लाइक अगर फर्स्ट दैट इज फॉलोइंग द जीरो ऑर्डर तो पहले ऐसे होगा, देन इट बिकम स्ट्रेट। तो ये फर्स्ट जीरो हो गया, ये फर्स्ट ऑर्डर हो गया, ट्रांजिशन हो गया। यहाँ पे देखो, दिस इज अ ट्रांजिशन। तो वट एवर वॉज द वैल्यू गिवन टू यू अकॉर्डिंग टू दैट कॉन्सेप्ट, इफ यू नो देन द थिंग्स आर इजी। Anyways, guys, chalo, let's wind up this topic. Let's wind up this session. The sir is waiting for us. The next faculty is waiting. So, you people have to provide me the photographs of 4 graphs that is asked in your exam. So, accordingly, I will give you the best answer for that. Take care of yourself, guys. We'll meet again soon. Bye. All the best for your results.
Thank you, Saurabh, sir. When I was listening to your class throughout, it was a wonderful explanation indeed. And you make the concept so simplified and so interesting for the students. So, but I am the most happiest faculty here, sitting here since yesterday, waiting to discuss the questions. Uh, Hope all the students are with me. As a general surgery faculty, I feel so happy that in a way I'm very sad because only 4 questions I could recollect from the session, but all the 4 were directly from the my class notes. In fact, one of the questions were my class same question I had discussed in the class as well. So we'll discuss them one by one. So meanwhile, once again, I want to congratulate all my students for successfully completing the exam and waiting for the best. Meanwhile, if you have any questions or if you could recollect any more questions, please let me know. We'll discuss at the end. So first question, what I could recollect was, which of these tumors involves resection of the nerve and nerve canal in the management? So during treatment or during surgery, which of the following tumor involves resection of the nerve? That means which nerve usually involves which tumor, which malignancy has got propensity to involve the nerves? That was the question. So options were squamous cell carcinoma, adenoid cystic carcinoma, melanoma, and chondrosarcoma. Okay. So with this we are directly discussed. There is no doubt about doubt in this question. Squamous cell carcinoma, although has got some propensity to involve the infiltrate into the nerve, but not so common. It's not the characteristic feature of this carcinoma. So this is ruled out. Okay. Melanoma, it's a skin cancer and it involves only the epidermis and some part of dermis. So even that also can't infiltrate into the nerves. Okay, melanoma. And chondrosarcoma involves mainly cartilages. So it arises from the cartilages. So it's very far away from the nerves. So that's also ruled out. So by ruling out all other 3 options, we come to the conclusion that adenoid cystic carcinoma is a type of salivary gland tumor. See, this is my screenshot from my notes. We had discussed most common salivary gland tumors in that one in one single chart. I had discussed about all possible questions. In that, if you see, one question we had discussed, the most common response to radiotherapy among the malignant tumors. The answer was adenoid cystic carcinoma. In that, I told adenoid cystic carcinoma is most common in among the smokers. Okay, and it mainly involves the submandibular gland. Okay, see that the question we had discussed here. Most common malignant tumor in submandibular gland is adenoid cystic carcinoma. And that time I had told you this is more prone for nerve involvement or perineural invasion. This mainly involves the whichever nerve in the sublingual nerve or if it's a parotid facial nerve. It has got more propensity. Yes, correct. What you're all answering is correct. NAMS, Vishnu, or perineural invasion. Excellent, Priya. So, okay. So this is the directly from the notes and we had discussed from the class. So if you want to see the exact my class notes, see during the discussion, I told you about this adenoid cystic carcinoma and involvement of nerve. Okay. So I think all of you have got this right. SCC, second best answer, Shivam. Okay. It's not the most commonly which involves the nerves. But adenoid cystic carcinoma, as you all know, it's a very aggressive tumor and it can locally infiltrate into local structures. Okay, mainly the nerves. So that was the first question. I'm very sure you all got this right. Second question, and for which we had given one separate session, and we had discussed so many questions based on this topic. And this was expected question also. Last year also there was question. This year also they had asked a question on oral cavity malignancy staging. I had told you in the class only one malignancy staging will be asked to you in exams, that is oral cavity malignancy. And the question was very simple, very straightforward. Four TNM classifications were given. Select the correct answer from the given below code. Okay, so stage 3 oral cancer. Which of the following TNM classifications belong to stage 3, they had asked. So T1, N1, M0, T2, N1, M0, T3, N1, M0. Any N1, that is third stage. Okay, and T3, N0, M0 also a part of this thing, third stage. See, we had discussed this in the class. This one AJCC classification of oral cavity malignancy, 8th edition. In that, if you see here, in the third stage comes the T3, N0, M0. Okay, once the tumor becomes T3 more than 4 centimeter, okay, it becomes third stage, and any T1, T2, T3 with N1, if the ipsilateral node is involved, okay, then that means it is third stage. Okay, so this was a direct question, and we had a bet on this also. The question will definitely come. So that is as expected. If you want to see from our class discussion, see, this was our discussion. I had given 5 stars on this this particular table. If you can see, check your own class notes. This particular table for oral cavity malignancy, all the options were stage 3. Yes, correct, Nams. Very good. Okay, all the 1, 2, 3, 4 all belong to stage 3. Very good. Okay, this particular chart in the entire class carried maximum weightage, and the question also came from that only. Okay, so very straightforward question. I think we all got this right. Any doubts? Any doubts so far? Okay. Another question, the third question, it was a practice question I had given to you in the class. After the discussion, I had given you this as a practice question. Same question, ditto question was repeated. Okay. A patient presented with the ulceroproliferative region on the lateral border of the tongue. Okay. We understand it's SCC of the tongue. Biopsy reveals SCC. Okay. Which of these is the most important prognostic factor? Correct. So options were depth of invasion, perineural spread, location, whether where it is present, or histological differentiation grading. All the 4 are important. They are all important prognostic factors. But for SCC of the oral cavity, the most important. Very good, Divakar. Very good, Samima. Very good. Priya, excellent. Okay. Very good, Divakar. Okay. So it's depth of invasion. For oral cavity malignancies, it is depth of invasion. Histological grading also matters. Okay, well differentiated or moderately differentiated, all those things matters. Perineural invasion also, all those things matters. But for the prognosis purpose, we consider the depth of invasion. That's why if you see in oral cavity malignancy TNM staging, in all other malignancies, they only consider the size. But here you see the depth of invasion also separately mentioned. Depth of invasion also equally significant here. Okay. So in all the T staging, they consider the size as well as the depth of invasion. Okay. So see, same question I had asked you. Same question. This is from my practice questions for after your class. If you remember, after every class, we used to have a lot of MCQs discussed. So one such MCQ was in your INICET question as well, which is the single most important prognostic factor in oral SCC. I had asked you. So size of the tumor, depth of the invasion, site of the tumor, histology subtype, same, right? So in that, depth of the invasion was the answer, and more than 4 millimeter has got of depth of invasion has got high risk of nodal spread, which has got poor prognosis. You want to see how many questions we are discussing? This was the case-based MCQs after oral malignancy class. We have discussed. I remember you answering so many questions based on TNM staging, right? See, stage 3. In that we have discussed all the stage which all belongs to stage 3. याद है? याद आ रहा है अभी? स्टेज 3 के बारे में कितना क्वेश्चन हमने सॉल्व किया था? ठीक है? So in that, the last question, whatever we discussed was about the prognostic factor indicator, that is depth of invasion. Okay, lateral and ventral, that doesn't matter anyway, site doesn't matter, whatever it is, wherever it is, doesn't matter. Clear? So what Shubham Sunil is telling, lateral and ventral surface. Okay, fine. It anyway doesn't change the prognosis. Okay. So next question, again, expected question, one from this sutures topic, always there. In my grand tests, I had told you one definite question from sutures will be there in INICET. That is their favorite topic. So this time also very simple, straightforward question. Which of the following is a non-absorbable suture? They had asked. Polyglactin, you know, polyglactin is Vicryl. Okay, polyglactin is Vicryl. It gets absorbed almost in 90 days. Okay. This is PDS, 180 days. Okay. Polyglycaperon is monocryl. That's also delayed absorbable. Okay. And polyester. Polyester is ethibond. It is non-absorbable. Correct? Very good. All of you have got right. Very good. Kushbu, Vishnu, Divakar. See, this is a class screenshot from the class notes. If you want to see exact discussion, we had done all the type of suture classifications we had discussed: natural versus synthetic, braided versus twisted, monofilament versus multifilament, coated, uncoated, absorbable, delayed absorbable, non-absorbable. In that, absorbable were catgut within 7 days, polyglactin 3 months. Okay, delayed absorbable PDS 180 days, non-absorbable were silk, polyamide, which is nylon, and also polypropylene, which is proline, and polyester. Okay, here we have discussed poly. And one more, another chart also, if you want to see. See, these are the class notes. Class notes. In that, absorbable was non-absorbable. We had a big chart. In that also, see, polyester in the non-absorbable category, it is there. Okay, so all the 4 questions directly from the class notes, and we had stressed so much on these particular topics. Only one thing which I didn't get is trauma. I thought for INICET people, trauma is their favorite, and from surgery, that's the most important topic as well. But I could not find any trauma topics in the questions. But all the 4 questions, whatever we discussed, were very straightforward, simple, knowledge based, and my students would have definitely got this right, because we had had so many practice MCQs in the after the classes. And 5th question, although this is not related to general surgery, it was included under me. If other faculties have discussed this, it's okay, or else I just want to discuss with you, although it's not my topic. 45-year-old female presented with a 2 centimeter ulcer in the hard palate, showing dark necrotic tissue. This is important here. Dark necrotic tissue, blackish at the base. This is consistent with. Okay. So any answers for this? Necrotizing ciliometaplasia, squamous cell carcinoma, mucoepidermal carcinoma, mucormycosis. Any answers? You're all answering it as A. Okay. Maybe, yeah, you maybe because I'm not a subject expert of this, but I feel the answer should be mucormycosis. Mucormycosis, because black, it's a dark necrotic tissue they are telling. Okay, so dark is black. Black is usually necrosis because of usually this mucormycosis has got the propensity to involve the palate and paranasal sinuses, etc. Very aggressive. Okay, and it has got a blackish tissue because of it involves the vessels. So there is ischemia and so causes blackish this thing. Whereas necrotizing silometaplasia also causes necrosis and ulcer, but not very blackish, very dark. See, can you see? The first image is and it's a benign thing and it's a self-limiting thing. It's a benign and self-limiting thing with necrotizing silometaplasia. See, as you see in the image 1, this is necrotizing silometaplasia and SCC, mucormycosis, not there in option. Okay, then what was there? I don't know. This question was given to me by the team. I'm trying to discuss, but again, I'm not this. What was there? Then what was the option? Other option? What was another option? Okay, SCC. Okay, we'll try to see one by one. Okay, so SCC can't be the answer because it will ulceroproliferative lesion like this. It can also have a necrotic base, but can't have a dark necrotic tissue at the base like this. Okay, how they mentioned. Can't have just ulcer. It's always a ulceroproliferative lesion. Even a mucoepidermal tumor like this, it's a proliferative lesion, not just an ulcer. Okay, whereas see, mucormycosis can have a very black, dark, base ulcer like this. Okay. Okay, I marked A. Okay, then let's hope that A is the answer. If mucormycosis is not there in the option, then it could be A. Okay. If mucormycosis is not there in the option, then another thing among all three, which can have a ulcer in the base of the palate, would be necrotizing silometaplasia. Okay, you may be right. I don't know. Anything from the surgery you could recollect? Somebody was asking from trauma. She wanted to ask me a doubt. Please ask. I'll be more than happy to answer some trauma questions. Samima, sir, can I ask a doubt in trauma? Please ask. I'll add to the questions if any other questions are there. Okay, anything you want to add? Fifth question. Question, please. Is it possible to ask a doubt? Yeah, definitely you can ask me doubts. Any doubts, not just trauma. Any general surgery related doubts you can ask me. I'm very sad that only 4 questions, but if you could recollect more, then I'll be happy. But I'm happy that all the 4 were very easy, straightforward, and directly from the class notes, and I'm very sure you all could answer them. Dr. Sir, question was about road traffic accident, severe maxillofacial trauma. According to surgery, Divakar, nice man. You will definitely get selected, not just surgery. Among all subjects, also you'll definitely get an answer, rank this time. Be hopeful. Okay, but it was discussed in oral surgery. Okay. Ma'am gave the answer, orotracheal intubation. Okay, fine. Yeah, maxillofacial, madam discussed. And yeah, anything, a question could be which is not done. Okay, maxillofacial injury, you don't do orotracheal intubation, something like that. But in the class are told, na? Workout filled with blood in that question. Okay. Emergency cricothyroidum should be done. Yeah, Samima is right. I also think the same. Anyway, I don't know what madam has discussed. I'll just get back to you in the Telegram group after discussing with madam what was the question and what she has told you. Okay. Anything else? Anything else, please? Please. 2 questions from trauma at least, or anything, any other topic. Okay, now I don't know what is the question exactly. So I'll get back to you after discussing madam with madam and getting to know what exactly the question. facial swelling, bilateral mandible fracture. Yeah, in such cases, in usually any mid phrase, correct. We avoid orotracheal or nasotracheal intubations. Okay, we try to go for lower down because it may cause further injury to the vessels. There can cause more bleeding. Okay, we go into what they were. If the cricothyroidum was the option, that is the correct answer. Question 5. No, no other questions, Anurag. Only 4 questions from surgery. Only 4 questions we could recollect. And if you could tell us any other, then we'll be more than happy to discuss them. I'm very sad. Anything else, Poonam? So please give a hands up if surgery was easy. If not, give a thumbs down. If you could not attempt them, or if you could not answer well with ease, so give a thumbs down. Okay, no anesthesia questions also. Okay, that's sad. No anesthesia question, no surgery questions. Okay, anyway then, we'll move on to the next session. I think faculty is already waiting. What was the answer to last question, sir? One GA question was there. Okay. So tension pneumothorax was there. Okay, please recollect them. Tension pneumothorax, hemorrhage question was there. Okay. Please, can you please, Pooja, can you please tell me what was the question then? This is expected. One from tension pneumothorax is expected in trauma. And yeah, hemorrhage classification could be expected, Shamima. You're right. One question definitely expected from hemorrhagic shock or something like that. Please try to recollect. Yeah, see, we are Samima is right. See, from that chart, how many times I told you in the class, from that hemorrhagic classification chart, one definite question will be there. And I think that was there. Shivam is telling, yes, sir, tension pneumothorax was there. Great. Shifting of trachea, suggestive of tension pneumothorax. Simple, straightforward. Anything else? Patient lost 700 ml. Like, okay, what was which class? 700 ml blood loss, which class? Right? That was the question. Class 1, class 2, class 3, class 4. Dyspnea, hyperresonant. Yeah, hyperresonant on percussion is pneumothorax. Okay, any hyperresonance on percussion is pneumothorax. And if the tracheal shift was there, that is tension pneumothorax. Okay. Okay, Rajesh sir has discussed. Okay. Yeah, less than 700 ml is class 1. Correct, Gunjan. Correct. Anything else? Patient management, which option is not correct? Okay. Patient loss 700 ml blood. Management, which option is not correct? Okay, the answer was no need of full blood. Yes, not required. That's correct. That also we have discussed. If you want to see for which way this thing is required. Okay. See, this is the exact chart. This is exact what you see. Need for blood, the last line. Okay. The answer. The answer was no need of full blood transfusion for that question. Correct. See, this can you see here? My class notes. need for blood in that chart. The last line was need for blood. For class 1, less than 750 ml, monitor, only monitor, no need of blood transfusion. In the class 2, possibly required, not definitely. In the class 3, definitely blood transfusion is required. And class 4, massive blood transfusion is required. Okay, this was it, right? Anurag, I'm really not sure about that question. Okay, it was just given to me by the team, but I'm not a subject expert of this hard palate. This whatever the ulcers were given. If you can tell me the questions are correct, and most of them telling mucormycosis is not there in the options. Then what was there? The fourth options. I feel then A only the if not mucormycosis, then A is the right answer here. Option A, urine output more than 30 ml. Option B, whole blood should be replaced. No, no. The other two options were not able to recall. Okay, that's okay, Samim. Now you got it. No, I showed you this thing chart. This should be something from this only, this particular chart only. Okay. This was asked. Okay, fine. Anything else you want to discuss or recollect? Question from creative form. What is creative form? Mucoepidermoid, usually it's a proliferative. Any tumor, it's a proliferative lesion. See, this is a mucoepidermoid. Does it look like a ulcer to you or ulcer or proliferative lesion to you? Okay, so it can't be mucoepidermoid can't be just like this with ulcer with a black base like this. Okay, chalo. If nothing else, we'll creative form questions. I'm not sure, Anurag, what you're asking. There's nothing called creative form in surgery. I think Kunal sir is already waiting to discuss the more interesting things. Sir, if you're ready, I'll wind up. Kunal sir, are you there? Thank you. Thank you so much then. Okay. Thank you so much. They wish to give some correct, correct. Sir, please confirm trauma question. Sure. 2 centimeter pellet also showing creatiform appearance was the question. Okay. How many questions is from estimated? Thank you. Okay, fine, Samima. Okay. Thank you so much. Thank you, everyone. Okay. If you could recollect any other questions, please post it in Telegram group. We'll try to discuss them as well. Okay. Thank you. Thank you, everyone.
All right. Good evening, students. Good evening, everyone. How was the exam yesterday? Specifically about orthodontics, because so far I've got mixed reviews about the entire paper as a whole. But specifically, I'm talking about orthodontics. What do you think? How was the paper? Please let me know in the chat box in the comment section below. Please let me know in the comment section, guys. Because I have got my own inputs. I want your inputs as well. One second. Where is the comment section? I don't know where is the comment section here. Just a second. Okay. All right. So as I was saying, it was a mixed question. It was a mixed review from my students, from my students in the college where I teach as an associate professor right now. So as I can see, I think 3 questions were asked out of aligners. One question was overlapping with pedo, which was based on space maintainers. So I'll also be discussing that question also, and I think it has already been discussed by the pedo faculty. If you want, I can skip that also. It's your call. I have that question in this PPT for you ready. So if you want, I need to skip that, I can do that also. Right? So let's start with the very first question. The question was, which of the following is meant by the term staging in terms of clear aligner treatment? Now, one more thing I would like to stress here is that almost all the questions whichever have been asked in the exam yesterday, we have covered each and every topic in the live classes, in the regular classes, in the discussions, in the recordings, everything. I think there was only one question which I want to emphasize, which maybe we have talked about it, but I think I have not stressed much upon that particular topic in the discussion. So we'll be doing that as well. But for your information, for everybody's point of view, I want to emphasize that whatever questions were asked yesterday, almost each and every question have already been covered by me in the previous discussions. All right. The first option, the magnitude and sequence of tooth movements with each aligner. Arch formed before starting the treatment. Number of aligners delivered to the patient in a single appointment and type of attachment used on the teeth. Now, what do you think should be the answer? Please let me know in the comment section. So the term staging, as you can recall from your own common sense, staging means aligners are always delivered in certain stages to the patient. Not a single aligner can do the treatment, right? It's not possible for a single aligner to complete the treatment from start to finish. So we have to divide the treatment into different stages, into different groups. And then we deliver the aligners to the patient in those particular sequences. So by that, you might think option C might be correct, but it's not. Staging actually means, as I said, we are dividing the total tooth movement into certain stages, into certain step by step. So that's why option A, that is magnitude and sequence of tooth movements with each aligner, will be the right answer. As I was saying, we have covered almost everything in the recordings. If you have studied the notes properly, I have mentioned the term staging here, staging in virtual orthodontic treatment simulation on ClinCheck software. I've also shown few of my own cases, my personal cases, which I have treated in my clinic, in consultations, in outstation consultations, in the college, everything. So what I'm emphasizing here is that we have already discussed about staging in clear aligner treatment, right? So option A will be the correct answer for this question. Next, another question from clear aligner treatment. Clear aligner shows most predictable expansion in which region? So this is what I was talking about. I have not talked about expansion per se when I was talking about aligner treatment. So this is, maybe you can say that this was a small bouncer. If you have read about aligner treatment properly, maybe you would have been able to answer it properly. So options are incisor region, canine and premolar region, molar region, and gingival area. Now let's start eliminating the options. Gingival area doesn't make any sense. It doesn't make any sense. Why? Because the aligners hold the teeth. They don't hold the gingiva. So we cannot achieve expansion in the gingival area. So as simple as that. So we can eliminate gingival area. Now molar region. We cannot achieve predictable, satisfactory expansion in the molar region. Why? Because molar tooth is made up of 2 to 3 roots, maybe 4 roots sometimes. So we have got a lot of anchorage in that area. It's almost very difficult to expand the tooth, expand the molars by using fixed appliances, let alone by orthodontic treatment by aligners only. So we will not be able to achieve predictable expansion in the molar region because of anchorage and cortical bone support, both on the lingual aspect as well as on the buccal aspect, right? Incisor region, again, not a correct answer. Why? Because incisor, let's talk about low incisor. So incisors are supported by a very, very thin plate of buccal cortical plate. So any attempt to expand in that area might lead to development of dehiscence or fenestration. Might lead to development of dehiscence or fenestration. So that we don't want. We are, maybe in that case, we might be iatrogenically making the tooth periodontally compromised, right? So we cannot achieve predictable expansion in the incisor region as well. What is left? We can go for predictable expansion only in the canine and premolar region, because these teeth are having only one root. These teeth are having only one root, number one. Number two, the cortical bone support is not that much as it is present in the molar area. And it is more dynamically stable also in the long run. So that's why option B will be the correct answer. Let's. Another question from aligners. This also we have discussed. Least predictable tooth movement with clear aligners is. Least predictable tooth movement with clear aligners is. So I want to emphasize that we have talked about this as well. It is there in the notes video on page number 474. So I have categorized the different types of tooth movement into different categories: highly predictable ones, moderately predictable ones, and less predictable ones. Now, if you look closely, what are the type of tooth movement which are not very predictable in terms of aligner treatment? We have severe rotations of premolars and lower canines. We have extrusion, but without retraction. So extrusion is one of the most unpredictable treatment by clear aligner treatment. I'll tell you the reason why. Next is mesial movement of posterity, that is premolar extraction, short clinical crowns, and less mature teenagers. So whenever we are encountered with these patients who do not have properly erupted teeth and who have short clinical crowns, maybe in that case we have to go for crown lengthening procedures, or we might have to wait for the teeth to erupt properly whenever the patient who is standing in front of you might not be mature enough to hold the aligners in place, right? So extrusion is one of the less predictable tooth movements done by aligners. Why? Because, so these are the incisor. I'll take an example of low incisor. And this is how the aligners fit over it. So there is very, very less gap between the incisor surface of the tooth and the inner surface of the aligner. That thickness, aligners hold the teeth properly. They snugly fit onto the teeth. All the aligners snugly fit onto the teeth. So there is a circumferential, all I can say that the aligners are holding the teeth in all the three planes. from the buccal aspect, from the mesial aspect, as well as from the occlusal aspect, right? So once the liners are holding the teeth from the occlusal oblique incisal aspect, so we do not have that free space for the tooth to erupt into that. So that's why the least predictable tooth movement with clear aligners will be extrusion tooth movement. Got it? Right. So Shivam has said B. No, bache, it's extrusion actually. Intrusion is a predictable tooth movement, but extrusion is not. Right? All right. Next question. Staley and Kerber's model analysis is a modified form of which model analysis? Again, we have talked about this particular analysis in the chapter on model analysis earlier. When if you have watched my recorded and live lectures earlier. So options are Tanaka and Johnson's analysis, Moyer's analysis, total space analysis, and Hickson and Hohlfather's analysis. Now, again, this is the screenshot of the notes what you already have, which you have already read about earlier. So I have talked about Staley and Kerber's analysis. I have included that graph, that predictability chart and graph as well. It's right there in front of your screens. And I have particularly mentioned here that Staley and Kerber's revised the Hickson and Hohlfather prediction with measurements obtained from persons who participated in the lower facial growth study. So Hickson and Hohlfather was an older version. The modification done by Staley and Kerber was that they have added this graph, this predictability chart. Predictability chart, it's called. So that's the modification they have done to the old version of Hickson and Hohlfather, right? That's why option D will be the correct answer. This also we have talked about. It's there in your notes. All right. Next, which of the following appliances can be classified as myodynamic appliance? Again, we have talked about this earlier in the chapter on myofunctional appliances. That myofunctional appliances chapter is a very, very important one. I particularly mentioned this topic, this chapter as an important one. I flagged it and I have stressed upon repeatedly in the live discussions that you have to make sure that you read this chapter properly, because I have seen multiple questions being taken directly or indirectly as application-based question from that particular chapter. So here, that's why we are here. Options are Harvol's appliance, twin block, Bionator, or Frankel. Now let's take a look at the screenshot of the notes, what you already have. So I have classified myofunctional appliances. I have written about Profit's classification, which are further classified into tooth-borne, passive, tooth-borne, active, and tissue-borne. Then I have talked about Graeber's classification, which have further classified myofunctional appliances into group 1, group 2, and group 3. Then based on nature of removability, we have removable functional appliances, we have fixed functional appliances. And finally, based on the way the muscle is used, you can see here, one is myotonic appliance, one is myodynamic appliance, right? So I've talked about myotonic appliances, I've talked about myodynamic appliances in the live and recorded lectures earlier, along with examples. So myotonic appliances, examples are activator and Bionator. And myodynamic appliances, what are those actually? They rely on the muscle movements or dynamic properties of the muscle, right? So they are not particularly relying on forward positioning of the mandible as it is done for activator, twin block, Bionator, right? So myodynamic appliances, the appliances are designed in such a way which will harness the total kinetic energy, kinetic potential energy of the musculature of the face, the stomatognathing system, and redirect them into the condyle TMJ area, right? So that's how the condyle is going to grow, and that's how the mandible will come forward. But there is no need for the mandible to be put forward. That is called myodynamic appliances. Example is Wimler appliance, and we have one more example, what has been asked in the question, Harvol's appliance. So we have talked about myodynamic appliances in the lectures earlier. So correct answer will be Hard-Wald's appliance, right? Next. Now this is a controversial question. Why? I'll tell you. First requirement in cervical headgear is, now at the first instance it might look like very simple, but it's not. It's not simple. I'll tell you. Options are 50 to 75 grams per side. That is way too less for an orthopedic appliance. 150 to 200 gram per side. 250 to 300 gram per side, or 400 to 500 gram per side. Now, as I was saying, at the first instance, it might look that option D is the correct answer. It might look that the option D is the correct answer. But I will not choose option D. Rather, I will choose option C here. Because I have mentioned in the notes also, it's written here that 450 to 500 gram per side may be applied for orthopedic changes. This is written in the notes, but this figure is in general for orthopedic appliances. This figure is in general for orthopedic appliances, general force value. Why I tend to differ here is because in a cervical headgear, I'll draw the diagram. This is the molar, upper molar. This is the upper first molar. And the line of force for cervical headgear passes below the center of resistance of the molar and of the maxilla as well. So according to the laws of orthopedic appliances, whenever the line of force passes below the C-rest of the tooth or of the bone, there is a tendency for the tooth to move in a clockwise direction. That's called moment. There's a clockwise movement. Now, because the line of force is passing below, there is also a tendency for the tooth to erupt, to supra-erupt rather. So the tooth might become slightly distally tilted and slightly erupted as well. Understood? That blue colored outline is the position of the tooth after the treatment is done, whereas the violet color outline is of the tooth before starting the treatment, right? Now, why I would go for 250 to 300 gram per side? Because it's a cervical headgear and extrusion requires lesser forces as compared to distalization. So any forces passing below the C-rest will cause extrusion of the tooth. That may be desirable in some cases, that might be undesirable in certain cases as well. So case selection for putting a cervical headgear is very important. So anyways, that's a different thing altogether. We have talked about it as well earlier. Now, the forces in the range of 250 to 300 gram per side fall slightly below the orthopedic range and slightly above the orthodontic range. So we are wanting distalization of the tooth and we are wanting slight extrusion of the tooth. That's why cervical headgear was chosen as a treatment of choice by the treating orthodontist. We don't know the clinical scenario. It has not been given in the exam, but I can only assume that why cervical headgear was used might be because the patient might have deep bite. So we want maxillary teeth to slightly erupt, and because of wedging effect, we want the mandible to rotate downwards and backwards. Maybe that could have been the clinical scenario. Based on that assumption, I am giving option C as the correct answer. Okay, still I'm saying I might not be 100% correct. I will look into it even more. So I'll mark this question as a star mark. I'll mark this question as a star mark, right? Okay. All right. So let's go to the next question. Indefinite retention is required for all except midline diastema, severe rotation correction, maxillary expansion in cleft palate cases, or in deep bite. Again, this has already been discussed with you. It's there in the notes. If you have read about it, I have particularly given this in the form of a table. You can see here on the screen. So retention duration for different types of corrected malocclusion. That's the heading of the table, right? So first is self-retentive or retention plan is not required. We have crossbite in that. Then we have short-term retention or limited retention up to 3 to 6 months. Very, very small correction, very, very minor correction of the teeth might fall under this category. Medium-term retention, this is indicated where the supported tissue will take a longer time to adapt, and it might extend between 1 to 5 years, right? Examples could be class 1 non-extraction cases, class 1 and class 2 extraction cases, corrected deep overbite. Corrected deep overbite. This is what I want to emphasize. And permanent or semi-permanent retention. Examples could be cases treated by expansion, particularly in the mandibular arch, because I've talked about this many times. Any expansion done in the mandibular arch is not stable, both from the standpoint of physiology as well as biomechanically. We have talked about that earlier. I'm not going to repeat that again because we are less on time here. Next is generalized spacing with arch length axis, severe rotation, midline diastema in otherwise normal occlusion, and cleft palate cases. So these three options, severe rotation, midline diastema, cleft palate cases, is already there in the question. So midline diastema requires permanent retention, severe rotation requires permanent retention, maxillary expansion in cleft palate cases also require permanent retention. What doesn't require permanent retention is correction of deep bite. That falls under moderate retention. Right? Am I clear? Am I clear? All right. Raj is saying, yes, sir, you have included everything in his notes. Thank you, Raj, for the acknowledgement. So I am assuming you must have given your best shot yesterday. So let's wait for the results. All the best to you. All right. So next question. Most balanced orthodontic tooth movement is. Now, this is an indirect way of asking what we have studied in the chapter on biomechanics. Most balanced orthodontic tooth movement is tipping, intrusion, translation, or rotation, right? Now, before that, I want you to reflect on the concepts of loading diagram of PDL, what we have read about in the chapter on biomechanics of tooth movement. Concept of loading diagram, it is asked in an indirect way here. They are asking most balanced orthodontic tooth movement. So they are actually indirectly asking which of the tooth movement shows a uniform loading of the PDL, right? So you have the diagram in front of you. In case of tipping, this is uncontrolled tipping rather. This is uncontrolled tipping. There are only two areas of PDL which are under extreme stress. The shaded part here, the shaded part here, right? So this is the area that undergoes compression. So we have bone resorption accordingly, and the corresponding area of the bone of the PDL undergoes bone deposition. You know that already. We have discussed about that. Excuse me. Now, in case of translation, you will observe that there is a uniform area of compression of the PDL on one side. So we have a rectangular loading diagram. So this area of the PDL has undergone uniform compression, right? So the C-res, the root, the crown, everything means the entire tooth is moving in a single line. Otherwise, in other types of tooth movement, the root is moving in one direction, the crown is moving in one direction. But in this case, in translation or in case of bodily tooth movement, the entire tooth, the root, the crown, as well as the C-res passes, it moves in a straight line, right? Everything is going together. Whereas in case of intrusion, the loading diagram is concentrated only on the apex, where the complete force of the tooth, where the complete force of the orthodontic appliance is concentrated. And it is one of the most difficult tooth movements to achieve clinically. This also I've talked about in the lectures earlier, right? So this question was an indirect way of testing your knowledge about loading diagram. That's why I will choose translation as the correct answer here. Most balanced orthogonal tooth movement is translation. All right. Next, this also we have talked about earlier in the chapter on interceptive orthodontics. Crowding due to mesial migration of posterior teeth is called. Now you have seen many cases, you must have seen rather, I have seen already. So there are many patients, many students, many parents who bring their wards, who bring their children to me or to other orthodontists with the prime chief complaint that a particular tooth is not able to come out properly. So upon asking the history, whenever you come across such patient, you have to ask the history, no? So I asked them what was the age when the primary molar exfoliated. So I get different answers. Some parents say that it exfoliated on its own. Some parents say that it was decayed, so we had to get it extracted. But none of the parents ever said that we got a space maintainer done in the place of extraction of the tooth. So that's what I tried to explain them, the importance of having a space maintainer, rather timely intervention by using a space maintainer in the extracted space. Otherwise, the posterior teeth are going to come forward. This is the molar. This is suppose second molar, second primary molar. This is first primary molar. So I'll write it as M-1, sorry, M-2, M-1. And this is maxillary first molar, right? In case of premature exfoliation of suppose primary second molar, because of mesial migration of the teeth, because of something called anterior component of force, that's again a different physiological aspect of occlusion. We have talked about this as well. Anterior component of force and mesial migration. The molar, the maxillary first molar tends to drift mesially and encroach upon that space which was originally reserved for yet unerupted second premolar. Right. So once the molar gets anteriorly, the premolar doesn't get enough space to erupt properly. That's why it becomes crowded. It becomes either impacted or deflected, or it becomes palatally impacted, or it becomes palatally deflected. There are many permutation combination beyond that. So crowding due to mesial migration of posterior teeth is known as secondary crowding. It's known as secondary crowding. What is primary crowding? That also I've included in the notes. This is a chapter on interceptive orthodontics. Primary crowding I've talked about. This is hereditary and is due to Ashton discrepancy, which can be again classified into mild, moderate, or severe crowding. Then, excuse me, we have secondary crowding. It is functional in origin. It could be caused by lingoversion of mandibular incisors, brought about by pressure of a thumb, lip, or finger sucking habit, or the premature loss of a primary tooth. So this is what I was talking about. The premature loss of a primary tooth followed by mesial migration of the posterior tooth leads to development of secondary crowding. Am I clear, guys? So this you have in front of you. I have included in the notes. What is tertiary crowding? Tertiary crowding is a different terminology. So this is basically due to late mandibular growth. So whenever you have late mandibular growth, it could be due to many factors like growth hormone. Whenever the patient achieves proper growth, the soft tissue pressure on the mandible and on the lips, the musculature forces, the the forces due to erupting third molar wisdom tooth, all those reasons can lead to development of late incisor crowding specifically in the lower mandibular region. So that is called as tertiary crowding, and there's nothing called complex crowding. I have not heard the term complex crowding ever, right? So that is secondary crowding. Now you have an image-based question. Identify the condition by studying the images below. In the first figure, you have an edge-to-edge bite, whereas in the second figure, you can see the mandible has been protruded forward and the posteriors are in proper occlusion. So in most cases, in most scenario, this is a case of pseudo class 3. Class 3 in the making. And you already know, I have talked about the difference between pseudo class 3 and true class 3. Pseudo class 3 is mostly functional in origin and true class 3 is mostly skeletal in origin. So it is associated with functional interferences when the mandible moves from red position to occlusion, and there is a shift from class 1 to class 3 molar relationship as the mandible closes in centric occlusion. Right? So this is what the patient is. This is how the patient looks like in a pseudo class 3. Now, whenever you have functional interferences in the path of occlusion of the mandible has a tendency to shift forward. So it is appropriately termed as anterior shift. It is not termed as functional shift. Why? Because functional shift is associated with lateral movement of the mandible. Lateral movement of mandible due to occlusal interferences. So such cases require occlusal equilibration. You have to equilibrate the occlusal anatomy in some cases. You have to take a articulating paper, mark that point, whichever is articulating in a premature way, just grind it slightly, just smoothen it, and then that's it. In most cases, that's it. But in this case, this is how functional anterior shift happens. So the class 3 is in the making here. So it is the right time to intervene. It is the right time to intercept with the proper functional orthopedic appliances. All right. Ugly duckling stage is characterized by increased overjet, increased overbite, distal tipping of maxillary incisor leading to midline diastema, or retroclination of maxillary anteriors. This again you have talked about. You already know what is ugly duckling stage. It happens during second transitional period. It's also called median physiological diastema, also called broadband phenomena. Everything is synonymous to each other. And you know this is how it looks like. We have talked about this so many times earlier. It's a self-correcting anomaly. The path of eruption of maxillary canines is such that it pushes the apical excuse me, it pushes the apical ends of the lateral incisors mesially, and indirectly that mesial movement of the apical end of the incisors pushes against the same area of the central incisors. So all in all, what happens? The crowns move distally, opening up a space in the middle that is called midline physiological median diastema. Okay, so we have discussed about this in the recorded and live lectures multiple times. So what will be the correct answer? Can anyone tell me the correct answer? It should be option D, that is distal tipping of maxillary incisors leading to development of midline diastema. And as I said, this is a self-correcting anomaly. Right? This is what ugly duckling stage is. Now, this is a tricky question. Rotation along vertical axis is called. Now, they are talking about rotation of the jaw, not of the tooth. First of all, mind it. Rotation of jaws, that is what they are talking about, not of the tooth. Again, I have included this very concept in the notes. So there are three concepts: pitch, roll, and yaw. Pitch, roll, and yaw. Pitch means up-down movements of the maxilla or of the mandible in the vertical plane of space. Right? Roll is canting of occlusion. And yaw means lateral movement of the mandible in relation to the vertical axis. Right? Now let's take a look at the figure. So this is roll. Roll is right or left movement of the mandible along a vertical axis. Sorry. I'm sorry. Roll is occlusal canting. Roll is occlusal canting along a transverse axis. Right? Roll is along transverse axis. Yaw is right or left movement of the jaws along the vertical axis. This is along the vertical axis. Whereas pitch, pitch is along what? Anteroposterior axis. Right? So the question is asking about rotation of the jaws along vertical axis is called as, it's called as yaw. It is called as yaw. All right. So this is what I have talked about in the lectures. You can see these rotations are pitch viewed as up-down deviation around the anteroposterior axis, roll viewed as up-down deviation around the transverse axis, and yaw viewed as right-left deviation around the vertical axis. So this is important, and this is exactly what was asked in the question. Okay. Next, tooth fails to erupt due to physical obstruction is called. So whenever you come across any physical obstruction in the path of eruption of the tooth, what is that condition called? Is it ankylosed tooth, impacted tooth, unerupted tooth, or embedded tooth? Well, ankylosed tooth you already know. The cementum fuses directly with the bone. There is no intervening PDL. So we can eliminate this option. Impacted tooth, we'll come back to it. Unerupted tooth means whenever there is not enough forces to make the tooth erupt into the oral cavity. It could be physiologic, it could be pathologic, anything. And embedded tooth means whenever the tooth is submerged, maybe below the occlusal surface, below the occlusal table. So that is called embedded tooth. So whenever we have a physical obstruction in the path of eruption of the tooth, that condition is known as impaction. Most common impaction is maxillary canine. I'm talking about in terms of orthodontic treatment. This is not the sequence. So most common impaction, I'll write down the sequence also. It is mandibular wisdom teeth, mandibular third molars, followed by maxillary canines, followed by mandibular second premolars, right? And the rest. So this is the common sequence what we see normally in the clinics, in the clinical practice. So any failure to erupt due to physical obstruction is known as impacted tooth. Okay, I think this was, this is a pedo, this is overlapped with pedo. If this has already been done, do you want me to skip this question or do you want me to tell you the exact answer? Please let me know in the chat box, in the comment section. Okay, Raj is asking, are your notes enough for NEET? Well, notes are just a summary of the textbooks. You know, Raj, you have to read the textbooks properly. As I've been talking about earlier, I keep on sharing my own experiences. How did I prepare during my time? I cleared NEET exam in 2013 with an All India 46 rank in the open general category. So the strategy what I followed was, whenever I was not well versed with any topic, I used to write it down. I used to open up the content page of any subject, of any textbook. I used to study that first. I used to make a note that whichever topics I am well versed with or whichever topics I do not know anything about. So first I'm going to cover those topics which I don't know anything about. It will take time. It took time for me, but it was simply one subject versus other subjects, right? No offense to anyone, I was extremely poor in dental materials. I think dental materials faculty is not going to like this. So I was not good in dental materials. So I, out of the entire time which I used to study, I gave almost 1/3 time to a single topic, to a single subject, and 2/3 time to other subjects. So, so that's why, Raj, my notes are enough for NEET. Yes, they might be enough for NEET, but if you want to read about the chapters, if you want to read about the topics in depth, I will recommend you to go back to the textbooks, follow this approach or any approach, whichever you like. You have lots of mentors around you. You have your own teachers, your own friends, everything. But I'm just sharing with you my own experiences. How did I prepare for my own exam in 2013? Okay. Okay. So an 8 years old child presents with bilateral loss of lower primary molars. Which space maintainer will be indicated in this case? Lingual holding arch, distal shoe space maintainer, band and loop, or crown and loop. Maybe crown and loop might not be there in the options. So I did not have a proper recall. Maybe that's why we have included crown and loop in as one of the options. So again, I have discussed about fixed lingual arch in the notes. I have talked about the indications where there is bilateral loss of deciduous molars. A fixed lingual arch is most often satisfactory. Then I've also talked about how it is made, how is it clinically made, what are the modifications of that, along with the clinical pictures, right? So this highlighted line where there is bilateral loss of deciduous molar of fixed lingual arch is most often satisfactory. So that's exactly what the question is asking. There is a bilateral loss of lower primary molars. So what space maintainer will be required? I will go with lingual holding arch. Okay. All right. In which of the following clinical scenarios there is no need to extract lower incisor? This was also one of the options, and I will tell you my reason to choose one of them. 4 mm crowding, non-vital tooth, periodontally compromised tooth, or distal fanning of lower incisor. Now, question is asking there is no need to extract the lower incisor. In certain cases, we do need to extract lower incisor whenever the crowding is too much, or whenever the tooth is periodontally compromised, or whenever there is distal fanning of the lower incisor teeth, distal fanning of the lower anterior segment. So this is a sure shot indication. This is a sure shot indication. Left are only A and B. 4 mm crowding or a non-vital tooth. Now, some of you might argue with me, sir, why not non-vital tooth? Now, non-vital tooth can be treated it can be treated by a root canal treatment, right? So it is not a necessity to remove the non-vital tooth. We can treat it, we can crown it, we can put a bracket over it. So it might not be required to be extracted. However, in case of 4 mm crowding, 4 mm crowding is not much. First of all, it's very, very less in terms of clinics. So that crowding can be alleviated by means of slight dentoalveolar expansion. It can be done by interproximal enamel reduction also. IPR, that's called interproximal reduction, or some amount of space can be obtained by slight labial tipping of the teeth. Slight labial tipping of lower incisors. Right? So we don't need to extract the incisors in case of 4 mm crowding. So that's why I will go with option A, that is 4 mm crowding. So I will go with A above B. That is what I'm going to choose. Okay. So this again we have discussed in the notes. Maxillocentral incisor, maxillateral incisor, mandibular incisor, whenever we have severe crowding, whenever we have transposition of anterior teeth, whenever the tooth is severely periodontally compromised, right? So all these conditions, all these clinical conditions will indicate the orthodontist to remove one of the lower incisors, whichever he feels the safest and best to remove, right? Looking at the broader aspect of the treatment possibility, right? So I've included all the I've included indications for extraction of all the teeth, maxillocentral incisor, maxillateral incisor, mandibular incisors, canines, first premolars, second premolars, and of course the third molars also. It is there in the notes. Himanshu is asking me pulp stone question. But I think that is a part of endodontics. It doesn't come under orthodontics. So I think you should contact endodontics faculty for that. Well, this is the answer key for you guys. I hope I was able to solve your doubts. I was able to enlighten you. Maybe. I don't know. I want your feedback. So if you have any doubts, you know where to find me. You can ask your doubts on DBMCI MDS group on Facebook and Telegram. And needless to say, the next faculty is already waiting. Dr. Priyanka Deshmukh is already waiting in line. So I'll take your leave. All yours, Dr. Priyanka. Bye-bye. Good evening, students.
Hi, good evening to all. Am I visible and audible? If yes, please post it in chat box so that I'll know. Am I visible and audible? Okay. Okay, so welcome to INICET recall of OMR subject. Okay, so you people have done with most of the subjects. So let us now discuss OMR questions that was asked. Okay. Okay, first you guys tell me how were the OMR questions? Easy, moderate, or difficult? Easy, moderate, or difficult? Were they easy? Easy, okay. Easy peasy, okay. Good to know that. All right, chalo. So easy, so I want all your answers. Okay. So this session is not only for the students who already appeared for the exam, but those who will be giving exam next year. Okay, so they'll know which concepts to focus on, which topics to focus on. Okay, and so accordingly, we will be discussing the questions. So I'll be first writing down the most important topics, okay, from which the questions were asked in this exam. All right. First, syndromes. Okay, syndromes. In every INICET exam, they ask syndromes. Okay, sometimes easy syndrome, sometimes out of box syndrome. So in this exam, they had asked very easy syndrome. If you all have been through all the syndrome, or you know all the features, all the easy syndromes, then you would have marked it correct. Okay, so you will have to focus on syndromes, easy syndromes, moderate syndromes, and out of box syndrome. So you will be focusing on PYQs also and other syndromes also. Okay. Second topic that you'll have to focus on is a radiographic interpretation. So in radiographic interpretation, what is included? First, cyst, tumors, benign tumors, malignant tumors, bony lesions. Okay, so they'll be giving one radiograph and they'll ask the radiographic diagnosis. So you should know all the features radiographically of each conditions, or cyst, tumors, or any bony lesions. Correct. So radiographic interpretation was also one of the topic that was asked. Third, CBCT related. So I'll say advanced imaging related questions. Most commonly asked question in this topic, CBCT or CT, especially in INICET, is slice. Okay, they ask you sections. I'm sorry. Okay. So they ask you sections or slices of CBCT CT. This is a most favorite of INICET. Okay. So CBCT related questions, exposure, slices, or let's say anything related to diagnosis. Okay. Then fourth topic is related to exposure. So exposure from various radiographic examinations. So let's say starting from IOPA, OPG, cephalograms, then CBCT, CT. Okay, so how much exposure do we get after doing this radiographic examination? Okay, then next topic, oromucosal lesions. Oromucosal lesions. Correct. Oromucosal lesions may they mostly ask swellings, then red and white lesions, then ulcerative lesions. So all the questions related to oromucosal lesions you should be learning. Okay. So these were the important topics in this exam. Okay. So let us start with the first question. I want everybody to answer in the chat box. Okay. Let's say first question, which of the following syndromes is characterized by recurrent oral ulcers? Okay, very easy. We have discussed in our lectures also. Recurrent oral ulcers. Chalo, fatafat. Everybody answer. Recurrent oral ulcers is seen in which syndromes? So there are 4 to 5 syndromes in which we have discussed there are recurrent oral ulcers. Correct? So this is the screenshot from the notes. Okay, so we have discussed recurrent ulcers seen in Behçet's disease, Reiter's disease, PFA-PA, magic syndrome, and cyclic neutropenia. Correct? Very easy. Behcet syndrome mein, what do we see here? Recurrent genital ulcers, recurrent eye lesions, aphthous ulcers, skin lesions, and the pathology test is positive in Behcet's disease. All right. So, answer for this question, option A. Question number 1A. Correct. Everybody correct. Next, again, first 5 to 6 questions based on syndrome and very easy syndromes, you can easily answer those. So, patient presented with sparse hair, partial anodontia, lack of sweating, and deformed nails. And this shows, again, the condition they are asking in which they see all these features. Correct? So, if we look for the options, Page's disease, ectodermal dysplasia, Apert syndrome, and Down syndrome. Correct? Sparse hair, partial anodontia, lack of sweating. So these all are structures which are derived from what? Which are derived from ectoderm. Correct? Ectoderm. Ectoderm. Correct? So the this inherited condition which is there is ectodermal dysplasia. Ectodermal dysplasia, this is abnormal development of tissues derived from ectoderm, and all these features are most or characteristic features seen in ectodermal dysplasia. Correct? So that is hypotrichosis. The synonyms or other name for this: sparse hair, meaning hypotrichosis. Second one, anodontia or hypodontia. Anodontia or hypodontia, which is absence of teeth or missing teeth. Correct? Next is anhydrosis. Anhydrosis or hypohydrosis. So these three features are the important ones. Anhydrosis or hypohydrosis meaning absence of sweat glands. Correct? So we got our answer. Option number B is our answer for question number 2. This is also direct question. Next question. This is not a definitive finding in P-Robin syndrome. P-Robin syndrome also most commonly we have learnt it frequently. Correct? So you should know answer to this question. P-Robin mein which three features are the most important features seen? First, second, and third. P-Robin mein we see micrognathia, triad of micrognathia. Second one is glossoptosis. Glossoptosis and cleft palate. Correct? Micrognathia, glossoptosis, and cleft palate. These are three important features, and we have it in options A, B, C. These three features are seen. But with this, there is upper airway obstruction. Yes, this is also seen in P-Robin syndrome, but this is a secondary finding, or you can say secondary effect due to glossoptosis. What is glossoptosis? It is downward or backward displacement of tongue. Correct? Backward displacement of tongue. And due to backward displacement of tongue, what happens is patient will have a difficulty in breathing. So there is upper airway obstruction due to glossoptosis, but it is a secondary finding or secondary effect. Okay. Chalo. Option number D is our answer, not a finding in P-Robin syndrome. Okay. Moving on to question number 4. A 12 years old presented with multiple radiolucencies, bifid ribs, palmar plantar pitting, and calcification of falx cerebri. This is also we have discussed. Correct? Which syndrome shows all of these features? Which syndrome shows all of these features? It is Gorlin-Gold syndrome, or it is also called as nevoid basal cell carcinoma syndrome. Correct? Multiple ocases, odontogenic keratocysts. Okay, so all these features come under nevoid basal cell carcinoma syndrome. Option D is the correct answer here. Okay. All right. Chalo, moving on to question number 5. This is also most frequently asked. A 63 years old male shows pain and swelling in jaws. X-ray shows multiple punched out lesions. So we have, I don't know how many times we have discussed this multiple punched out lesions. Radiographic feature of multiple punched out lesions. Correct? And lab findings, additionally, they have given us Bence-Jones proteins. Bence-Jones proteins seen. Correct? So, this is from the notes. Multiple punched out lesions. Correct? Multiple punched out lesions. So, this is seen in multiple myeloma. This is seen in multiple myeloma. Option A is the correct answer. Directly multiple punched out lesions, you see, whenever you see, search for multiple myeloma. Additionally, they have given Bence-Jones proteins also. So it is a very correct answer for this question. Moving on to question number 6. Child shows following features. What is the diagnosis? This is also syndrome based, easy syndrome. Correct? Hyperelasticity of skin, hyperextensibility of joints, frequent easy bruising, and delayed wound healing. Abhi hyperelasticity and hyperextensibility. Correct? This all are features of connective tissue disorder. Connective tissue disorder. Correct? Now, what happens with this disorder or connective tissue disorder? There is a defects in collagen synthesis. Abhi collagen synthesis mein hi defects hai. That means you will see such a features: hyperelasticity, hyperextensibility, and easy bruising. Okay, easy bruising is due to fragile skin. Okay, due to defects in collagen synthesis. So, very easy. Option number A, Ehlers-Danlos syndrome. Correct? Oh. All right. Chalo. Next question. Okay. Now, this is what I have recalled or what I have got it from students. Okay, so some students told me there was a radio opacity surrounded by radiolucency. Okay, just the OPG image with a radio opacity surrounded by radiolucency. Correct? So, you guys tell me what was the exact features, and I'll be explaining you between difference, like between two options. Okay, if there were a radio opacity surrounded by radiolucency, there are chances of two correct answer here. Okay, but I need to know exact features. Okay, so sandalwood music's telling the same image. Okay, same image. Okay, so I'll be explaining you this based on the same image. All right, so there is a radio opacity, okay, and surrounded by little radiolucency. First of all, we will rule out other options. Okay, osteosarcoma may you see sun ray appearance. Okay, sun ray appearance, correct? Sun ray appearance, can you see sun ray appearance here? No. Osteomyelitis may you see onion skin appearance. Onion skin, and sometimes it shows moth-eaten appearance also. Okay. Then we have ossifying fibroma. Ossifying fibroma may you see this radio opacity, which is smooth surfaced, well defined, and expansive lesion. Correct? So if we rule out all these three options, we are remaining with first option, that is osteoid osteoma. Okay, this could be our answer because the features of osteoid osteoma is matching to this radiograph. Okay, so this is how osteoid osteoma appear radiographically. Okay, so most commonly this is found in femur and tibia. Femur and tibia. Okay, rarely in jaws. Rarely in jaws. Okay, but they are given jaws ka image, so we will take that in consideration. Now, the size of this osteoid osteoma is less than 1.5 centimeter. Is less than 1.5 centimeter. And if it occurs in jaws, it is seen in posterior mandible. Correct? So, it is less than 1.5 centimeter. Then, radiographically, how it appears is poorly defined central nodules surrounded by reactive bone. So you'll not be able to define this lesion. Okay, define this lesion. There will be a central nodules, like a central radio opacity, just like this image. There will be central radio opacity, and surrounded by is a sclerotic bone, reactive bone. Okay, reactive bone, and size will be less than 1.5 centimeter. Okay, so this is how it appears radiographically. All right, so we have it in the option osteoid osteoma. And some students told me there was this radio opacity and well-defined radio opacity. So if this is the case, if this image was asked, then your answer would have been ossifying fibroma. Ossifying fibroma. Can you see? Smooth surfaced expansive lesion, well-defined expansive lesion, and the size of this ossifying fibroma will always be greater than 2 centimeter. Okay, so accordingly, you have to differentiate between two lesions and answer the question. Okay, so based on this given image, I would go with option A as osteoid osteoma. All right. Chal, moving on to question number 7. Which of the following is clinical feature of nasopalatine cyst? So we have to select clinical features, combination of these options. First, anterior palatal swelling. B, bluish discoloration of incisive papilla. 3, discoloration of maxillary anteriors. And 4th, salty taste in mouth. Okay, now nasopalatine cyst, if we look clinically, it appears like this. There is a swelling. Okay, anterior palatal swelling is there. Incisive papilla, yes. Bluish discoloration is seen. Swelling is there. And sometimes salty taste is also there. Okay, salty taste in mouth is also there. So all these three features are there. But if we talk about discoloration of maxillary anterior, that means the tooth is non-vital. Okay, discolored tooth means tooth is non-vital, and that's how we differentiate between nasopalatine and radicular cyst. Okay, so if the tooth have been non-vital, then it would have been radicular cyst. But the discoloration, if it is there, then it would be radicular cyst. If discoloration is not there, it would be nasopalatine cyst. Okay, so discoloration is not there in nasopalatine. So option 1, 2, and 4 is correct, related to nasopalatine cyst. And option 4, you can say salty taste in mouth. It's sometimes patient feels salty taste in mouth, not in every case. Okay, not in every case. So we will go with option A because it consists of option 1 and 2. Okay, that feature 1 and 2. All the other options contains this third feature, which is not the feature seen in nasopalatine. So we will be going with option A. All right. This is how it appears radiographically. Okay. Chalo. Moving on to the next question. Very easy. Identify the type of radiograph. We have discussed in our class and in CBCT topic this exact slide. Correct. So this is the CBCT panoramic view. This is the CBCT panoramic view. And this all are cross sections of CBCT image. Correct? This is from notes. So if you have read it well, you would have answered this. CBCT panoramic view. Correct? Question number 8, option C is the correct answer here. Moving on to question number 9. Interproximal caries in primary molars is best seen in. Okay, whether it is primary or permanent tooth, interproximal caries you will best see in bite wing radiograph. Bite wing radiograph. Okay, this is the bite wing radiograph in which you see crowns of maxillary and mandibular teeth and the interproximal area. So interproximal caries also you will be able to see very clearly. Correct? So option C is the correct answer here. Chalo. Moving on to the next question. What exposure in microsieverts for lateral cephalogram? This also we have discussed. This is the notes of this is screenshot from notes, and we have studied about effective doses from different radiography examination. Here they are asking lateral cephalogram. So we will be taking this into consideration. That is 3 to 6 microsieverts is the exposure from lateral ceph. Okay, when you take lateral cephalogram. So 3 to 6 microsieverts. Here we don't have option as 3 to 6. We will be going with less than 10. We will be going with less than 10 as our correct answer. Okay. Moving on to the next question. Okay, a 3.5-year-old child shows swelling since birth. Now, this is the important point. This is the clue that we have. Since birth, present since birth means it is a congenital condition. It increases slowly and has sessile base attached to gingiva and it is firm in consistency. Okay, so congenital condition, only option that contains this word is congenital epulis. Okay, so what is congenital epulis? Basically, it is also called as congenital granular cell tumor. Okay, so it is present exclusively found in neonates. Exclusively found in neonates. Correct? Now, most common location of this congenital epulis is maxillary anterior ridge. Maxillary anterior ridge. Okay. Now, this congenital epulis is single firm, smooth surfaced, for sessile or sometimes pedunculated. Okay, so This is the description of congenital epulis and granular cell tumor. Why it is called as granular cell tumor? Because histopathologically, it contains round cells with granular eosinophilic cytoplasm. Okay, granular eosinophilic cytoplasm. Okay, histopathologically. So, congenital epulis is also called as congenital granular cell tumor. All right. So, this, if we talk about other options, pyogenic granuloma is not firm, it is vascular. Okay. So, it is soft. So, this rules out based on that. Fibroma is firm, but since they have mentioned congenital, present since birth, fibroma, the cause could be a trauma. Okay. And so we'll rule out this. Mucocele, the common location for it is not the anterior gingival region. So yeah, option D is the correct answer here. Okay. Uh, okay, so many of you are telling. Okay, so can you recall all the options so that we can discuss it? Can you recall all the options? Okay, got it. Neurofibroma tha. Or which were the other options? Or all options are wrong. Okay. So can you recall other options, correct options? Can somebody recall other options so that we can discuss it? Okay. Chalo. Okay, so I'll be discussing it with okay, so let's I'll confirm it with the more students later, and we'll be putting it in the group, Telegram group. Okay, so there is confusion, so we'll be discussing it later. Correct? Okay, so let's start with next question. A 25 years old female suffers from desquamative gingival lesions. What is the differential diagnosis? Okay, so desquamative gingivitis. Desquamative gingivitis is the only feature that is mentioned. Correct? Now, based on this, we'll have to give the diagnosis. So, A, lichen planus, cicatrial pemphigoid, epidermolysis bullosa, and erythroplakia. Okay, so there are two lesions or two conditions in which you see desquamative gingivitis. First is lichen planus, that too the erosive type of lichen planus. Erosive type of lichen planus, and then cicatrial pemphigoid. Here in these two conditions, you see desquamative gingivitis. Now we will have to select it between these two options. So they have mentioned only one lesion, one not lesion, feature. And the characteristic feature or hallmark of desquamative gingivitis is seen in cicatrial pemphigoid. Okay, so cicatricial pemphigoid can manifest as a desquamative gingivitis only. Okay, sometimes there is a feature of desquamative gingivitis. There are no other signs and symptoms seen, and that can happen in cicatricial pemphigoid. That is why we are giving priority to cicatricial pemphigoid. So B over A. We will select B over A. Okay, and this we have discussed in our classes. Okay, this is a screenshot from the notes. Most common oral manifestation of mucous membrane pemphigoid or cicatricial pemphigoid is desquamative gingivitis. All right, so this is the correct answer. Next, a patient present with swelling in maxilla. X-ray reveals unilocular radiolucency around impacted tooth. Okay, so they have given this features. First is maxilla, it is seen in maxilla. Then unilocular radiolucency around impacted tooth. Okay, and the histology reveals odontogenic epithelium arranged in duct-like structure along with eosinophilic matrix. What is the diagnosis? What is the diagnosis? Now, all these features and mostly this histopath feature of odontogenic epithelium arranged in duct-like structures with eosinophilic matrix is the feature you see in which tumor? Eosinophilic matrix, that is the amyloid material. Amyloid material. Okay, amyloid material. So this is the lesion or tumor that we had discussed. It is seen in anterior maxillary lesion. It is related to impacted tooth, correct? Radiographic feature is not mentioned, but radiographically it is seen as a pebbly calcifications around the impacted tooth, correct? Pebbly calcification, mixed radio-opaque radiolucent lesion, correct? So, and the hallmark, histopathological hallmark is you see duct-like structure along with eosinophilic matrix, which is amyloid material. Okay, so option D is the correct answer here. All right. Moving on to question number 14. A 45 years old female presented with 2 centimeter palatal ulcer showing dark necrotic tissue at the base. This is consistent with, okay, so among given options, these all are confusing options. So we will be ruling out the options. Okay, so necrotic tissue at the base, okay, and 2 centimeter palatal ulcer. 2 centimeter palatal ulcer, correct? Now, first option, necrotizing xylometaplasia. Yes, necrotizing xylometaplasia mein you see dark necrotic tissue at the base, correct? Next is squamous cell carcinoma. Squamous cell carcinoma, you will not see necrotic base, but sloughy base. Sloughy base, correct? And indurated margins, correct? So squamous cell carcinoma mein you see sloughy base with indurated margin, but margin is not mentioned. We will have to give diagnosis based on this necrotic tissue at the base, correct? So we will discuss this option C also. Mucoepidermoid carcinoma. Abhi mucoepidermoid carcinoma mein what you have, this is salivary gland carcinoma, correct? So here we have submucosal mass. Mucoepidermoid carcinoma mein you see submucosal mass, not a necrotic ulcer. Not a necrotic ulcer. Correct? Next is mucormycosis. Abhi mucormycosis mein yes, necrosis is there. There is a necrosis with rapid destruction of bone. rapid destruction of bone. Okay, it is there. But mucormycosis, it's seen in immunocompromised and diabetic patients. Correct? So if they would have mentioned anything related to immunocompromised patient or diabetic patient, then we would have marked mucormycosis as a correct answer. But there is no no feature such mentioned. So 45 years we will consider this patient as a normal patient, normal healthy patient. Okay. So considering this, we will be marking option A as the correct answer. Option A as the correct answer, which is necrotizing silometaplasia. Okay. Necrotizing silometaplasia, we all know that is self-limiting condition, benign self-limiting condition. Correct? And it heals within 6 to 8 weeks. Correct? It heals within 6 to 8 weeks. And what exactly happens in necrotizing silometaplasia? There is a ischemic necrosis. Ischemic necrosis, due to which there is a dark necrotic tissue at the base. Okay, so option A is the correct answer. Okay, so yeah, mucormycosis is not in the option. Okay, if it is not in the option, still we'll go with option A. If there is other option that you can tell me, then we can compare it. But even if we rule out mucormycosis, the answer still remains necrotizing silometaplasia. Okay? All right, sure. So we have completed with OMR questions. Okay, and anyone have got any doubt, you can post it in Telegram group. We can clear it there. Okay, and Dr. Garima ma'am is waiting. So we will start with PhD session after this. All right. Thank you so much, guys, and all the best for your results. Wish you all the best.
Evening, students. Very good evening. Garima ma'am is right here. Okay. So you seem to be waiting a lot. Is community, how was community? Could you answer questions, not answer questions, mixed response? Five interim game is over. Okay. I think, see, the strategy is that if there are bouncer questions, okay, which are like not known to anyone, so the way out is that I think it's very unlikely that the answer will be in B or D. So you need to mark A or C in that. Okay. So, all right, yeah, ma'am came. Why this wait? Very anxious about community. Hello, hello. Hello, Anju, Shivam, Komal. Hi. Okay. Good evening. Good evening, Glenn. Good evening. So shall we start with our discussion? How was community? How did you answer? जो आंसर किया उसमें कॉन्फिडेंस है? हेलो, हाय मोहित. स्टार्टिंग से कुछ नहीं होता, एंडिंग अच्छी होनी चाहिए. हाँ, that is true. Community was hero of INICT. Okay. Okay. So did you all came out as heroes? Real game changer. So could you answer? No confidence. Why? Why, Shivam? Anyways, so I think the questions which were typical bouncers, one or two questions were definitely much above the line. So I think that'll apply to all the students, you know. It won't be a deciding factor, but what's important is that the things that you knew, you answered them well. Okay. So I think, yeah. So I think let's start with that. And I'm hoping the result will come out amazing for you all. Okay. And okay, so let's start with the first question. The first question is the Iowa index is useful for the prognosis of. So you must have covered this in endodontics. Yes, the last whole section was of community. I heard the section 4 was completely filled with communities questions. I know. So this says that the Iowa, so you must have read about Iowa index, right? So Iowa is something which is, it is a diagnostic tool. Yeah, very good, Shivam. Okay. Iowa is, so did you answer this in exam? Okay. So Iowa is the diagnostic tool, okay, which is used in what? It is used in endodontics. And it is an index which is specially used, like it is specially used for diagnosis, okay, and specially used in case of a cracked tooth, okay. So this is the first question. Second is, what are the 5 A's of tobacco cessation? 1 second. Oh, okay. I think we are opening the 1 second. One second, wait. 1 Yes, yes, your sequence is right. Just that we have certain additions, some new figures in this PPT. So I was trying that. Okay. So this is, as you can see, that the 5 A's. What are the 5 A's of tobacco cessation? It is ask. Okay. What did I tell you about this? It is ask. First is ask the patient that how much are you using it? What is your tobacco consumption? Check for the signs. Is there presence of halitosis? Are there staining? Okay, so the first step is definitely ask. So here only we get the answer that the first step is ask. Okay. Second is advise the patient. The one who's not using, tell them to never use. And those who've quit the tobacco, congratulate them. Then assess. Assess is how ready a patient is to quit. What is his level of independence? That we do that. Okay. Yeah. I hope that happens, that you get selected due to whichever subject, but you should get selected. Okay. Himanshu, one more question on this topic. Yeah, Shivam, tell me, what was the question on this topic? Any other, you can type in the comment sections that in case you've missed any question. Okay. So the next is advise. Assess. That progesterone test is used to evaluate the level of dependence. Okay. So if a person is consuming tobacco just 5 minutes on getting up, okay, that is what you assess. If the patient is not ready to quit, that is where you use the 5 hours. Okay, 5 hours, not hours. Then we've read about 5 hours. Okay.
Then also assess that in this patient, what is the risk of relapse, okay? And then the next step is assist. How do you assess? Set a firm date, remove the tobacco products from the vicinity, avoid the places where it is available, manage the withdrawal symptoms, and then arrange for follow-up. So as it is, this was taught to you in your notes, okay? And also in your classes, also in your recorded classes, okay? So we covered the 5 A's as it is, okay? So I'm sure you would have answered this. Okay. Now the next question is screening time. So again, a very important topic. We would usually cover this topic in live classes, also give a lot of time to it because the MCQs used to come from this topic, right? So what is screening time? Now this exact thing was covered in your diagrams, in your screening notes, that this is the time between the first possible contact and the final critical diagnosis. Okay, so this is the time between the first possible contact and the final critical diagnosis is screening time. Okay, so basically screening time is something that this is the search for a disease which is not diagnosed. Okay, screening is the cases like we had studied in the iceberg phenomena. Okay, like this is the tip of the iceberg and this is the water. All right, so in the iceberg phenomena, like there might be underlying symptoms which are not visible. Okay, so basically this is screening, that the disease which is present but it is not recognized. Okay, that is called as screening time. Okay, Shivam, that is more of a survey topic, I would say. Okay, we have covered that question in this. Okay, so this is screening. Okay, so this is also covered in your notes very nicely. Okay, so again, now this question says that prosto wale. Okay, this is not the okay. So we had a question something like that, denture based cast. Okay, where all is this kind of waste discarded? Okay, now what, if you recall that there were many questions, okay, which were asked in INICT, or we had taken in our revision questions, that what kind of waste is disposed of in the yellow containers. Okay, so the kind of waste which is disposed of in the yellow containers is basically, they say, contaminated and to be incinerated. Okay, this is the kind of waste that we dispose of in yellow containers. Okay, this is, we had covered multiple times. Now if you see the notes, if you see the discussions that I had taken for you all, okay, yes, so basically the lab waste, because what your models, they are contaminated with saliva. All right, so this will be in yellow. However, I think the question would have been more specific. So in that case, if they mentioned something like, you know, the models, okay, unused cast, so that would be your gypsum products. Okay, so if it is just the gypsum products, those would be you know, general waste, so they would be in your black bags. So when they would be in your black bags, this would be disposed of in sanitary landfill. Okay, so what is sanitary landfill? Sanitary landfill is basically, it is not harmful, so we can easily put them in the waste bag. Okay, so this is something that you dispose of in the in case of a sanitary, like in a black bag, because even if it gets mixed with water or anything like that, so this is something that it is not harmful. Okay, yeah, many is, Sandrapan is saying so many questions. Yes, many questions from PhD this year, but some of them, of course, one or two at least were totally bouncers. Okay, I think even if somebody studies a lot, it is very, very difficult for anyone to cover that. So those we have to take with a pinch of salt. We have to ignore. But for most, if you've understood the concepts, I'm sure you would have, you know, performed, and I think you'll do well. Okay. So now, which is a factor that increases the incidence of disease but doesn't cause it? Okay, so the factor which is not related to the causation is basically your one second. Okay. So the factor which causes the disease, okay, like that is not what they're asking. Okay, this is a factor which will increase the incidence of disease, but it will not actually cause it. So that is a risk marker. Okay, what is a risk marker? Risk marker is called as an attribute. Okay, this is an attribute, characteristic, okay, or an exposure. Okay, so this is something that is associated. Okay, it is associated with an increased possibility. So because they are associated with the possibility of a disease, but it is not directly causing it. Okay, so these markers correlate with the outcome of interest. Okay, but they do not actually cause the disease. Okay, this is called as a risk marker. Now, what is a risk determinant? Risk determinant is basically, it can be modified. So if you intervene, okay, you can modify it. So you can reduce the possibility. So these are something which can be modified by intervention. So you can reduce the possibility of the disease. Okay. Now, what is risk factor? Risk factor is something wherein it is directly involved with the causation of disease. Okay. It is directly involved in causation of the disease. And this is an exposure that is significantly associated with the disease. Okay. The presence of which is significantly associated with causes of the disease. What is risk indicator? Why not risk indicator? Now, indicator, what do you understand by indicator? Indicator means that, where did the chat go? 1 second. Yeah. Okay, so indicator basically means that I got this one correct. Very good, Shivam. Okay. So basically, indicator means that how do you indicate? For example, high blood pressure is an indicator for cardiovascular disease. So this is a measure. Okay. By indicator, we mean that this is a measure or factor that signals. Okay. It is indicating or signaling that there is an increase in likelihood of a particular outcome. Like it is signaling that the outcome could be cardiovascular disease. Understood? That is a risk indicator. So this, the risk factor and the risk group, we had covered this in which chapter of yours? I had taken a recording of association chapter. Okay, that is where we had covered this for you. Okay. Next question. Now, in a population, okay. No. The answer is risk marker. Sorry. The answer here is, the answer is risk marker. Okay. The next question, in a population, the DMFT, okay. DMFT that they have obtained is 8. Okay. Standard deviation is 3. Okay. Now, which of the following best describes the Carey status? Okay. Now, what is DMFT? DMFT is the index that measures dental caries. Okay, this is a key measure. Thank you, Ridesh. Are you our student, Ridesh? DBMCI student? Thank you for the compliment. Okay. Yeah, so basically, DMFT is a key measure of dental, for measuring dental caries. Okay, so DMFT 8, it indicates that there is a very high level of decay, right? DMFT 8 is very high. Okay, standard deviation of 3 means that there is variability in the data. Okay, like the data is varying. So that means that some individuals have very high decay and the distribution might not be uniform. But the people in the locality, they have very high level of caries. So your answer will be caries is high at the local area. Now, please understand one thing, that we have only recalled what was the option C was unequally distributed in the population. I think C, it is in the local area where we are taking the DMFT off. Of course, there is variation. Standard deviation is 5. Okay. So again, see, there will be the answer might vary due to the options and to the language, based on the question of the language we have recalled. Okay, so due to like whatever best we are trying to recall here, we are trying to take a discussion, okay, so that our concepts are better cleared and we have some clarity around it. Okay, so of course there could be changes, because sometimes the question can be accept, but we might have just remembered that question said which of the following is, because it's a very big question paper, so it happens. Okay, now a study was conducted with 3 groups to check the increase in salivary pH. The readings were done at 1 hour, 3 hours and 8 hours. Now I think there is some confusion in the 1 hour, 3 hour and 8 hours. This is something which is mixed of some question. I think for 5 the answer is risk marker. Okay, yeah. So I think here they are talking about the classical studies of dental caries. Okay, so we are discussing about the highest impact when the sugar source was removed, and all the options here that are mentioned are the groups which were given in the Whiphome study. Okay, so what was Whiphome study? Basically what they want to ask is that which group had the highest impact. Okay, so now basically your Whiphome study is something which was done by Gustafsson. Okay, on whom was it done? This was done on the mentally challenged individuals. Okay, they were given institutional diet which is nutritious. Okay, now these these groups in the Whiphome study, basically they had a control group. Okay, this control group had received low carbohydrate. Yeah, they had given chocolate also. I'm coming to that. So there was one control group who had received a low carb diet. Okay, and there was a second group which was a sucrose group. So they found that in the sucrose group there was no significant increase in caries. Now, although Whiphome is considered, this is another MCQ which is asked, that this is the most unethical study. Why is it called the most? I'm sorry, I'm digressing to another MCQ. Why is it called the most unethical study? Because it was all these things, all this intervention was given to the patients without their consent. So whenever a study is conducted, you have to take the consent of the individuals. Okay, and these were the patients who were mentally challenged. Without asking them, they were given so much of sugar exposure. Although the results that came out from the study were very useful in coming to the conclusion that, you know, which form of sugar is most harmful, whether sugar should be taken in a sticky form, non-sticky form, in between meals or with meals, all the very important conclusions were drawn. Okay, but it was unethical in nature. Okay, so there was a sucrose group and there is a bread group. So what is a bread group? Bread group mean they in the first 2 years they did not give, they had given sweet bread, there was no increase. Okay, then 350 grams of bread was given and that led to significant increase in caries. Okay, and the next is a chocolate group. Okay, so that in the chocolate group it was low in the first period, then there was a significant increase. Now why the answer would be caramel group here is because what they did in caramel group is that they gave 22 caramels. Okay, now in the 5 years, after 5 years, caramel was withdrawn. Okay, and that was replaced by fat. Now, when caramel was given, there was a significant increase in caries. And when they withdrew the caramel, okay, the result was fall in caries. Understood? So this is where they understood that when you remove the substrate, there is a decrease also. So in caramel group, it was very demarcated. Okay, and then there was a 8 toffee group. Okay, there was an 8 toffee group, and there was a 24 toffee group. Okay, so all these we have covered in our notes, in our recorded classes, in our online classes. Okay, all this we've covered. Okay, this is a picture from your notes. Okay, next question. Topical fluoride application of a child comes under. Okay, so the topical fluoride is, what is Pitt-Fisher sealant? Okay, Pitt, this is also another MCQ that I'm covering. Pitt-Fisher sealant is comes under primary level of prevention. Why primary level of prevention? Primary level of prevention is the action that you take before the occurrence of caries. Okay, that is called as primary level of prevention. Okay, in that there are two forms. Okay, there is health promotion, okay, and there is specific protection. So specific protection is, this is a screenshot from our own notes, our own lectures, my lectures, okay, in DBMCI. Okay, so basically specific protection is topical fluoride application. Okay, here we have written, this is also asked as an MCQ, Pitt and Fisher sealant. So specifically that you're protecting will come under specific protection in the levels of prevention. Okay, next question. In the ethical principles of public health research, which of the following is correct? Autonomy is respecting. So this is a multiple choice answer. So of course, I think in your INI now a lot of MCAs have also started being followed. Okay, so basically in ethical principle, this says that in the ethical in the ethical principle, this says that which of the following is correct? So autonomy is respecting the patient's choice. So A is correct. Okay, beneficence is do no harm. This is wrong. Why? Because beneficence is to do good. That is like you're benefiting the patient, right? So this is this guy, I told you all that this is beneficence, do good. So it is described from the word beneficence. Okay, non-maleficence is to do no harm. Okay, so the answer for this would be A. C. Confidentiality is you have to protect the patient's information. Deceptive is not at all allowed. This is also true. So the right answer would be A, C, and D. Understood? Okay. So these are the ethical principles that were taught to you all. This is a screenshot of the notes covered in your recorded classes, available in your main batch, currently in your main package. Okay. All right. All right. So the next is, so here we've given, right? To do good is beneficence. Understood? Now this question says that which of the following does not include school health program? So all the years I think were given here. Okay. Now what happened that school health services, okay, they in India they date back to 1909. Okay, so now the Bhore committee, which was in the year 1946, okay, they reported that in India the school health services were non-existent. So here the answer would be A, because at that time the school health programs were not existing. Now what is Tokyo? How all of this are an option? So sometimes you, even if you know the other three, you can rule out the one that you don't know. There are SS of the recorded lectures. Yes, Taruna, these are all these things that we've taken. Like, see, this is the time 0.28, 2.30. These are the screenshots, and this is your notes basically. Okay, so from the notes and the recorded lectures, everything. Okay, yeah. So basically your school health program. So what is the Tokyo Declaration? Okay, Tokyo Declaration was made on 19th July 2001. Okay, now what is Tokyo Declaration? When was this made? This was made at the first Asian conference. Okay, when was this made? First Asian conference on oral health promotion. Okay, this was made on oral health promotion for school children. So this was held when? In Tokyo. All right, so this is a part of the school health services. Okay, then there is Ayodhya Declaration. Okay, so this was made on January 5, 2005. Okay, this was at a WHO workshop. Okay, and what was that workshop on? It was on prevention and promotion of oral health. Okay, and this was through the schools held at Bangalore. Okay, this is one. Next is Next is what Bangalore we have read. Okay, yeah, what is Bangalore Declaration? So Bangalore Declaration, this was sorry. This that I covered was Bangalore Declaration, and Ayodhya was basically in Thailand. I made the wrong arrow. Yeah, this is Bangalore Declaration, and Ayodhya is something. One second, be more specific. Yeah, Ayodhya is a place in Thailand. Okay, so it was named after that place, and this was made on February 23, 2003. Okay, so what this declaration did is that they called upon national authorities in health and education to ensure that school health program was implemented. Understood? Okay. Now the next question says logistic regression is used when the dependent variable is of which type? Okay. So now basically in logistic regression, okay, the dependent variable that you have, all right, the dependent variable is typically binary in nature. Okay. What do you understand by binary? That it can take one of the two possible outcomes. Okay, like out of the two outcomes it will select one outcome. This happens in case of logistic regression. So this kind of variable is called as dichotomous variable. Okay, so the answer would be dichotomous. Dichotomous basically distinguishes between two groups, which is like one group says yes, one group says no. One group explains success, the other explains failure. So this makes it a suitable for logistic regression analysis. Okay, all right. Now the next question that says is that basically, yeah. So this says that a study was performed to assess the treatment outcomes. Okay. So there was one group which was receiving scaling route planing. Okay. And there was another group that was receiving tetracycline and plus scaling route planing. Okay. So which study would be used in this case? So now see, this is what we had explained in our notes. Whenever you are giving an intervention, you're giving the mouthwash, doing a technique. Okay, this is interventional study. So experimental study type is a RCT or an interventional study, wherein if you are giving an intervention, it will be a root canal study. Now in this case it could be two designs. Like even in the RCT, if we go more into detail, it could be something like a split mouth technique. So split mouth technique is what? Like, as you know, that in randomized control trial, you have a control group also. So one part of the mouth is where you would give the drug, other part would act as that person's mouth only would act as a control, like a comparison group. Okay, either you could do a split mouth technique, or if you're doing tetracycline as a crossover drug, okay, in that case, like you're giving tetracycline, so maybe you could use a crossover design, wherein if you're giving one group, so what is a crossover design? Okay, like these are two groups. One group you gave scaling route planing, and other group tetracycline plus scaling route planing. Now both the groups will be given both the treatments. So you give a washover period like for 10 days, 15 days, and then this group will be given tetracycline. This group will be just given scaling and route planing. Okay, so that is a crossover design. So the answer here would be D. Very good, Priya. Okay, coming to the next question. Which of the following indices, okay, is used to assess the severity of dental caries when no treatment is done, in case of when no treatment can be done? So when a treatment is done, what is the index? DMFT. Treatment done, so we've done the filling, so this can't be the answer for sure. Okay, we know about sick index also, severity. Okay, cast we know. Now of course sometimes you just have to rule out based on what you know. Okay, this SIC index we have read so many times in MCQs. Okay, we have read all about DMFT. Okay, so you could go with definitely PUFA. Okay, what is PUFA now? This is a question which pertains to the index that you are assessing the caries when no treatment is done. Okay, when no treatment is carried out, that is when you do the PUFA index. Okay, the full form for PUFA is basically P would stand for pulpal involvement. Okay, whenever there is involvement of the pulp. So basically, in all these cases, when no treatment is done, okay, or can be done for dental caries, why it could not be done? Either there was pulpal involvement, U stands for ulceration, either ulceration was there, third is either fistula was present, and fourth is when there was a presence of an abscess. So basically, this is an index which is used to evaluate the untreated dental caries and associated conditions. Taruna, which you want me to repeat the answer? The answer for this question will be PUFA, C. Okay, again, as I told you, sometimes in the vague questions, the answer could be hidden in A and C. Okay, the answer for this is D. Is it clear? Question number 12. Yeah. Question number 12, the answer is D. Randomized control trial. Okay. Clear, Taruna? Shall we move ahead? Okay. Now, the next question says that, coming to the 17th question, this says, oh, sorry, the 14th question. So there was a study conducting correlating phone usage, okay, to brain tumors. So like they were conducting a study to see that how many, like what was the usage of the phone, okay, as compared to basically in the occurrence of brain tumor. Okay, so the cases were from the hospital. The people with brain tumor were taken from the hospital and the controls were from outside. So what type of bias if the recollected information is not taken properly? Now, what do you understand by that recollected information? So basically, the information that was based on recalling. Okay, so it will be, so we don't have information recall bias as the answer. So automatically the answer would be information bias. Very good, Priya, Shivam, you've answered correctly. So the answer will be information bias, okay? Because the bias that occurred while collecting the information, so that your information that you brought about, which is used as the data, okay, that is jeopardized. Okay, that is affected because the person could not recall properly. Okay, so this is taught to you all in your notes. This is again a screenshot of your notes. Okay, this is information bias, where due to memory it's written, the bias that occurs is your information bias. Understood? Okay, got it? Next question. Case control study are particularly useful for which of the following purposes? Okay. Now this we had studied, that this is also something, see, I have marked in your notes also, taught you also. It is used in rare diseases. I've written MCQ also in the bracket. Okay. And this is the exact thing which is asked. That case control study is something which is useful in the study of rare diseases. Okay, so basically case control studies are used in the study of rare diseases. Okay, now the study which has the highest level of evidence, this is something discussed with you on multiple occasions. One of them, again, I think this was asked in INI May 24. Again, I had shared with you that how we had covered this in your Telegram queries also. Okay, and also basically covered so many times after your live classes. So when in the question, if the option is given clinical guidelines, then you will go with clinical guidelines. First comes clinical guidelines, then comes the meta-analysis and systematic review. Next comes the randomized control trial. So in this case, your answer will be meta-analysis. The study with the highest evidence will be meta-analysis. Understood? Okay. Yeah. Question 15 A B C D multiple choice. 15 में A B C D था. What were the other options? I don't know. See, this could be then not to generate the hypothesis, this would be to test. Maybe this must have been the language to test the hypothesis. Okay, it can't be incidence rate because incidence rate is calculated in cohort study. So this would be wrong in this case. Okay, and about the cause and effect, this is mainly basically this is testing the hypothesis. Okay, and of course effect to cause, this is what we see in this. Okay, so accordingly we could have marked. Okay, coming to the next question, which is Canberra index does not include. So now Canberra, I think they must have covered an endo for you all, because and also I think in one of your TND and or revision, I had covered the question which was asked related to Canberra. Incidence rate not there. So maybe they must have given prevalence in that as one of the options. Can you recall what all were the other options? You can always share. Okay. Yeah, so Canberra index does not include. So now what is Canberra index? First of all, Canberra index is it has several components for managing the risk in patients. Okay, what are the components of Canberra? This is like, these are all like fact based. So we had covered this in revision or test and discover TND of yours. Okay, so these are the things that you mug up towards the end. Okay, detail must be in endo. Okay, so this was definitely covered. Canberra includes clinical assessment, risk assessment, and risk stratification. Okay, these are the three components of Canberra. Okay, preventive measures is not a component of Canberra. Okay, so the answer here would be this. This is your answer. It does not include preventive measures. Okay. Coming to the next question, which is reliability is a measure of, again, something that I have taught you in your index also and on multiple occasions in your survey. Okay, we've read about kappa, the value of kappa measures. Okay, so what is reliability? I have always asked you that whom do you consider as most reliable? Okay, so the answer, whom do I say is the most reliable in cricket? Okay, so reliable is what? That when that person gets down on the field, it's not that he will either go for 0 or 100. Every time when you're in a crisis, if he lands down, he will make runs. Okay, so it would be Rahul Dravid or Mr. Dhoni. Okay, so reliable is something that on repeated intervals, okay, the same results are generated. Also, there are two types of reliability that we have studied, also very nicely explained in ideal requisites of index: intra-examiner and inter-examiner. So if I examine or if you examine, the result would be same. Okay, yes, it's there in app question bank too. Yes, very good, Vishnu. So basically, whether I measure or if you measure, the results are going to be same. If I measure in the morning or in the evening, still the result would turn out to be the same. That is called as reliability. So the answer would be consistency. Why it won't be simplicity? Simplicity is that the rules are very simple to carry out. Validity is what? You all know the definition of reliability. Validity. Okay, we all have mugged up. Validity is it measures what it is intended to measure. Okay, and accuracy. So the answer would be consistency of results. Okay. Now, which one shows maximum ROC curve? Okay, so now this is a diagram of an ROC curve. Okay, what is an ROC curve? The ROC curve is called as the receiver operating. Okay, it is called as the receiver operating characteristic curve. Okay. Now, this is something which is that illustrates the performer of a binary classifier model at varying threshold levels. Okay, so we are plotting true positive rate against the false positive rate. Okay, now the maximum area under the curve. Okay, under the curve indicates the best performance of a test. Okay, so the best performance of a test between positive and negative. Okay. So any test which has, we all know the ideal requisites of a test. Okay, I have always told you that whenever they ask you which is the ideal requisite of a screening test, although for any test it is not possible to be both highly specific as well as sensitive, So a test with high sensitivity and specificity will produce a REC curve that is resulting in more area under the curve. So the answer would be high sensitivity and high specificity. Okay. Coming to the next question, in forest plot, what does the square indicate? Okay. Now what is this? These are the diagrams of a forest plot. Okay. This is what a forest plot looks like. So they are asking what are these squares? Okay. What do they indicate? So as you can see, these are the various studies. Okay. So what is a systematic review and a meta-analysis is that you compile all the studies in that topic and you basically you compile all these studies, okay, and you classify them. Okay, so you categorize them based on that, whether what are the results of those studies, and then we analyze them. Okay, this is done in case of a meta-analysis. So what happens in meta-analysis is basically that in meta-analysis, this we make a forest plot. Okay, what is a forest plot? This is a graphical representation. Okay, this is a graphical representation which is used to display. We use this forest plot to display the results of, this is the result. Okay, like this is the outcome of multiple scientific studies. Okay, so these are like the multiple scientific studies and we are discussing their outcome. Okay, so this is particularly used एक बार मुझे सारे options भेजना, then we'll discuss. Okay, so multiple scientific studies, okay, particularly in meta-analysis, that allows for easy comparison. Okay, so now these are the multiple studies. Now the size, each study is represented by a dot. Okay, and the size of the square is representing the weight of the study. Okay, so the size of the square is like what weight the study carries in the overall analysis. So if the squares are large in size, it indicates the studies with more participants. Okay, now each square, okay, like you can see the size. Okay, so each square is basically indicating the magnitude, like what is the magnitude of the study and in what direction the treatment will be is estimated from each study. Okay, in what direction the treatment would go. Okay, so basically it would be in size of the square may also reflect the weight of the study in the overall analysis. So the answer here is that it represents the effect size. Okay, the square represents the effect size. Understood? Coming to the next question, Sullivan's index comes under. Okay, so here as you can see, this is a screenshot of the notes. We have covered it in the disability indicators. Okay, we had covered in concept of health. There are various indicators. There is an indicator called as the mortality indicator. Okay, that would be covering all the, we had covered under 5 proportional mortality, maternal mortality, infant mortality, all the death related rates. Okay, then there was a morbidity rate. Okay, this we had studied. This is like incidence and prevalence. Okay, these are morbidity. Then there is notification rate. Okay, then there is admission rate. Okay, then there is spell of sickness. Okay, so all of this will come in the morbidity rates. The next category would be basically your disability rate. Okay, disability rate would be, we have read Sullivan's index. Sullivan's index is the expectation of life which is free of disability. That is only the definition of Sullivan index. Okay, so these three are the disability rates. Okay, HALE, this is also asked as an MCQ at times. Health adjusted life expectancy. What is DALI? Disability adjusted life years. Okay, so the life which is left after free of disability is Sullivan's index. Understood? Now, the best test that measures the prevalence and severity of fluorosis, I would go with Dean's fluorosis index, because this is an index which is widely accepted. Okay, it is widely accepted. Okay, it is most accurate. All right, and it is based on the clinical appearance. Okay, so the best test that measures the prevalence and severity of fluorosis would be Dean's fluorosis index. Okay, which is the oldest periodontal index. So if we go according to the years, okay, so in that case, Russell's would be the oldest. All right, like the Russell index came into 1956. Periodontal disease index was 1959. CPITN was found in the year 1982. But I would go for CPI in this case, because this is a widely recognized. Okay, if we talk about the index which is widely recognized in periodontal diseases and which is utilized at a global level. So in that case, the answer would be CPI. Okay. Coming to the next question, what is the sequence of epidemiologic study? So this is something we've read in last question was Pendry fluorosis. What was the Pendry fluorosis index? Okay. So what is the sequence of epidemiologic study? We have read this multiple times. Okay. First is you will plan, okay, how to start the study, then do the data collection, okay, then disseminate the findings, and then do the analysis of the findings, okay, and then interpret the results. Okay, so the answer would be, I think, D, B. Okay, it is D, B, again A, analysis, okay, then analysis, and then interpret, and then disseminate the findings. Okay, this would be, I think, the answer. Okay, yeah, all right. Yeah, this ancient index question would have been the same, the oldest ancient index, which was used to index periodontal disease. I don't know what was the exact question, oldest periodontal index they are asking, or if they're asking ancient, then the answer should be Russell's. Okay, something like that. Okay. All right. So now this was the complete, I think, all right. The actual, this is not the image which was asked in the question. What was asked in the question was network plot. Okay, this image we've put because this is called as the bubble plot. Okay, so for you to demarcate. Now, they had asked a network plot. So what is network plot? This is like that, you know what the image was like, like something like this, and how the network like this, they are connecting. You've seen that image, right? So it is, I'm sorry, I forgot to put in this. So basically, network plot is that these are the visual representation of relationship between entities. Okay, and this is called as nodes. Okay, and it is like basically the connection is called as the edges. So this is, just remember it as the network plot. Okay, now the next is karyogram does not include. Okay, so we all know that karyogram has various factors, again taught in your notes. This is a screenshot of your class and your notes. Okay, karyogram, the chance is represented by the color green. Okay, this is chance. Okay, diet is basically represented by dark blue. Bacteria are represented by the color red. Susceptibility, light blue in color, that is susceptibility. Circumstances to avoid is yellow. Okay, again, in this, karyogram is a graphic representation of the factors affecting caries. Okay, so basically restoration or fillings is not included in karyogram. Okay, understood that? So restoration and fillings is not included in case of a karyogram. Okay, so basically these are the questions which were asked, and this is all about PhD. Okay, I hope you all feel a little satisfied and confident after watching this. Okay. All right. Okay. So thank you all so much.